every gentleman and lady gathered here. I thank you for coming and so early for the session. And we would start this Tapicon session with invoking God's blessing. We pray that the Almighty has given us abundant blessings, and He has given us the right time, the right person, the right opportunities, and the right place to go on with this eventful session. And I thank the Almighty for making this a great event.
We welcome you all to this knowledge tour on internal medicine, and we hope you all will have a great journey these 2 days, during which you will acquire critical knowledge which you can apply in your daily clinical practice. We start today's scientific session. To chair the session, I invite Dr. Kaveri Kannan, Dr. Madhiselvan sir, and Dr. Mukundan sir to chair the session.
And we'll start today's scientific session with Professor S. Arulraj guest lecture, for which I invite Dr. Anupam Prakash to deliver his lecture on glycemic variability and its impact on clinical practice. Over to the chairperson.
Good morning. We'll start with the first session. This Professor S. Arulraj guest lecture. The speaker is, I have great pleasure in inviting my friend, Dr. Anupam Prakash. He is the Director and Professor of Medicine and Head Department of Accident Emergency in Lady Hardinge Medical College and Associate Hospital, Delhi. He has got many publications in international and national, and he is the governing body member of JPA, and he was also the faculty council member of Indian College of Physicians at JPA. And he received many awards as listed in the biodata, and he is the president, Delhi Diabetic Forum. He is the president, Indian Society for Atherosclerosis Research, and he is the treasurer of JPA Delhi state chapter. With this introduction, I request Dr. Anupam Prakash to proceed his proceedings.
Well, thank you, Dr. Mohan.
So before the guest lecture, I invite Dr. Kaveri Kannan for the citation.
Good morning. Professor is Arulraj guest lecture. The lecturer is Dr. Anupam Prakash. Dr. S. Arulraj guest lecture has been instituted in honor of Professor S. Arulraj, who was former adjunct professor of medicine at the Tamil Nadu Dr. MGR Medical University. He is a honorary national professor as well as chief patron of the IMA CGP and chairman of the Commonwealth Medical Association. He is the recipient of the prestigious B.C. Roy Award. He continues his active medical practice in Tuticorin and has a special interest in critical care medicine and cardiology. The Association of Physicians of India, Tamil Nadu State Chapter, with great pleasure, is pleased to award the prestigious Dr. Arulraj guest lecture for the year 2022 to Dr. Anupam Prakash for his immense contribution to the field of internal medicine and cardiology on November 26, 2022 today. Dr. Anupam Prakash, MD, PD, CC, Hospital Management, PDCC, a lot of the qualifications. And he's a Director and Professor of Medicine, Department of Accident and Emergency at Lady Hardinge Medical College, Delhi. He is the president of Delhi Diabetic Forum between 2016-2022 member of Indian Society for Atherosclerosis Research 2019 to 2022, member of Governing Body of Association of Physicians of India 2019-2023, treasurer of Association of Physicians of India Delhi chapter 2019 to 2023. He is also member of Faculty Council of Indian College of Physicians, Association of Physicians of India 2015 to 2018. He is a fellow of Indian College of Physicians, American College of Physicians, and Indian Association of Clinical Medicine, and Royal College of Physicians, Edinburgh. Dr. Anubhav Prakash is the editor-in-chief of Indian Journal of Medical Specialties, which is indexed in Web of Science. He has served as associate editor in APA Textbook of Medicine for 10th, 11th, and the 12th edition. He was also the assistant editor of APA Textbook for the 9th edition. He has also had 285 publications in journals to his credit and written chapters in various books and authorized 8 books. He has delivered 191 lectures and 22 paper presentations. He is the principal investigator of 15 phase 3 international trials, guided 8 STS theses. He has received a DST award as a young researcher to meet Nobel laureates in Germany during 2003. He is the recipient of LHMC Oration 2016, Dr. G.S. Sainani Oration APA 2012, Srimati Pawan Kumari Jain Oration APA DSC 2008, S.K. Gupta Oration 2021, and B.B. Thakur Oration 2021.
Thank you, sir.
Well, a very good morning, and it has been my privilege to come here after a long time because of COVID and earlier some constraints. I had not been able to make to Tapicon physically, and I am indeed indebted to the organizers, to the people of Tamil Nadu who have so kindly and so open-heartedly welcomed me since yesterday and even today morning. Everybody has been so affable. So it is a privilege here. Once again, I say and thank you, the chairpersons, the organizers, and the esteemed delegates, and the secretary, Dr. Palaniappan, Dr. Chandrasekhar, and the chairman, sir, also. So I will be talking upon glycemic variability. I know it is a very common topic these days, but I have selected it for this guest lecture because I just wanted to highlight some points. And I will go through them. This is the post breakfast session, and obviously the glycemic variability is supposed to be high only. So that is how I will introduce glycemic variability. So once you have, in a normal individual also, you have excursions of blood glucose, and in a diabetic and otherwise it may be more of a problem. So we always understand that fasting hyperglycemia as well as postprandial hyperglycemia, these are the two things which always happen in a diabetic patient. And fasting hyperglycemia has always been a problem with us. And postprandial glycemia, which we correlate with macrovascular morbidity and mortality, which is not easy to pick up also because most of our patients would get a fasting done and not get a postprandial done, or even normal persons would not get the postprandial done or the post 2 hour 75-gram glucose value done, which is the ideal test that has to be done to see whether the patient has a postprandial glucose excursion and detect diabetes early. Now, this is in a non-diabetic cohort. You can see the risk of death as the blood sugar values are increasing. There is a correlation. So that is how actually fasting blood glucose variations, even in non-diabetic individuals, do have a correlation to the morbidity and mortality. Now, we all understand there are a number of studies, I will come to them a little later, so I'm not spending time here. But the diabetic patients, you can see overall stay 29% of the day in the hyperglycemic range. And similarly, those who are well controlled, they also have 57%. Now, obviously, the ADA has given target for time in range concept, which I will come to allude to a little later. So variations are a rule. Even normal persons have variations. Just like I said, we had, if you have a sumptuous breakfast, you will have some excursions, but they are within normal range. But as I showed, even within normal range, excursions can have problems. So it is important for us to pick up these variations. Now this slide I will just escape. I will go to the, yes, this is what actually I want to suggest, that if you have a stable blood glucose, then the oxidative stress is much less. Now, this is a relatively old article, but this still alludes to the fact that if you have acute glucose fluctuations, you have greater oxidative stress. And mind you, oxidative stress actually is considered to be at the core of all cardiovascular as well as diabetic complications. So, this is what is important. The more glucose fluctuations you have, the greater is the oxidative stress and the damage to the body. Now, this is just actually how it has evolved. When the senior persons in the audience and the chairpersons, they will recall that we used to harbor about 25 years back on urine sugar testing. But that could not detect that, yes, that would detect hyperglycemia, but that would not detect the glycemic variations. But yes, we had these glucose sticks and then the glucometers, and now glucometers are the standard of care, and self monitoring of glucose is the norm which is there. Now, blood sugar testing with self-monitoring of glucose, it is important, and still, despite the fact that we have ambulatory glucose profile available with us, this is the standard of care. And it is important to realize that this is actionable. You can perform it as a routine as well as in an emergency. So this remains the standard of care, and though it is painful, even if you make 10 pricks, it is less than sending the blood sample to the lab. So it is less painful. And yes, it is practical, easy to perform. You can do it bedside, and it is standardized and reliable. Now, most of these glucometers actually have values translated to the capillary or venous blood glucose. So that is the norm, and these are the cutoffs that we have. So this is important for us to realize that self-monitoring of plasma glucose is the standard. I am not going to the details. This was a document in International Diabetes Federation 2009. This whole document is on self-monitoring of blood glucose. So self-monitoring of plasma glucose, it is important that you should recommend it, but people have to have the knowledge, the skills and the willingness to do it. The patient has to be compliant, patient has to be motivated. And it is important, I will just spend a brief about it because this is what actually is available to us. You can advocate, you can make the patient aware, teach the patient, educate the patient, and also be able to take action upon it. So there are number of regimens that you do. This is a focused SMPG regimen or the focused self-monitoring of plasma glucose regimen. You can have a 5-point profile if you want your patient to have less pain or less pricks, and you can have a 7-point profile, which we all understand. But because of pain, because of compliance, because of even the cost, many of our patients are actually not able to afford these glucometer strips also, especially in a government hospital where I am working. So you can have these staggered SMPG regimens. So you can ask the patient to do a pre-post breakfast on Monday, maybe pre-post lunch on Tuesday, and pre-post dinner on Wednesday, or even a less low intensity SMPG regimen if the patient is not willing, maybe the patient is elderly, patient does not have the resources, you can stagger it further lower down. So obviously you understand the less number of readings you have, the less chances are to pick up the glycemic variations. But yes, this is the standard of care, and we should understand that we should impress upon our patients to have these SMPG as a tool, and as physicians also we should use it. Now, HbA1c is now used not only for monitoring but also as diagnostic tool also, and we have these point of source machines also now available with us, which have very good precision and accuracy. So you can see HbA1c has been incorporated a few years back also as a diagnostic tool, and the targets is less than 6.5 HbA1c. It gives you a average control over the last 3 months. So that is what is important, and that has what has been the criteria even in clinical trials for us. But it is important that today, if you want to see the control, you need a fasting or a 2-hour postprandial glucose. And that is what is important. So all these three criteria, the plasma glucose values and the HbA1c, both remain the standard of care for monitoring when you want these patients. The advantage with HbA1c now is if you are using the NGSP or IFCC standards, then you can translate into a EAG, which is an estimated average glucose. So the patient may not understand what this 5% is, but when you translate it to average blood glucose, then definitely the patient understands that A1C of 11 is 270 blood sugar, and when you say that your average blood sugar should be 100, 140, then he understands it is nearly double of what it is. So this is the advantage with HbA1c. I have already dwelt with this. I am not going. Now, this is what has come recently, and this is what actually gives you a good indicator of glycemic variability. So, this is an ambulatory glucose profile 24 hours a day. This device measures every 15 minutes there is a reading. There is a silicon filament which is actually embedded. I will go to that slide later, but I just want to show that all these 4 profiles, these are 24-hour, 14 days profile. These have an A1C of 7.6 to 7.7%. But you can understand the fluctuations here are minimal and the fluctuations here are so large. And yes, you have some sugar values which are low also. So that is what actually this device tells you. So there is an advantage to that. But yes, you have to understand that this is at the cost, some price, and obviously skills also which is required for you. So this ambulatory glucose profile gives you, these are the values per day values. So you will have 14 curves because there are 14 days this AGP device can be put, and you have these 5 values. So yes, these are the 5 lines which it gives finally. So this is the 10th percentile, this is the 90th percentile, this is the 25th, the 75th, and the average line, this red, is the average or the 50th percentile. So you understand that this is how the blood sugars varied around this axis throughout the last 14 days when this patient you get the result out. So just for clarity, so you have this and 50% plus minus, and this is 90% plus minus. So this is the range. That is how you see. I will show you some actual graphs also. So this is the small patch which is placed now, which has a chip inside and a silicon filament which is embedded in the interstitial fluid. And this is the sensor which will give you the reading. So this is, we just apply it at the back of arm, and we measure the blood sugar. You can measure it every 3 days, every 5 days also. So as is the time with the physician and the patient. So this is just the device before you load it. So this is actual presentation that I have for, initially we had placed, so this is a patient you can see. So this is the fluctuation which is the patient is having, and A1C is 6.1%. When your patient has an A1C of 6.1%, obviously the question will be, why are we actually getting an AGP done? So we are trying to see whether this patient has a good control and whether this patient is having any hypos, and whether we can fine tune her or his blood sugars still. So you can see this patient has glycemic excursions post dinner. This is 22, so 10 p.m. These are excursions. And there are some lows also during night and maybe during the late evening phase also. So I would just elaborate this. So this is the 14-day profile, which you can see there are some dips which are less than 70. So this is 70 milligram to 170 milligram. And so there are some highs also. So that is what you can do, is you can fine tune. So if we do not have this device, if you do not have, it is okay. We don't have also. I am also using it as a research purpose. Our patients don't buy it. But you can see 6.1 A1C is quite good. But if you want to see how much is the blood sugar level within average, it is still not right. So the time in target now, time in range is 70%. So this is the profile that you get. So red, means that there are high chances of hypoglycemia during this period. So this is the time which you actually need to intervene. So others you can see median glucose is okay. This is slightly moderate, high. So this again you need to actually take care of these patients. So these are values which are important. So, and this graph gives you something like this also. How much percent of time the patient was hypo, red is 4% and is hyper. So 15%, 32%. So day 2 it was 15%, day 3 32% of the time which was high, 15%, 28%. So you get a reading, these 2 pages, and if you want to see the actual readings, you get it like this also. A little more effort, you can translate the data into Excel and you can get the values absolutely. How long was the hypoglycemia or hyperglycemia if you want to intervene. This is another patient that we had, same time, but you can see how precise this is, and probably this is a normal person and not a diabetic person. So you can see that just I want to show that is the difference between a diabetic and a non-diabetic. So non-diabetics, what the God, the Almighty's blessings were invoked in the morning, but what the God has made, it is a very, very precise control that we have. So I'm not going to this. So ambulatory glucose profile, this is the last part of my talk, and how this profile actually translates into practice. So I have given you some live examples why we actually do it and how we can achieve a better control and reduce the glycemic variability. But why do we actually need to reduce this? So there is enough data now. So glycemic variability has a role to play in subclinical atherosclerosis as well as cardiovascular disease risk. So you can see the high carotid intima thickness was noted in patients who had increased glycemic variability. Further, the IMT decline also, it was associated with a reduced risk of myocardial infarction. So once you have a greater glycemic variability, you have greater subclinical atherosclerosis. Once you regress it, there are more chances it will also improve. Similarly, this you can see the measured by MAID, this is mean amplitude of glycemic exertion. This is one of the variables to assess glycemic variability. It can actually contribute to monocyte subsets and plaque vulnerability. So there is a link to subclinical atherosclerosis. Apart from that, obviously, we have glycemic variability, which is linked to cardiovascular disease. So this is about increased risk of renal disease. So there are increased not only renal disease, but macrovascular events also, ulceration, gangrene, cardiovascular disease. So high glycemic variability is associated with macrovascular disease and atherosclerotic endpoints. The advanced study also showed that HbA1c variability was positively associated with risk of macrovascular events. So this was before AGP was being used, ambulatory glucose profile. The Digludec trial also, the DEVOTE 2, not the DEVOTE cardiovascular event high risk study, the Digludec versus insulin glargine, DEVOTE 2 part, it also suggested high day-to-day fasting glycemic variability was associated with severe hypoglycemia as well as major adverse cardiovascular events. Similar to the flat sugar trial, now this was with GLP-1 receptor agonist, and you can see that those patients who had GLP-1 receptor agonist, they had significant reductions in glycemic variability. So how can we control? So there are a whole, this is again glycemic variability relation to acute coronary syndromes, and these are the drugs which have unequivocal proven to have benefit in reducing glycemic variability. So GLP-1 receptor agonists, SGLT2 inhibitors, DPP4 inhibitors, they reduce glycemic variability, and probably because their effect is not dependent upon insulin action. So the glycemic variability is reduced in patients who are on these oral drugs or parenteral subcutaneous GLP-1 receptor agonists, and that is the advantage. So presently today we have the tools to detect glycemic variability and also probably the armamentarium also to treat glycemic variability. Well, I think I will rest my voice with that. Thank you so much. Thank you.
You have covered all the parts of glycemic variability, importance of self-monitoring glucose, ambulatory glucose monitoring, and how to control the cardiac events. So thank you very much, sir, for your excellent lecture.
Thank you.
Yes, sir.
So wonderful stimulation, brain stimulation for all of us. It looks very casual, but it is a very, very important phenomena. both extremes are very bad. That is what the message is. So we have to train our diabetic patients, even our relatives, to avoid the swings or fluctuations in the blood glucose level. As Bharati says, காலை எழுந்தவுடன் படிப்பு, பின்பு கனிவு கொடுக்கும் நல்ல பாட்டு, மாலை மாலை முழுதும் விளையாட்டு என்று வழக்கப்படுத்தி கொள்ளு பாப்பா. So you have to train our patients not to go for any major fluctuations. So on practical question, we have seen a lot of hypertensive variabilities, hypertension variabilities, day-to-day variability, nighttime variability, weeks variability, months variability, lot of variabilities. For that, we have got one ideal drug, that is amlodipine. Still, it is the drug of choice for hypertensive variability. For this glycemic variability, any specific drug? You have given so many choices. Thank you.
Well, thank you, sir. It is a very difficult question to answer today because glycemic variability, the best possible estimate that we had till now was with SMBG. And we understand that, as I already showed, SMBG is not an easy tool to follow. It requires a good deal of motivation and a good deal of commitment from the physician, treating physician also, because the patient will come to you with 10, 20, 15 values, and then you have to understand and decipher what the patient had at that point of time which resulted in hyper or hypo. So the best thing is glycemic variability definitely should be addressed, but before that you actually need to have a good fasting and postprandial control, or a pre-meal or a post-meal control. So once we achieve all those controls, so then the next step would be glycemic variability. So for that, yes, these three drugs are the choice because we assume that the patient would already be on metformin. So you have SGLT2 inhibitors, you have GLP-1 receptor agonists, and also the DPP4 inhibitors. And right now today, sir, as you rightly said, the choice is driven by pre-existing ASCVD or atherosclerotic cardiovascular disease or existing cardiovascular disease. So it is not actually the glycemic variability. Our trials and our scenario is driven by hard endpoints. And we see for existing cardiovascular disease. And as the chairperson, sir, has rightly said, we have to look for plaque stabilization and an unstable plaque. So we will have to move our endpoints to those studies where we have that stage of subclinical atherosclerosis, where actually we understand what drugs are benefiting and which will lead to less of glycemic variability and less of cardiovascular disease. So right now we are seeing for ASCVD, so targets will have to change. So maybe in the next few years we know which drug is better of all the lot.
Thank you, sir. This is a guest lecture, so no questions. We thank the organizers for giving this opportunity. With this, we'll close the session, sir. Thank you.
Thank you so much.
Thank you, sir. Thank you, our moderators, for chairing the session. So the next topic will be on neurology. I invite our chairpersons, Dr. Balaji, sir, and Dr. M. Chandrasekhar, sir, to kindly come onto the stage for chairing the session.
And the first topic in neurology will be chronic inflammatory demyelinating polyneuropathy in clinical practice. And I request Dr. A.V. Subramaniam, sir, to come over to the dais to deliver the talk.
Good morning, senior and junior colleagues. Thanks, sir, for asking us to chair this session. This session is about neurology. And the first speaker is Dr. A.V. Subramaniam. He's a senior consultant neurologist practicing in Trichy. Has undergone special training in neuroelectrophysiology from Chandigarh. Awarded Professor Sivakumar Oration for 2015 at Tapicon at Tanjavur. Awarded Dr. Arumugan Memorial Annual Oration for 2002 in Karur. Area of special interest in neurology, neurodegenerative diseases, psychoneurology, immunology, and mind-body medicine. Other areas of interest: sought a speaker in various colleges, societies, and clubs for his talks on public health, mental health. Interested in writing books and in travel. His recent titles are on selected stories from Sivapuranam and Rasatala. He's a busy practitioner in Trichy. In spite of that, he has a lot academic activities. He has almost talking every week or month on some forum or other. So busy with his academic work also in spite of his busy practice. Now I ask Dr. Avius to talk on chronic inflammatory demyelinating polyneuropathy.
Thank you very much for your kind words, sir. A very good morning to all of you. Respected chairpersons, senior physicians, dear colleagues and friends. It's a privilege and honor for me to be here talking about CIDP in clinical practice. May I have the first slide? First slide. CIDP is a rare disease. So I thank the organizers for focusing on a rare disease, because more rarer the disease, the less the awareness about the disease, more the delay in diagnosing disease. And this is a disease which is eminently curable or eminently treatable. And we can avoid a lot of morbidity if we know about the disease and treat it and pick up the cases early. If you look at the prevalence of CIDP, you find that there are big studies from USA, Europe, Japan at the extreme, and Australia. And curiously, you don't find any study from South America, Africa, India, China, Asia, etc. So we don't have big studies about CIDP in these countries. Most of the studies are from developed countries. Still a very rare disease, between 5 to 8 cases per 100,000 population. So I want to focus this talk for the physician and the general practitioner. So putting it very simply, when should you think of CIDP? So you should think of CIDP if the patient has a progressing or relapsing muscle weakness of more than 2 months duration. This 2 months is very important, because this is what distinguishes AIDP from CIDP. So CIDP, you have 8 weeks or 2 months. Or if you have progressing neuropathic symptoms in the lower limbs or upper limbs of more than 2 months duration, you can think of CIDP in undiagnosed chronic neuropathies, or person presenting with a neuropathy without any obvious medical cause or a etiology for neuropathy. So these are the situations where you need to keep CIDP in mind. When it is not CIDP, so this is again one important thing we should realize. If you have a history of toxin exposure, drug exposure, you have a clear-cut medical cause of a neuropathy, and there is a family history, possibly inherited or genetic. So these two slides, so I go back to the slide. When do you think of CIDP? And when it is not CIDP? These two slides will be the takeaway slides of this talk. So the usual presentation of what we call as a classical CIDP or a typical CIDP. This form around 60% of all CADPs, and it's enough if we know about that in general practice. We have a symmetrical, very important, progressing motor weakness in the lower limbs. It starts usually in the lower limbs for more than 2 months, or symmetrical progressing sensory symptoms, lower limb, upper limbs for more than 2 months. So note the point, symmetrical, note the point, 2 months, more than 2 months. Reiterating the definition of CIDP, each word in the definition is important. So you have a typical CIDP, chronically progressive, stepwise or recurrent, symmetric. Because once it is asymmetric, it goes on into the atypical CIDP. So symmetrical, proximal and distal weakness, sensory. So you have a sensory motor kind of presentation developing over 2 months with early areflexia. Because it's a demyelinating disease, you find that the reflexes become hypo or absent very early in the course of the disease compared to the axonal neuropathies. So this is a small clinical thing you need to keep in mind. More the demyelination, more the loss of reflexes. So patient will have absent reflexes or a hyporeflexia. And what is not CIDP is what we just told. The sphincter disturbance usually doesn't happen, and not meeting criteria for other disorders which may present like a differential diagnosis for CIDP. Of course, there are uncommon presentations also which form around 30 to 40% of CIDP. You will be pardoned if you don't know much about this, because this basically CIDP itself is a rare disease, and the typical CIDP or a classical CIDP forms 60% of the cases, and these form around 30-40%. Just for a knowledge, you can have a relapsing pattern. For example, in women, they relapse during pregnancy. So that should be kept in mind. You may have a predominant motor presentation, predominant sensory presentation, predominant distal involvement known as DADS. Now that is coming out as a separate disease, distal acquired demyelinating symmetrical neuropathy. You can rarely have AIDP progressing to CIDP. So normally AIDP comes and then recovers over a period of 4 weeks. So you may find that some of these patients progress. And who are those patients? These patients may have HIV, SLE, malignancies. So they may start with AIDP and then progress into CIDP. Your other atypical variants like asymmetrical variants, very rare presentations like papilledema, root enlargement. We'll just talk about that later. You can have some amount of central demyelination, though in classical CIDP, CNS involvement does not occur. And rarely you can have a chronic immune sensory polyradiculopathy. These are all rarer things. I wouldn't want you to break your head over this. So I want you to focus only on the first figure, which is the symmetrical sensory motor kind of involvement over 2 months. And these are all the atypical involvements, pure sensory, pure motor, DADS, etc. So I would like you to focus only on this first presentation. So the usual clinical findings are, symptoms are, progressing weakness, both LL, UL, usually LL more than the UL, symmetrical. Symmetry is very important in classical CIDP. You have proximal as well as distal involvement. Because it's predominantly a demyelinating illness, you do not get muscle wasting. Muscle wasting is a direct, sequelae of axonal loss. So here you find that axonal loss is not there. It happens very late in the disease. You have predominant demyelination. So you find that muscles are still preserved. Even though they are weak, there is hyporeflexia and areflexia. These two are the cardinal kind of clinical features in CIDP. Muscles are not wasted. There is a lot of weakness. There's a lot of sensory symptoms. The reflexes are lost early in the disease. Age of onset is approximately 50 years. In relapsing type, the age of onset may be younger. Age of onset is older with CIDP associated with malignancies, etc. In children, rarely, CIDP can present like a very acute presentation of the gait abnormality. In the sensory symptoms, you find that they are symmetrical, Glauben-Stocking type, more involving the large fiber. There's a point to be noted that the pathology here is demyelination, and there's a lot of myelin in the large fiber. The small fibers are largely unmyelinated. So you find that the small fiber symptoms do not happen. It's predominantly a large fiber kind of symptoms. So you find that the small fiber symptoms like burning, pricking, tingling, paresthesia, they are less rare, rare or less dominant. And neuropathic pain as such is very rare in CIDP. So you find more of a painless kind of sensory motor dysfunction progressing over 2 months. So that is CIDP. You don't get much of pain, you don't get much of paresthesias because small fiber involvement doesn't happen. It's predominantly a large fiber involvement. So that's one thing to be kept in the clinical features. Nerve conduction is a very, very important test in CIDP. It forms part of the diagnostic criteria. Finding suggests a demyelinating sensory motor polyneuropathy. The other things are all supportive. You can have a CSF showing an albino-cytological dissociation. You may have a MRI showing gadolinium enhancement of the roots, and then sural biopsy in some cases where you suspect a vasculitis, malignancies, etc. But the basic thing will be clinical and nerve conduction. Clinical and electrophysiology is the cornerstone of the diagnosis of CIDP. CSF, MRI, sural biopsy are supportive kind of evidences. Just to show you an example of MRI neurography done in patients of CIDP. So you see that because of recurrent demyelination, remyelination happening continuously, this remyelination is a bit kind of abortive kind of remyelination. So you find this thickened roots, and this thickening is because of constant D and remyelination happening. So the picture on the left is the typical CIDP where you find a symmetric kind of involvement. The picture on the right, you find a lot of asymmetry, and that's an atypical kind of CIDP. So MRI can sometimes help you to show the thickened roots. So what are the investigations which are basically needed when you have a patient with a chronic progressing neuropathy? Obviously need these investigations which are mentioned here. Just like to mention about serum electrophoresis, this is normally not done in the routine evaluation. We should start doing serum electrophoresis in all patients of neuropathy because there are many patients with paraproteinemias whom probably we are missing. So apart from the usual investigations, just like to highlight the importance of peripheral smear, serum electrophoresis, malignancy screen, breast examination, sometimes in ladies. So these are investigations which should be done basically in any patient of chronic progressing neuropathy. Patients who have CIDP with associated monoclonal gammopathy, they are older, they have more distal involvement, more protracted course, they respond less to immunomodulatory treatments. So how do you treat CIDP? So corticosteroids are the mainstay of therapy in low-income countries. So in countries like ours where people cannot afford IVIG, corticosteroids are often the drugs to start with. You start with 1 milligram per day, single dose daily. In 2 or 3 months, you find that the patients start improving. And then once the patient starts improving, you can then convert it into an alternate day, single dose. And then if they are still they continue to improve, you can reduce the dose by the even day dose by 10 milligram per week. You can maintain the steroids for around 6 months, by which time this remission starts happening. And then once the remission starts happening, you can taper 10 milligram per month to the lowest possible dose. They may require a small dose for a long time. Actually, steroids are quite effective in CIDP. The only problem is the adverse effects. They give actually a long remission time, better than IVIG, better than plasma exchange. The problems are the adverse effects which accompany the steroids, especially in a long therapy. So the multiple side effects which you also need to keep in mind when you have a patient on steroids. The next modality is plasma exchange. You can start with 3 exchanges, 50 ml per kg, weekly for 2 weeks. And then you can have 1 to 2, you lower the number, 1 to 2 exchanges weekly for 3 to 6 weeks. And then you see the response and then decide on the next exchanges. And these can be continued for months or years. You can continue steroid plus plasma exchange also. In developed countries, people have shifted to IVIG. So they almost dropped plasma exchange. Some people are going for this immunoadsorption because of a better side effect profile. So compared to plasma exchange, people are preferring immunoadsorption. But in developed countries, people have shifted to IVIG. Now this is the therapy which people are using in countries abroad and even in India where patients are affluent. So if somebody is affluent, can afford therapy, IVIG should be the treatment of first choice. If he is not able to afford IVIG, then we can go for steroids. So IVIG, you can go by the traditional dosing of 0.4 gram per kg per day for 5 days, or you can go for what is known as the induction therapy. So the therapy on the extreme left is the induction therapy. So 1 gram per day on day 1, day 2, and sorry, that was 1 gram per kg per day. Small thing I missed there. 1 gram per kg per day on day 1 and 2, which is called the induction therapy, and then you give it after 3 weeks. Earlier, IVIG, because of the extreme cost, was used for severe deficits, progressing course, refractory to other therapies, etc. But now, because of a very good efficacy of touching 80%, IVIG is now used as the first line therapy, even without giving steroids. So if somebody is able to afford IVIG, directly start on IVIG. There's no need of having him get the side effects of steroids, etc. If he is able to afford a long-term treatment with IVIG, there's no need of steroid, no need of plasma exchange. You can directly go in for IVIG. So you give the induction therapy, which is given on the extreme left, and then monitor the patient. Then whenever he relapses, you can give a single dose of IVIG, 0.4 gram or 1 gram per kg. Usually you find that the response is there for 3 to 4 weeks, but of course it depends, it changes from patient to patient. Roughly every 3 to 4 weeks you need to give 1 gram per kg as a kind of maintenance dose. Recently they have noted that a subcutaneous administration of IVIG is actually more convenient, can be done even at home, easier for the patient to do it himself once you teach him how to do it. So this is now emerging as a kind of therapy which people can try at home, cheaper, lesser side effects. You can just guide him how to do it, he will do it at home itself whenever he finds that he is deteriorating. For patients who are then refractory to all these treatments, steroids, IVIG, plasma exchange, then you need to go on to cytotoxic drugs. Azathioprine, long time favorite of all of us, very safe drug. We have tried it for a long time, have not had any problems till now. Then mycophenolate, fast replacing azathioprine today in today's practice. That MMF also we have had a very good experience, no major problems. Of course, there are other options in patients who are very, very refractory. So just wanted to mention two things about this CADP. I don't want you to break your head over this slide. The only thing you need to focus is the two arrows. That is, in CADP, in a small percentage, we have started detecting autoantibodies, especially in this DADS, where you have an anti-MAG antibody. You have a CIDP with IgG4 antibodies. So some autoantibodies have started getting detected. It is still a matter of debate whether we should keep these disorders under the umbrella of CIDP or take them away to another category known as paranodal neuropathy. So that's another big category that is coming up. But whatever it is, if the antibody is positive, they do not respond to IVIG and the plasma exchange steroids very well. So if people are having an antibody positive, they need to go for rituximab. So rituximab works better when there is an autoantibody. If they don't have any antibody, the other immunomodulatory treatment, steroid, plasma exchange, IV immunoglobulin, this is the usual treatment. So that's the only thing I wanted to tell about this. So if you have a detectable antibody, rituximab will do better. So what happens when you treat these patients? The initial improvement is very good. So you find that almost all of them, 95% of the patients have a good initial improvement. Around 50% remain in remission. But around 1/3 of patients start deteriorating. They do not respond well. And 10 to 15% you may find that they may even die later due to complications. Some amount of motor disability sets in as the disease progresses. And that's what we want to avoid by picking up the patient very early. And presence of axonal loss in either the biopsy or the nerve conduction, you start knowing that secondary axonopathy has started setting in. It starts with demyelination and then goes on for axonal degeneration. So once the axonal pathology starts coming in, the muscles start getting wasted, the weakness increases, and that indicates a poorer prognosis or an incomplete recovery. So the message is that we should pick up these patients earlier. And this is basically a very rare disease. So we need to create awareness to the medical population regarding this disease so that people are aware, they pick up CIDP earlier, and we start one of these therapies earlier so that we avoid this kind of motor disability which accompanies the disease in the long term. Newer developments are a lot of antibodies are being detected. So there are antibodies against neurofacin, contactin. So a lot of antibodies are being detected, and this CIDP umbrella is actually widening. And maybe there will be a time when this will be a different category altogether, like a paranodal neuropathy, and you have a classical CIDP. So it is still coming under CIDP, but then it's a very widening umbrella. There's a lot of dynamicity happening in this field, and a lot of exciting developments are happening. And most of these patients will need rituximab. So we need to change our treatment protocol. CIDP generally responds well to immunomodulatory. Here we need to go in for rituximab. So thank you very much.
Thank you, sir. You rightly started by thanking the organizers for having chosen such a very rare yet useful topic. Now it's time we thank you for having done a great justice to the topic by having a very clear presentation on this topic. Just to reiterate what you said, CIDP is just a clinical and an electrophysiological correlate. And you rightly started with the situations where we start to suspect a CIDP in a clinical scenario. Thanks for the presentation, sir. Thank you. Now, I think we'll have the questions at the end of the session after the other speakers finish. So, thank you, sir.
Thank you.
Thank you, sir. For the second talk of the session today, I request Dr. K. Mukundan to come to the dais to deliver his talk on restless leg syndrome. Over to you.
Professor K. Mukundan, my mentor, whom I reach to at all situations. He is a professor and HOD of neurology at Stanley Medical College, revolutionizing and revitalizing neurology academics at Stanley Medical College. So the academic excellence of Professor Mukundan is displayed, and we'll move to the next topic of restless leg syndrome from Professor K. Mukundan.
Good morning, respected Chairperson Chandru sir and my colleague Dr. Balaji. First of all, I thank Dr. Sethuraman sir and the organizing team for giving me this opportunity to talk on restless leg syndrome. Restless leg syndrome is also known as Willis egg-bomb disease. It's a common neurological movement disorder characterized by an uncontrollable urge to move, mainly in the lower limbs. The diagnosis is mainly based on the patient's history and neurological examination to exclude differential diagnosis. Commonly, it occurs in 2 to 7% of adults and 2% in children. Women, 1.5 to 2 times more likely than men. Early onset, that is younger the age, less than 45 years, and the late onset is more than 45 years. The early onset RLS is often familial and slow progression of symptoms, whereas the late onset have rapid evolution and associated with comorbids. Above all is an iron deficiency state. This is the diagnostic criteria by International Restless Leg Syndrome Study Group, which is a consensus diagnostic criteria. The first is an urge to move the legs usually, but not always accompanied or by felt to be caused by an uncontrollable or unpleasant sensation in the legs. The next, the unpleasant sensation begin or worsen during the period of rest or inactivity such as lying down or sitting. Then the unpleasant sensations are partially or totally relieved by movement such as walking or stretching. 4. The urge to move the legs and accompanying unpleasant sensation during rest only occur or worse in the evening or night than during the day. And the above features is not solely accounted for the symptoms primary to another medical condition. The supportive criteria are family history, dopamine treatment response, and periodic leg movements during wakefulness or sleep, a lack of profound daytime sleepiness. A single standard question for rapid screening of restless leg syndrome validated by the IRLSSG. When you try to relax in the evening or sleep at night, do you ever have unpleasant or restless feelings in your legs that can be relieved by walking or movement? So this is the restless leg syndrome, which carries 100% sensitivity and 96% of specificity for the diagnosis of restless leg syndrome. The genetics, it's a familial disorder, particularly with the early onset, less than 45 years, as autosomal dominant. Because in first degree relatives, many genes are associated. MEI, this one was the strongest risk factor. What is the pathophysiology of this condition? The iron, dopamine, opioids have been extensively studied to identify the pathomechanics. Although the serum iron is often normal, some patients will have low iron in the brain, mainly in the substantia nigra, also in the putamen and caudate nucleus. Hence, there is a dysregulation of iron transport across the blood-brain barrier is one possible mechanism. And also the endothelial cells in the blood-brain barrier serve as iron reservoirs in the brain. So the underlying problem is probably lack of sufficient iron in the reserve of the endothelial cells to meet the physiological demands. Also, and it's a dramatic response to dopamine medications, which implies a brain dopamine deficiency, but it suggests a hyperdopaminergic state also. So there is a circadian profile that the dopamine reflects the hyperfunctioning in the morning and throughout the day, and hypofunctioning in the evening and night time. Hence, the dopamine receptor downregulation coupled with low dopamine activity at night may create a state of dopamine deficiency at nights when these symptoms occur. What are the clinical features? Uh, they may complain of strong, irresistible urge to move. I told you mainly in the lower limbs, legs, often accompanied by uncomfortable sensations, crawling, tingling, cramping, creeping, painful, itching, burning, and prickly sensations. Isolated pain with an urge to move is not restless leg syndrome. The urge typically begins or worsens during periods of inactivity, especially lying down or sitting, and relieved by movements such as walking or stretching is a characteristic feature of restless leg syndrome. The symptoms occur in the evening or night, can worsen at night, tend to resolve spontaneously in the early hours in the morning. Mainly, it occurs distal to the knee joint. These symptoms generally occurs bilaterally, can also occur unilaterally on the alternate on two sides, more rarely be strictly unilateral. This picture shows the pattern of involvement of restless leg syndrome, mainly distal. So, next is the intermittent borreless, which is defined as when symptoms are not treated have occurred and average less than twice weekly for the past 1 year with at least 5 attacks. And then another definition is chronic persistent RLS when symptoms not treated have occurred an average of at least twice weekly for the past 1 year. What are the co-occurring diseases? Mainly iron deficiency state, renal failure, Parkinson disease, multiple sclerosis, hemodialysis, then IBD, depression, anxiety, and migraine and bruxism. The etiology and DDs are the primary, which is idiopathic, occurs in middle-aged, the progressive clinical manner with genetic association, mainly related to dopaminergic and brain iron dysregulation. The secondary RLS, there are three major reversible causes. One is iron deficiency, pregnancy, and end-stage renal disease. Also occurs in vitamin B12, folate, and spinal cord disorders, Parkinson's, and fibromyalgia. The differential diagnosis are, there's a very big list: nocturnal, leg cramps, habitual foot tapping, akathisia, vascular causes, arthritis, and drug-induced RLS. The neurological examination is invariably normal in primary RLS. Secondary RLS, the features of neuropathy, renal failure, Parkinson, or iron deficiency, anemia, clinical features. So, what are the mimics of RLS? See, neuropathic pain syndrome, which is not relieved with movement, whereas RLS is relieved with movement. The peripheral neuropathy, all of us know. The root involvement, the particular root distribution weakness. Then sleep-related leg cramps, which will have palpable tightening of the muscle, relieved by stretching, not by the movement. Then habitual foot tapping image, no urge to move, but reduce awareness of the movement. Drug-induced akathisia, which is inner restlessness, it is because of the neuroleptics. Here the movements are body rocking or whole body movements, whereas the painful legs and moving toes, no circadian pattern, there is no sensory discomfort, which is to be differentiated from restless leg syndrome. So the periodic leg movement disorder, the movements range from shallow, continual movement in the ankle and toes, and strenuous kicking and flailing of the arms or legs. The movement of the legs are more typical than in the arms. It occurs for 0.5 to 10 seconds, usually occurs in stage 2 sleep. Nocturnal myoclonus, the correct diagnosis requires 3 periods during night, lasting for few minutes to an hour each, containing at least 30 minutes movements, followed by arousal or awakening. Akathisia, as I told you, inner restlessness due to drugs, rock back and forth, may experience an uneasy feeling with their whole body. So the nocturnal leg cramps, by average of 9 minutes per episode, it's a painful and incapacitating muscle cramps. Posteriorly, calf muscles are involved, which is to be differentiated from RLS. The investigation done, or we have to have patient mainly history, and the neurology, the examination is invariably normal in primary. We have to exclude peripheral nervous system and vascular causes. The blood tests are done to rule out secondary RLS or iron studies, full blood count, B12 and folate, sugar, urea, creatinine, electrolytes, creatinine, and thyroid function tests. So what is the treatment of RLS? The general principles are severity rating scale as a guide to therapy, and a secondary factor should be identified and corrected. There are non-pharmacological interventions, behavioral strategies, and step-by-step approach to pharmacological treatment. So the iron supplementation for anemia, the ferritin needs to be rechecked after iron supplementation. Then what are the drugs which are given, we have to identify. Then lifestyle changes, as mentioned in this slide, I am not going to it. Sleep hygiene is very important. Then walking and stretching, massaging the affecting limbs, relaxation exercise are important. So the iron therapy, we have to determine the patient iron status. All of us know, I am not going to detail. The treatment, the first line treatment is dopaminergic agonist. The first and foremost is ropinirole, which is the first FDA approved drug for the RLS, which acts on the high affinity towards D3, then less with the D2 and very less with the D1 receptor. The dose is 0.25 to 4 milligram. So the response starts after a week. Then pramipexole, the another FDA approved drug, where it acts on the D3 receptors, then D4 and D2, then less with the D1 receptor, which is metabolized in the kidney. So we have to use low dose in case of renal impairment. We have to give 0.125 to 0.75 milligram. The rotigatin is a drug which acts on the D2 receptors mainly, and also D1 and D3. The dose is 1 to 3 milligram per 24 hours. It is a transdermal patch which is very useful in restless leg syndrome. Then levodopa formulations are tried. Then the next, the second line treatment are alpha 2 delta calcium channel ligands, which are pregabalin and gabapentin. We have to start with 50 milligram. We have to step up the dose till you get the response. Then how do you treat intermittent RLS? First, we have to try non-pharmacological therapy, then drugs like levodopa, benzodiazepines, and or low potency opiates like the codeine and tramadol. Chronic persistent RLS, try non-pharmacological therapy. Then you try with gabapentin or pregabalin. Then refractory RLS, it is nothing but restless legs, unresponsive to monotherapy with tolerable doses of first-line agents due to reduction in the efficacy, augmentation, or adverse effects. So we have to check the iron stores, and we have to replenish iron as needed. Then we have to correct the exacerbating factors. Then we can use combination therapy in case of refractory in the form of dopamine agonist, gabapentin or pregabalin, and also opioids or benzodiazepine. Then we can consider opioid monotherapy. So management of RLS during pregnancy, non-pharmacological therapies are strongly preferred, and we have special attention to iron stores. We can use IV in case of second or third trimester if necessary. Then we have to use drugs in lowest effective doses. In case of childhood, non-pharmacological therapy forms first, then iron replacement forms next, and we can give alpha to delta ligands as adults. So the treatment related adverse effects, the first and foremost is augmentation, which is the most common problem in this the condition. So what is augmentation? There is a overall increase in severity of RLS symptoms, like paradoxical response to treatment, whereas the symptoms get worse with increasing dose of medication, but improve following decrease in medication. It is common with levodopa and lowest with rotigatin. Worst long-term problem of dopaminergic RLS treatment. So we have to use drugs with long half-life and lowest effective dose. The predictors are low plasma ferritin and the previous episodes of augmentation and longest treatment duration. So the treatment related adverse effects are early morning rebound. There is reappearance of symptoms in the morning as the effects wears off. It can be managed by the currently prescribing drug in increasing dose and delaying the medication intake or dopaminergic medication with long half-life. Next is the impulse control disorder. The incidence is 3 to 17%. We have to reduce the dopaminergic medications, and non-dopaminergic treatment should be tried instead. So some alternative investigate and potential future therapies are tried. These have less evidence scientifically in the form of mechanical device, electric-magnetic stimulation, and botulinum toxin, magnesium, vitamin C, and E. So, ladies and gentlemen, I conclude my talk with the following conclusion. It's a common neurological movement disorder with great impact on quality of life. Before the diagnosing this the condition, we have to rule out secondary causes or exclude secondary causes. The treatment depends on the age and the comorbid condition and the drugs which are used. In mild RLS, reassurance and lifestyle changes might be sufficient, whereas in moderate to severe cases, pharmacology treatment is required. Thank you. Thank you for the patient here.
Thank you, sir, for a nice lecture. Gall Kodachal is one of the commonest symptoms by many of the patients, which we tend to ignore it as just a non-organic. So as he said, simple question like the time of occurrence, the type of the symptom, and whether movement improves may make a diagnosis of this condition. As he said, the questions will be at the end of the session. I call upon thank you, sir.
Thank you, sir.
I call upon the next speaker.
Thank you, sir. As the field of geriatrics is gaining more importance, we have the third lecture, Approach to Recurrent Falls in Elderly. I request Dr. N. Balamurugan, sir, to deliver his talk. Thank you.
Dr. Balamurugan is a prestigious alumni of NIMHANS Bangalore. He's an excellent star speaker and an academician. So we are eager to hear your talk, sir. Thank you.
A very good morning to you all. Thank you, Dr. Balaji. And we enjoyed your hospitality last year. And Dr. Appan Raj and Dr. Balaji did a wonderful Tapicon last year. Hope you all remember. And mid Tapicon. So, and it's great pleasure to be with you on this day. And I'm honored to have the top neurologists of this part of the world uh, in this hall. My special thanks to Dr. A.V. Subramaniam sir and Dr. R. Sundarajan sir, because I'm seeing him for the first time, but I'm learning through his records for the past 20 years. Nimans also, my teacher used to show that, see, this is Dr. RSR's file. So we learn a lot. Thank you, sir. Thank you. I'm blessed. Okay. Can you start? Okay, fine. So the topic is on approach to recurrent fall in elderly. And let's go step by step. And I'll be talking how common this one, what are the biomechanics, what are the things it causes, and in the history, what are the focus that you had asked, two important things in the history and focus examination, how to predict the fall risk in elderly people, and investigation with the focus on fall in elders, and I call third eye. So observing the attack or by CCTV or camera, that helps you to say what's the most likely etiology. 50% of the elders fall early in the long-term care setting, and 50% of the elders who fall are not able to get up without help, what we call long liers. They fall, somebody had to help them. And nearly about 10% of those who had a fall-related injury, and 60% of those with a history of fall in the previous year had a subsequent fall. So, ladies and gentlemen, fall is common in the elderly. A fall begets a fall, and it produces more morbidity and mortality. That's the message here. And what causes this? It could be motor incoordination, or it could be sensory problem, or it could be musculoskeletal. In addition to the intrinsic problem that we all know, the extrinsic causes also there, especially elderly. They cannot have a reflexive phenomena, especially footwear. In India, we are more towards now ceramic tiles. There is one recent article 3 months before from AIMS and IIT Delhi. They have evaluated the barefoot slip risk assessment of Indian manufactured ceramic floor tiles. They compared the rugs with the tiles, and the tiles, dry tiles with the wet tiles, and Lysol mopped tiles. And they found that wet and Lysol mop produces more fall in elderly. There's a wonderful article. You can go back and then see that. So we have to educate the patients on this. What causes this? So one is intrinsic and extrinsic factors that you can examine the patient at any time, and the fertility or the fragile individual, what we call now the word that they use, it fertile. The fertile is nothing but a physiological condition due to aging that causes decreased strength and endurance and physiological reserve, which in turn causes activity of daily living dependence, and so more morbidity and mortality. So this point is coming more and more nowadays in medical field, and now diabetologists have started using sarcopenia, the word, in one component of the muscle weakness. And these are the static, but always as a physician focused on precipitating cause. These are the episodic, because there is a static problem. In addition, something precipitates the fall. Most commonly a syncope or a seizure or vertigo or partial drop, sometimes the external factors. We have to focus on these episodic causes in examining. And history, as usual, you elicit all the history, but again I focus what triggers them to fall. And one important question that we ask that in the episodic phenomena, the triggers, is there loss of consciousness? Because when there is loss of consciousness, that means it's a syncope, very simple. So when there is a transient loss of consciousness, the job is easy. If it is a trauma-related concussion, if it is non-trauma related, most commonly syncope is a seizure. Metabolic and intoxication can produce, but mostly it is fluctuating rather than the short transient loss. And one more entity, there is no true loss of consciousness, but they fall abruptly, a rapid fall. So drop attacks, cataplexy, pseudoseizures. But these are all common in pediatric and young adults, not the elderly people. Unless you witness a drop attack, it's very difficult to get the history from the patient. So the common scenario in ER is that sometimes the orthopedician or the general physician may ask you to evaluate the fall, because the fall due to slip or the person had a syncope. How do you evaluate? They had an accident fall or a syncope? The question that we ask is there a transient loss of consciousness? Before syncope, whether the person had a pre-syncope, isn't it? So very easy. If it is there, okay, syncope. But the crux in the special edition people, the elderly people, is that prodrome is uncommon. In syncope, in elderly, prodrome is uncommon. So less than 10% of the elders have a prodrome. 90% do not have prodrome. Second, this is one important message in the history sitting. Often amnestic to transient loss of consciousness. I'm not talking about demented patients elderly or cognitively impaired. Cognitively normal elders, they are amnestic to transient loss of consciousness. And then what one article says 95% of the recurrent fallers with no reported history of syncope had actual transient loss of consciousness. It's amazing. So I thought it could be 50%, but 95%. Because I reviewed some of the videos and then asked the patient that whether you had loss of consciousness. They said, no, sir, I had a giddy. I never lost the consciousness. But the video clearly documented they lost the consciousness for a few seconds. So the history, two important message here is that don't rely on the prodrome to say as a syncope. Don't rely on LOC from the patients. Any fall, even the slip, it could be a syncope because the patient may not tell the transient loss of consciousness because they are amnestic. That's a very special problem in elderly. And in the examination, you all do that, but always I insist on examining the postural BP. That means BP in lying down, standing for 1 and 3 minutes. That's the most essential in evaluating fall in elderly. And fall risk assessment by timed up and go test or other test, I rely on this timed up and go test is the most useful test. And all elders coming to your OPD, even without history of fall, you should assess because this causes a long-term morbidity and mortality. And 30 days morbidity is more common when they could not complete the timed up and go test. This is very easy. You have to ask the patient to sit and then get up without a support, and they have to stand and then they walk for 10 steps, turn around and then come back and then sit. So normally it takes 12 seconds. So maximum about 15 seconds. So if they take more than 15 seconds to do this, that means there is an issue in the either the strength, the first part is the proximal strength, or the gait, or the balance, or sensory problems. So this helps you to say these are the people likely to go for a repeated fall and so fall related injuries. And we neurologists look at this pull test. You don't have the video of the pull test? Okay, fine. Let's see, you have not put that. It's fine. Okay, no issues. So we neurologists go for the pull test, especially in the patients having a Parkinsonism is there. And no, don't worry. So we ask the patient, yeah, you want to play? Yeah, sure. So we ask the patient to stand and then we just tell the patient that we are going to pull back. And normally, patients take 1 or 2 steps and then they balance. When they have problem in the extrapyramidal system, so this is a normal pull test. So you have to be careful. As an examiner, you should not fall. So abnormal response in Parkinson's that when you pull that, so always you stand behind the wall. Otherwise, the chance of fall is more. So that's the one thing that this is the one thing that it means they fall like a log of wood. So it means that they are having more prone for fall. That helps you to do that. Thank you, sir. And investigations, I'm sure that any person coming with repeated fall, you'll ask for a cardiologist opinion, ECG echo holter. Am I right? Yes. And if they go to the neurologist and we do EEG, CT scan, MRI, carotid Doppler. So because fall could be the syncope. Do you know how many percentage these tests gives yield? 10% and less than 1%. So something very common test that we don't do is that one is a tilt table test and is carotid sinus massage. Tilt table test yields 30% of falls evaluation positive results and carotid sinus massage in 10%. We commonly don't do that, but at least today, this message has to be very clear. So instead of going for a EEG, CT, MRI, carotid Doppler and MRA, and in an evaluation of a repeated syncope, better you go for a tilt table and carotid sinus, then you go for other invasive or interventional problems. So tilt table normally about 70 degree of tilt, lying down, and then BP with pulse has to be recorded, and carotid sinus massage bilateral, not simultaneous, sequential, 10 seconds of massage, horizontal massage. That give you the idea about is it a carotid sinus syncope or not. Then I go for the third eye. That means I will show some of the videos and how they fall, because the history will be just a fall, and this mostly I downloaded from the WhatsApp and the internet. So I carefully observe this person, a red shirt, the gentleman with the red shirt. So he was standing in front of the veranda of a bank, probably emotional imbalance he was having, I don't know that. But you carefully see that. Yes, he's having some amount of imbalance, prodrome. Amazing about the blue shirt, no? So that reflects what he had. Okay, so he was saved. So he had a syncope, and then so they could pull him back. I skipped the video, and then he was saved. There was so always the two messages are there. So syncope is a sudden, and when you build a house, the carpet should be at least 5 feet. Okay, don't stand with the carpet is less than 5 feet. The chance of fall is more. And there's a message here, and the fall is sudden always. Okay, don't expect all the people will have a prodrome and then they'll sit. So this is railway station. They called me and then to give an opinion about this, the Salem, that this is a railway police standing. It's a good stain. He was not trying to get up. Yeah. So that was turned out to be a seizure. What is the gyratory seizure? The fall due to gyratory seizure, but generally we think that it is in the platform. We may think that you're trying to get into the train. That is not the case. And how many of you had seen this? I don't know. And this is a rehearsal, Dan rehearsal on a selfie camera. She was doing that. And carefully see that how she was. Yes, this is called cataplexy. Sudden fall, a drop attack. And she's trying to get up, and then she's again getting more and more attack as a sleep attacks. I have never seen a case of narcolepsy like this. So this in a person coming, especially middle-aged, coming with a sudden fall and then getting up. Again, she goes for a sleep attack, sleep paralysis. So this is very classic for narcolepsy. There's one condition where they never lose the consciousness. Carefully see here again. This is sleep attack. Sleep attack may be hypnopompic or hypnagogic. So, can you put it on? Yes. So he is a CEO of BMW addressing the press conference and audio. So this is the classical
Harold Kruger was
vertiges.
making his first major appearance.
So you can see again he has that swaying to one side. He didn't have stroke, he had a vertigo. So the vertigo can cause, we generally define vertigo as a sense of imbalance, but they can have a fall. And if it is an autolytic crisis, the fall may be so severe, you carefully see that I would not have made the diagnosis of vertigo in this patient. So this is from JAMA, our reputed journal. They have evaluated these patients. Autolytic crisis, stomach-line crisis can produce a fall. These are some of the causes for fall. Now I take you through some of my cases where that helped me, that video recording or the third eye helped me to find out the cause. This 76-year-old retired teacher, a father of a cardiologist. So Eval had a recurrent attack of transient loss of consciousness. And I thank the family for allowing me to discuss about that particular gentleman. And he had his 8 attacks over 1.5 months. And the first attack I was describing, he was mopping the floor. His wife heard a sudden noise, sound, and he saw him in the floor and unconscious state. Within a few seconds, he recovered fully. So it looks like a syncope, isn't it? Sudden fall and then getting up. So there was no trip or slip. So he never had a prodrome. And he had a cup of coffee and then was normal. He had a repeated attacks over 1.5 months. And I divided the 8 attacks. The 6 attacks were similar in attacks. Sudden loss of consciousness, fall, recovering within 10 to 15 seconds. And I thought probably syncope. But one history was that the son was telling that he was having a grunting respiration and few jerks and abnormal eye movement. And eyes were going up. So he asked a neurologist's opinion, and then probably seizure. This was the thing that, and one attack was more of pre-syncope, and the 5th attack was more of vertigo. So all the investigations were normal, including the tilt table, which was no partial hypertension, ECG echo. 24 Holter was normal, and the neurologist side was evaluated for all these investigations, which turned out to be normal, including EEG. Of course, EEG may be normal in epilepsy, so sort of on anticonvulsants, CT chest and abdomen. It was a COVID time. That's the reason they have done that. So now you witness the attack. So he was normal now. So though he said in the history there is no prodrome, now you can see that he said the prodrome and he lost his consciousness, he collapsed, he fell down. He was having the, you can hear the grunting respiration, the voice you can hear. So the eyes gone up. So you can see the face redness. He recovered. So how many of you vote for Caesar? How many vote for syncope? So both are possible. The rapidity, just 15 seconds. So more in favor of syncope. And the rapidity he came up, so more in favor. The problem is that most of the time syncope, when they have a jerk, jerk means epilepsy. 90% of the syncope have jerks. 90% of the syncope, we call convulsive syncope, but 90% of the syncope have mild jerks. And if you have still doubt, you can put in the internet, Lampert et al. They have analyzed syncope nearly about video recording. You can freely see that videos of about 30 cases of syncope, how many of them had jerks. That's a message here. And he recorded completely. And what made us to think syncope is the detailed history, witnessing the attack and the phenomenology, and then the flush in the face. And I was seeing the pulse when he was had the attack. And the EEG and ECG tracing showed this is the ECG tracing. He had that phenomena here, and then you can see that no recording here, and again it starts. Nearly about 6 seconds, there was an asystole. So I called the cardiology son, and I said that, Baba, you had to go for an Holter again. Till you get an attack, the person has to be Holter. Because the first Holter, the person didn't have a clinical attack. So to his surprise, and then he called me again, he said that, sir, this is all right, that this is a syncope. He had only the P wave for about 6 or 7 seconds, and no QRS complexes, type 1 AV block, and that turned out to be AV nodal dysfunction, and he's doing well with pacing. So convulsive syncope and epileptic seizure, you can take this as a click, you can take this as a photo, and then the one message is that here the syncope is very transient, maximum about 15 to 20 seconds. So arrhythmic jerk after the onset of loss of consciousness is multifocal, and the jerks will be 4 or 5 usually. And they may be, the eye deviation may be upwards, the lateral eye deviation more in favor of epilepsy, and then slowly they recover, and they will have a clonic jerks and tongue bites. So we managed with the cardiology son managed with the pacemaker, and anti-epileptic was stopped. He is doing well, no attacks for the past 24 months. So the message here is that detailed history is essential. Paroxysmal event, better try to document. If you are not able to document in your Holter, in your EEG, there's a chance that he didn't have the attack, so you didn't get any positive finding. So syncope is a common epilepsy mimic, and they may not have prodrome. In all the cases, they may have a few jerks. Recurrent fall due to syncope, AV block, extrinsic idiopathic type was the final diagnosis. And the case number 2, 68-year gentleman had a recurrent transient loss of consciousness with a few jerk of 3 months duration, 10 attacks, lightheadedness and LOC, and the person was on syndopa, antihypertensive, nitrates, diuretic, and antiprostatic. The clues here now. So repeated attacks on standing, on lying. So this patient had the pulse BP, and on 3 minutes standing, so you could see the BP drops to 80-60. So can you play this? So if you're not able to play, leave it. Fine. So leave it, then leave it. Okay, fine. He had a partial drop, and the second case, again, he also had this partial drop, and at least this is coming up. So, what's the problem? Oh, it's going so short. So you could see that drop on the, this BP was normal, the first case, sorry, this is the first case. So when we ask the patient to stand, and then just to show you that a drop in the BP associated with the loss of consciousness will have a few jerks again, to show you that few jerks is common in syncope in elderly people. And here you can actually see that BP dropped to 60-40, and now you can see his. So this was in 2004-5 that I didn't have tilt table. We meticulously were doing that. So this is the thing that going up, and then he had a drop, and then we made the patient to sit, and when he sat down, he didn't lose the consciousness that time. He sat down again. The BP was not picking up. We should have asked him to lie down, and then now you can carefully see that few jerks that he drops his head and then he gets the jerks. Yes. Yes, this is syncope and then. So this is a partial hypertension. Another patient had more or less the same phenomena. Now we started having a tilt table, and then this person had again partial drop. The next, I'll go to the next steps. Okay. So here, I'll finish it in another 1 minute. Both the case had a syncope due to orthostatic hypotension. The case 1 and case 2, the difference is that the case 2 had the rise in the pulse rate with the drop in BP, and the case 3 had same pulse rate but the drop in BP. So here is a clue to suspect secondary orthostatic hypertension. The first one is that neurogenic. This is neurogenic, where there is a total autonomic failure. Here, the sympathetic part is good, and this, if you get, you suspect drug-induced or dehydration. So this is a take-home message here. Always record the pulse and then BP. If the pulse rate increases and the BP falls, it is most likely a drug-induced or dehydration. If it is not there, again it could be drug-induced or it could be autonomic dysfunction. With this, and then next case, this is a tough call. This case I had to show you. 95-year-old gentleman had considered as recurrent attacks over the past 1 year. All the attacks when he was upright and standing and sitting, sometimes in sitting position. None of the episode occurred in the supine posture. So we thought a partial drop, but he didn't have a partial drop. And during an attack, he had uprolling of eyeballs and few jerks. And again, so can you play this video? Yeah. Audio, please. So he was talking to me. He was working in. I was doing carotid massage. So I'm doing carotid massage. See the ECG tracing here. So within 2 seconds of carotid sinus massage, you could see this is gone. No way. He had gone for asystole. So here the attack. There's an attack. He fell down. We made him to immediately. He had a jerk. See the hand, left hand. So this is a classical carotid sinus massage induced. So this is a very classical case of carotid sinus syncope. Don't expect the carotid sinus syncope will come from the saloon and then saying that somebody was shaking my head and then have that attack. No, this is a rare. That's for all historical importance. But carotid sinus massage is very common when they wear the tight collar, when they wear the ties, and then when they frequently turn their head. They're so common, not an uncommon entity. And he recovered, and then, so this is the ECG, and he could see that absent P and QRS complex, the asystole. And this patient may, some of the patients, when you stimulate, they may have a brady hypertension. If they are not having symptoms, we call it a carotid sinus hypersensitivity. That's a normal physiology. They have symptoms, we call carotid sinus syndrome. So, carotid sinus syndrome has to be treated with now the current evidence from the American Heart Association and the European Heart Society is that you have to go for a dual chamber pacing. So in this patient, the lesson learned is 50% of the elders with undiagnosed recurrent fall had a carotid sinus syndrome. It can be diagnosed only by carotid sinus massage. No other investigation can help you. Whatever investigation, unless you do a carotid sinus massage, you cannot do that. And the only treatment option as of now is the dual chamber channel. The last case, he had a recurrent transient loss of consciousness. Some attacks were looking like a complex partial seizure. Some attacks were generalized clonic seizure. But the problem is that when the history was of complex partial seizure, some of the attacks he had a fall. We don't expect a fall in a complex partial seizure. So that made me to think that is it epilepsy? In addition to that, epilepsy was having a syncope. So we did an EEG, and then we were lucky to get an attack. So this patient was saying uneasiness. This is a time that he is getting the attack. You can see the change in the ECG, and there is some change in the ECG. Can we see that this is a rate, and then he is going for slow brady, and he had a behavioral arrest. He was not responding, and then you can see that asystole, almost asystole is going there. So now I am showing the compressed view that the seizure starts here. You can go, the seizures are going, and the rate comes to the brady and then goes for asystole here. So this is called ictal bradycardia syndrome. So here this patient had a complex partial seizure. If a complex partial seizure presents with unexpected collapse, consider ictal asystole. We don't expect a collapse in a complex partial seizure. The patients are usually unaware, but they don't fall. So that's a message here. So ladies and gentlemen, a recurrent fall is common in elderly. Look at the biomechanics. Your job is to elicit the history to important. The syncope has to be differentiated with seizure. Don't rely on the prodrome and don't rely on the history of loss of consciousness because they may be amnestic. Focused examination with focus on carotid sinus massage and tilt-table test, and you may get nearly 40 to 50% of the cases undiagnosed may be diagnosed by our clinical acumen. And always try to get the video clipping if you had the opportunity, or ask them to get the video recording. Thank you all for your patient listening.
Thank you, Bala sir. It was one another vibrant presentation. I think the way the audience and we are going to approach fall in elderly is going to change after your presentation. Thanks a lot for that. I think we have time for a couple of questions. If somebody has questions, I think the speakers are here. I just want to ask, start asking, how safe is doing a carotid sinus massage, sir?
So carotid sinus massage we were doing routinely for PSVT. So because the person is having a disease and supraventricular tachycardia, we do the carotid sinus massage. Most of the time the person will be in lying down position. So one of my teacher taught me, if the person is not responding, you make the patient to sit and then do that during my post-graduation. So we didn't have much evidence for that. When I reviewed extensively about the carotid sinus massage, none of the patient had injury or morbidity mortality related with, they have nearly evaluated around 120 cases of carotid sinus massage, no morbidity mortality related at all with carotid sinus massage, because it's a very transient phenomena. How long to stimulate? When you look at the history, carotid compression for 30 seconds started. Now it is just 10 seconds of carotid massage longitudinal. It's not there because angle of the mandible to the higher. So you have to pick up because it's a high level. So the maximum pulsation you can pick, just you massage that. You saw what I'm showing. I showed that video is that just about 1 or 2 seconds you get the attack. Once you get that attack, don't continue that. The patient has to do that. No morbidity mortality. I had nearly about 7 cases of documented carotid sinus. It's not uncommon. It's common, especially I say that you do it as a last when the tilt table is negative and still you are not able to get the cause, and you can do this because it can be diagnosed only by carotid sinus massage. Nothing else. You need not worry about that. You can get a consent if you want. What I do is that I show this video to my patients and they say, this is the thing I'm going to do that. Then they will be okay, fine. So best way that.
So one question, sir. I'm Dr. Lydia. Suppose we don't get a history from the patient. There's no attenders by the side. So how do we elicit whether it is a syncope or just a fall, a slip and fall?
No, that's the thing. So if you don't have a history, you don't have eyewitness. So there are 2 things. First, you have to examine the patient. If there is a tongue bite on the lateral margin, that's a strong clue. But I know that tongue bite in the lateral margin won't happen in all epilepsy. If it is there on the lateral, it's 100% it is a seizure. That's one clue. Second, you can submit the patient to similar situation like a tilt table, like a carotid sinus massage. I can examine the patient. Suppose the person is a known cardiac patient on stent. So my first thing will be going for an ECG and going for a Holter rather than doing all this carotid sinus massage. That's very common. So you have to go with investigations. So history is not there. The only clue will be a tongue bite. Other things very difficult.
Thank you.
So Dr. Mugundan sir is there and Dr. AV is also there. You can ask questions related to that. I can take up questions related to false, sir. Yes, sir.
Excellent talk, sir. And we recently had a hypotension conclave where we discussed this postural drop. And like you rightly highlighted, the postural BP drop causing the syncopal episode. We had, we gave them a mnemonic. It's called the 4D8 mnemonic, given in the Canadian Journal of Medicine, where if the patient goes for a syncope with tachycardia or without tachycardia, like you had pointed out, sir. So with tachycardia, we have 4 Ds. That is dysfunction, deconditioning, and dehydration and drugs. Dehydration and drugs. So this is a 4D where they go for tachycardia with hypotension. And in autonomic failure, AID, autonomic failure and idiopathic causes, and again drugs like beta blockers. And they'll have hypotension without bradycardia, without tachycardia. So So we have this 4D8 mnemonic, which will help us in differentiating the causes, like you had rightly pointed out, sir. And,
Thank you, sir. Thank you. Well taken. Again, the message is very clear. We have to do BP and pulse state because
BP and
generally we
pulse.
don't record the pulse state when you're recording the tilt table.
And
The
also,
pulse state has to be checked.
And
Thank you, sir.
also, we have to ask for the symptoms. What is the patient experiencing, like you are doing, sir, when you are demonstrating it? You are asking for the symptoms also. What's happening? What's happening? So that's again, it's all given in this particular mnemonic, 4D8 mnemonic. This for the sake of the PGs I've been telling.
Thank you, sir.
Thanks.
Thank you. Thank you.
Sir, Dr. AVS, sir, sir, in practice, we get to see some neuropathies which come, which may be relapsing, and we don't have any obvious causes for the neuropathy. Most commonly, we start thinking of paraneoplastic neuropathy. And suppose in those patients, we make a diagnosis of CADP and start them on steroids. And have you come across patients who later on go on to develop something later, like a cancer? What I'm trying to ask is, will the neuropathy predate the cancer? Would it be a paraneoplastic manifestation that we may miss and make a diagnosis of CAD?
Yes. Definitely, that's bound to happen. In fact, one recommendation is that in patients who don't have an obvious cause for neuropathy and who do not satisfy the criteria of CADP to the letter, it's better to reinvestigate them every year. Every year. So in those categories, where roughly we see that 20 to 30% of patients with neuropathy don't have any cause. We're able to detect a cause only in 60 to 70. So 20 to 30, that's an uncertain, unknown cause. That category should be investigated every year. The only thing is it's difficult to motivate the patient to undergo investigations every, because he says, I've already done all these tests, it was normal. So every year you should be actually reinvestigating them to pick up one of these causes, which may come up later. You're right, the neuropathy can predate the illness.
Sir, I have a question, sir. So thank you so much for the wonderful presentation, sir. My question is to Dr. AVS, sir. Sir, I have read in some articles and in Bradley's Neurology that CADP is common in insulin-dependent and non-insulin-dependent diabetes also. Is it true? Is it that much prevalent in diabetics? And what is the particular reason for, because AADP is not associated with diabetes, but CADP is more associated with diabetes. Is there any particular reason behind? Thank you.
I think this is probably the question of the day, because it's a very controversial topic. So basically, if you go by the definition, presence of diabetes would take it off the CADP, because CADP is basically, by definition, no known cause, no medical cause of neuropathy should be there, by definition. So if there is diabetes, it is not CADP. But then we get a lot of patients of CADP in a diabetic population. So why does this happen? So look, you have to look at this from two angles. One, a lot of diabetic patients may have independent CADP also, just by chance, just like you get, anybody can get CADP, and diabetic person is also getting CADP. And studies are there which showed that the percentage of CADP in diabetics is very high, higher than the normal population. So that is one aspect. Second thing is there a connection between diabetes and CADP? So that is the next aspect which is being studied. So as for now, what we can say is there is an association of diabetes and CADP. Now, how do you detect CADP in diabetes? Because diabetes also has different types of neuropathy. So you have different types, it's not a single type. So you have different types of neuropathy in CADP, and how do you recognize that this particular diabetic person with a neuropathy has CADP? So one very important thing is lack of, as I said earlier, clinical findings, lack of neuropathic pain, lack of small fiber symptoms, predominantly large fiber symptoms, sensory motor presentation. So that's one thing from the clinical. From the nerve conduction, demyelinating neuropathy. Diabetes generally has an axonal neuropathy. Very rare to get a purely demyelinating neuropathy in diabetes. You may get a mixed picture. So the common finding in electrophysiology is either axonal or axonal plus demyelination. But to get a predominant demyelinating picture in diabetes is very rare. Very rare. Some around 10% of diabetics may have that finding. So that is the category who may have CIDP with the diabetes. And the next thing is you look for CSF protein. If the CSF protein is more than 100 in a diabetic person, it's usually CADP. So these are the ways in which you can pick up CADP in diabetic. So one clinical, one nerve conduction showing poorly demyelinating, CSF protein greater than 100 in a diabetic person. because diabetes itself can cause a mild elevation of CSF protein. But if it goes above 100, CSF protein above 100 in a diabetic with a progressing neuropathy, probably there is CADP. So these are the small few ways in which you can pick up CADP in diabetes. But definitely there is a strong association of diabetes with the CADP. And they are now looking at the cause and effect. Like, is it just a chance, or is there a cause-effect relationship?
We can close this session. Once again, I thank all of you.
Thank you once again, dear esteemed speakers, for delivering your talks, and thank you to the chairpersons to have chaired the session. I now request Dr. Balaji sir to felicitate Dr. Balamurugan sir for his talk with a memento. Thank you, sir. I request Dr. M. Chandrasekhar sir to felicitate Dr. K. Mukundan sir for his talk. Thank you, sir. Now I request Dr. Balaji sir and Dr. M. Chandrasekhar sir to felicitate Dr. A.V. Subramaniam sir for his talk with a memento. Thank you, sir. I request Dr. A.V. Subramaniam sir to felicitate Dr. Balaji sir and Dr. M. Chandrasekhar sir for chairing their session. Thank you so much, sir. Now let's move on to the next session on COVID. I request Dr. D. Shivasubramaniam sir and Dr. Rajendran sir to chair this oration, and Dr. Prabhu sir also to please come on to the stage and take your seats for chairing the session.
Now we'll start the session with Professor S.K. Rajan oration. To deliver this oration, I request Dr. Dominic Rodriguez to come to the dais. He will be delivering today's oration, Scars of the Pandemic. I request Dr. Anita ma'am to take over the chairperson seat.
Now I request Dr. Rajendran sir to read the citation.
Dominic Rodriguez.
Dr. S.K. Rajan Memorial Oration has been instituted in honor of Professor S.K. Rajan, who was an eminent physician and pulmonologist in Chennai for more than 35 years. He was the professor and head of the Department of Internal Medicine and Dean of Stanley Medical College. He was also the Vice Chairman of API Chennai chapter. He was the founder chairman of City Physicians Association and decorated with Eminent Physician Award by Government of Tamil Nadu. He has contributed to Davidson's Textbook of Medicine as international advisor. The Association of Physicians of India, Tamil Nadu chapter, with great pleasure is pleased to award the prestigious Dr. S.K. Rajan Oration for the year 2022 to Dr. Dominic Rodriguez for his immense contribution to the field of medicine, and on 26 November 2022, Dr. G. Dominic has completed his MBBS in St. John's Medical College, Bangalore in 1988. He did MD in General Medicine in Kasturba Medical College, Bangalore in 1997. He has worked as physician at CSI Mission Hospital, Trichy, and as a senior consultant and physician at Kaveri Hospital, Trichy. He is a visiting physician and consultant at Ramakrishna Nursing Home, Stephen Nursing Home, Neuro Center, Joseph I Hospital Institute of Ophthalmology. He is a permanent member of IMA, API, ECG, Echo Club of Trichy and Diabetes Club. He has published 12 articles of various journals. He has received appreciation award for his exemplary services and support to IMA by IMA Trichy branch 2020. COVID Warrior Award by National IMA, November 21. He is the recipient of State President's Appreciation Award for exceptional COVID work by IMA Tamil Nadu State Branch 2021.
Congratulations.
I request Dr. Rajendran sir to felicitate Dr. Dominic sir with a shawl. I request Dr. Anika ma'am to present the certificate and the medal.
I am a proud student of Dr. S.K. Rajan in Stanley Medical College.
Thank you, sir.
Dr. Dominic Rodriguez, he doesn't need any introduction in Trichy. Well, this being a state conference, I would like to say that he has won many awards. As sir just introduced in the citation, he has been awarded the IMA Trichy Branch Appreciation Award for services and support to IMA in 2020 and the National COVID Award, COVID Warrior Award. When the COVID was at its peak, we were advising from the government, all senior doctors who are 50 plus, not to examine patients, just to sit back at home and relax, and the juniors would take care. But sir was at the forefront. He was a literal warrior, fighting in the forefront, leading by example. All his there are hundreds of his students. Sir has a big followers of DNB students also at Kaveri hospitals. Congratulate you, sir. And sir's always approachable by all his students, all the other colleague physicians, and his patients also. And he is patients personified. Congratulations to you, sir. and none other than Dominic sir could give such a topic. The stage is yours.
Thank you. Good morning, everyone. At the outset, I thank Dr. Seduraman, Chairman of the Tamil Nadu API, and Professor Anita Madam, and Dr. Muthamani, organizers of this conference, for giving me this esteemed topic. It's an honor for me. And also, I would like to highlight that I'm indeed grateful that I'm giving this oration in memory of Professor S.K. Rajan, who was an eminent physician and pulmonologist, and also the Dean of Stanley Medical College. Moving on to the topic outline is we are going to see scars of the pandemic. So, what is a scar? What is the evolution of different scars is in the acute and late phase? How to identify and manage the scar, and how to prevent a scar, and finally we'll see whether the scars are going to go away. So if you look at the definition of a scar in the Oxford Dictionary, it's a very classical definition. It's a mark left on the skin or within the body tissue, a wound, a burn, or a sore that has not healed completely, and with the development of fibrous connective tissue. It's an excellent definition. Merriam-Webster Dictionary says that it is a lasting moral and emotional injury. So we are going to approach this topic as a lasting moral and emotional injury. And to introduce the topic, the first 3 cases in India was reported in medical students returning from Wuhan to Kerala. So that was the one which started. And the first wave peaked in mid-September 2020. We started having cases from June and it peaked in mid-September 2020. And the second wave peaked in March 2021 with a massive increase in mortality and morbidity and the lack of oxygen and beds. And finally, the third wave, which struck us between January and March 2022 this year. So if you look at the cumulative data, this is the Indian incidence. So we had the incidence with the first wave, and then it rapidly increased in the second wave, and finally we have reached a peak. And also, if you look at the mortality, there was a mortality with the first wave, and then the second wave, and then the third wave. We'll go through this graph a little in detail later. What happened was that this first wave had a sort of a slow peak, and then it came down slowly. But when we were hit by the second wave, it came in a very rapid phase. So it was a very rapid rise in the number of cases, which started pushing the healthcare system into great jeopardy, because suddenly the patients were very sick and the hospitals were full and there was the oxygen shortage, everything. Then we had another large wave, there was a third wave, but fortunately you can see that the mortality was not so high in the third wave. So what happened was we had the second highest number of confirmed cases in the world, which amounted to about 4.5 crores of COVID-19 infection. And also the third highest number of COVID deaths, nearly 5,30,000 deaths. And the WHO estimated that there was a 4.7 million excess deaths. That is at least about eight times more deaths than what we recorded. So this was the real scenario, because we knew that the numbers reported were not really the same. There were 4.7 million excess deaths which occurred during this period, either both directly or indirectly related to COVID had taken place in India. And WHO also says that 80,000 to 180,000 health workers could have lost their lives due to COVID-19. And the second wave of COVID-19 is considered to be the worst tragedy since partition. Around 1 million people died during partition due to migration. At least we lost 500,000. Probably unaccountably we lost even more. So what was the moral and emotional injury? First was the loss of jobs, and there was a painful migration of laborers, which stands still in our memory. The saddest part was that these workers, when they went back to their hometowns, they were not even accepted in their hometown. They were rejected there also. That was a huge moral injury. The second thing was that the Delta variant, the second wave really hit us very hard. The Delta variant hit us very hard. And not only there was a COVID-associated mortality, there was a COVID-associated mucormycosis, which was causing a huge deal of problem. And there were more thromboembolic episodes. And suddenly, because the system was overwhelmed, and when we thought that the COVID has gone away, then we had a sudden shortage of oxygen, bed shortages, And we had antifungal shortages. We had no amphotericin B, nothing like that. So all sorts of things happened at the same time. So this was a bad scene that we were able to see, that this was happening in the ambulances. People were stuck in the ambulances. They were getting oxygen there. People were dying even before getting to the hospital. So this was a common scene during the peak of that time, and people were spending their time on the stretcher itself with oxygen, just needing oxygen in the hospital, and any makeshift bed in the hospital was occupied. So this was a terrible scene that happened during the second wave of COVID. And also it was painful to see patients having to be buried without having been shown to the relatives because of restrictions, and there was a mass burial, there was dumping in the rivers. So it's a very tragic sight which happened during the second wave of COVID. So these were all the emotional injuries. Not only that, you can see these two children, twins, and they lost both their parents due to the pandemic. And it's estimated by the Lancet that at least 17 lakh children were orphaned, either with one parent or both parents during the pandemic, even though the Indian government says it's only 1.53 lakhs. These are all huge moral and emotional injuries that we had to face. So the next step is, how did this scar come? How did it evolve in the acute phase and the late phase? So typically what was happening in COVID was, in the acute phase, we had an incubation phase, and then the first week was the viremic illness. And then in the second week, there was an immune phenomena was kicking in. So the people would become the one proportion, at least 40% of the people would become sick, and they'll start needing oxygen and becoming dyspneic. And in that, at least about 15% of them were becoming more sick, needing admissions, and 5% of them would become critically ill. So this was a scene which is happening. And slowly at the end of 14 days, with intervention, they will slowly recover, and then probably they'll recover by the end of 1 month. And I'm proud to say that our team from Trichy under Dr. Vivek Sundaram and Dr. S.P. Subramaniam, they published in the prestigious postgraduate medical journal. They described another entity called fulminant COVID, where the patient came, even in the first week, they became very sick, and they had a very bad course of illness, and they could die very early. So this was described by our team. I'm very proud of it. And what happened was, after the COVID was over, there was something called a post-COVID condition or a long COVID. So we expected the COVID symptoms to actually disappear by at least 2 months after the end of that 1 month period. So total 3 months period was taken as the time taken for the COVID to go away, but then patients continued to experience symptoms. That was taken as long COVID. So if you look at the timeline, so we expected the patients to recover by the 4th week or so. So the initial viremic phase, and then the test would become negative, and then in the meantime they would have had some illnesses due to either debility, the damage to the lung, damage to the brain, heart, or the thromboembolic episodes, the kidney injury or skin injury. So all this would have happened in the acute phase, and then some proportion of them would continue to have fatigue. They will continue to have dyspnea and cough, and some anxiety and depression and palpitations, and then thromboembolism in the long phase also, which if it had exceeded the 3-month period, that would have been taken as a long COVID symptoms. So mostly these patients went on to experience symptoms like up to the 6th month or so. So what is causing all this problem? Like, we can differentiate it into 3 phases. We had the acute infection phase, and like I told you, after the 7 days, there was the inflammatory phase, and then this was followed by a recovery phase. So what are the problems that were happening in the acute phase? The acute phase, probably most of them were receiving drugs either appropriately or inappropriately, which was causing by themselves, the drug was causing a problem. And also the acuteness of the organ damage, which is causing inflammation, and importantly the comorbidities. It was tragic to see a lot of renal failure patients who were undergoing dialysis. They were having the most severe disease, and those comorbidities like obesity, hypertension, they were all contributing to prolongation of symptoms. Then in the inflammatory phase itself, some patients went into hyperinflammation, cytokine storm. They had an altered immune status, which led them on the first phase. The first wave did not have much infection, but the second wave was terrible because we had the mucormycosis and secondary infections. And the inflammation contributed to prolonged symptoms. The third was the prolonged ICU and hospitalization in the sick patients themselves, and they had the psychological issues, which was contributing to the prolonged symptoms, and we can take it as the long COVID. So let us look at the different scars that were made, we are looking at it medically now, we are looking at the scars that were made on the lung. As you all know that the SARS-CoV-2 virus was targeting the ACE2 receptor, and then it was attaching to the ACE2 receptor, and then it was getting internalized. So when it got internalized, what you have left was there was an increase in the angiotensin 2 level which is circulating, and also there was simultaneously because of that there was an increase in the tumor growth factor beta level also which was increased in the blood. This led on to both myofibroblast activation and then extracellular matrix accumulation, which led on to lung fibrosis. On top of it, we must remember that these patients were also on ventilators. That led on to ventilator-associated lung injury, and also these patients were on oxygen, which led to oxygen-related side effects. So this all led to lung fibrosis. So there were three things which were possible to scar the lung. One was that the ground glass opacities turned into fibrosis, and then with time it was always healing. That was the most common scenario. We were seeing that most patients were healing their lungs. But there were a few who went on to have continuous fibrosis, and a very, very small population went to have worsening, most often due to related to infections, secondary infections like fungal infections. I will take you through one of our patients who had a very protracted stay, and also she had a very bad onset of the process. She had 100% involvement of both the lungs. She was a young lady, was a diabetic. She had 100% GGO involving both the lungs, and she was on continuous high FiO2 and NIV support. This was in July 2021. Over a period of time, she was started improving. You can see that there is a clearance of shadows. But unfortunately, in the third week, she developed a pneumomediastinum, which was causing a sudden worsening. So even through that, she came off. We used HFNO, and then she came out of it. Then again, in early October, she had another bout of worsening. This time, you can see the extensive shadows. This was due to a fungal infection. This was fungal infection due to aspergillus. We did a bronchoscopy, and we got the galactomannan positive. And after voriconazole, she eventually recovered, and we have sent her home with oxygen. And at the end of 1 year, she has returned back to her normal status with some residual changes in the upper lobe. So this was a protracted case, but most often what we saw was even when we sent patients home on oxygen, they all came back for first review without oxygen, and eventually they didn't even come back because they had recovered very nicely from COVID. This was the best part of the COVID. So the second thing that we had to watch out was sudden deterioration was in the third week. The patients who were sick and in the ventilator, they went on to develop a sudden worsening, and it turned out to be a pneumomediastinum or a pneumothorax. What was sad was in our own patients, we studied 2,440 patients, out of which it occurred in 11 patients, and we lost 50% of the patients. We had to lose 50% of the patients. It was a death sentence when we saw pneumomediastinum. So this complication we have to watch for in the third week, especially if the patient is on NIV support. So it has got a very high mortality. See, the next thing was the scars on the face. So this is a patient, as you can see, straight away you can recognize that this patient has developed a mucormycosis. So at least 15,000 patients had developed this new complication in the second wave. So in our experience, we had 74 patients who had either invasive fungal sinusitis that was seen between May and June 2021, and simply the presentation was very innocuous at times. They just complained of headache. One patient on round said that he has got slight numbness on the upper lip. That's all he complained. Some patients had just a bit of nasal discharge or a bloody discharge from the nose. But when we did the scan, we were surprised to find that they had already had a very highly invasive form of fungal infection, which needed immediate treatment. And the treatment was very radical and disfiguring. So these patients had to undergo orbital excenteration, they had to undergo a medial maxillectomy, and they were left with permanent scars. So you can see this patient who had undergone a maxillectomy, upper jaw, the teeth were removed with the bone, and he had to left with such a huge deformity. So these were the scars that were left on the face. And if you look at the scars on the vascular system, and it was found even in England that there was an excess of admissions. The excess of admissions in 2020 and 21, it just went up just like that. This was attributed to thromboembolic episodes. At least 268,000 patients had got admitted related to thromboembolic episodes. And not only that, in the community, you see that sudden spike. So at least a 30% spike in deaths in that period was attributed to COVID due to thromboembolic episodes. So this was happening in the community which we couldn't recognize. And the COVID-associated thrombosis was affecting any system. It was affecting the brain, it was causing a stroke, it was causing pulmonary embolism, it was causing MI, it was causing limb ischemia, and it was causing COVID dose. And our own patients, when we analyzed 33 patients, most of them were males. So it was typically the severe COVID was more in the males. And the males, 26 of them were males and 7 were females. And some of them had active COVID. During COVID itself, they had this problem, and some of them in the recovery phase. So we had to lose some patients, but at least heroic measures by our surgeons, by surgery, endovascular treatment or conservative treatment, they were able to salvage at least 50% of the patients, either lives or the limbs. So this was our story itself. The story in the community was even pathetic. And what were the scars on the cardiovascular system? This was the one which was most affected but least documented. What was happening was suddenly the regular follow-up was lost due to lockdowns. And also the patients with acute coronary syndrome did not go to hospitals due to the fear of COVID-19. And the interventions were greatly reduced all over the world. Suddenly you found that cath labs were empty. Nobody was going to the cath lab. Nobody was even going for an acute intervention, not leave alone chronic interventions. And the community events could not be identified because patients were not showing up. Yet there was an excess 30% deaths due to thrombosis. So this is the tragedy, that the patients could not go to the hospital and they were dying at home. So what are the problems affecting the CVS? There was a venous thrombosis, there was pulmonary thromboembolism, there was myocardial infarction, arrhythmias, myocardial injury due to myocarditis, all related in some way due to COVID, either due to immunothrombosis, reduced mobility, or just not reaching the hospital on time. All these things were contributing to this COVID-related mortality. So what are the scars in the nervous system? Again, the list is huge. It started with cerebrovascular disorders, complex memory disturbances, sleep disorders, and also musculoskeletal disorders, sensory disorders. What you will find surprisingly in this chart is that there are 3 groups which were identified. The first group is the group which was treated as outpatient. The second group was hospitalized, and the third group were become critically ill. So if you find that the way they recovered, you'll find that the patients who never went to hospital, they all recovered fast. But those who required hospitalization or those who became critically ill, typically they had a very long time to recover, and also they had a severe disease. So this was the problem with the CNS. So what was the scar on the immune system? This again is a very bad problem that happened with COVID. You know that any viral illness is going to do 2 things. For the virus to be successful to enter into your body, there are 2 things it has to do. It has to, 1, block your interferon system. The second thing is that it has to block your cytokine system. So if it blocks these 2 things, it is going to multiply in huge numbers. So that's what the virus was trying to do, but the SARS was different. What it was doing is it blocked the interferon, so it could multiply and enter the tissues, but at the same time, it just left the cytokine system. So suddenly you are having a cytokine storm. So the cytokine storm was going to come, the cytokines are going to cause a great deal of damage, and the damaged tissue, and through that the virus is multiplying. So you are having tissue damage and virus multiplication. So that was the problem with the COVID. So you would find that in COVID, there were several syndromes that was described. What was happening, especially in children, it was described in children. Most of the children would develop a normal immune response and then they will improve. But some children may go on to have a febrile, prolonged fever. So it is called a febrile inflammatory state. And the third group would develop a Kawasaki disease-like illness, and the fourth group would develop what is known as the multi-system inflammatory syndrome. Similar events are occurring in the adults also. This is the Kawasaki disease. What is happening in the immune system was in our patients was that there's a multi-system inflammatory syndrome in the children. In the adults, it could be a cytokine storm or a macrophage activation syndrome. And we were seeing more patients with this particular dangerous immune activation called the hemophagocytic lymphohistiocytosis. We documented 2 patients who had developed this problem where we had excluded most of the other diseases and everything. And finally, we had to say that these patients, they had very high titers of SARS-CoV-2 antibody, which led on to develop an immune activation system, and they had went to a terrible time. So is everything related to the COVID itself? If you look at it, it was associated to the vaccine also. The vaccine also had significant problems. We found myocarditis with mRNA vaccines affecting the younger people, and the thrombosis and thrombocytopenia, which is called the VITT. This is a devastating complication. We had 4 patients, out of which 1 patient we lost, and 3 patients somehow went through a tough time and had an orchidectomy because of testicular vein thrombosis, and then he finally he's recovered, and CVT also. So vaccines are not without complications. This could occur with vaccine also. So there are several syndromes that are described in the post-COVID period, at least 50 syndromes. It is exhausting, but the good thing is that by 6 months, most of them recover. So how do we evaluate and treat these patients? Evaluation is, we thought we would be having a lot of post-COVID patients, and we thought we'll be having clinics for that. But fortunately, we did not have great numbers. The main thing is to go by the symptoms, the cardiovascular system and the pulmonary system. We had to do the routine ECG, echo. And what was really helpful in these patients was to look at the D-dimer, NT-proBNP. The D-dimer, if it's elevated in a patient who has got dyspnea and normal CT, then you look for any thromboembolic episodes. If the NT-proBNP is elevated, when the CT is normal, you look for any diastolic dysfunction causing the problem. And if the patient complains of continuous fatigue and tiredness, you have to do a CPK to rule out any muscle disease. And also, don't miss out on a thyroid dysfunction, because thyroid dysfunction was also happening post-COVID, and that was causing a lot of fatigue and tiredness and tachycardia. And troponins to rule out myocarditis. So once we characterize what is the problem causing the symptoms, they had to go for either pulmonary rehabilitation, cardiovascular rehabilitation, or neuro rehabilitation. And fortunately, most of our patients recovered fast enough, and we did not have COVID clinics. So how do we prevent a scar? So preventing the scar, we must know what really predicted a bad severe illness. The vaccination status was one. Those who had received 3 doses of vaccine were relatively well protected compared to patients who did not receive the vaccine or got only 1 dose. And obesity, diabetes, hypertension, and CKD were very important comorbidities, and the number of comorbidities also mattered, because many comorbidities led on to severe illness. Immunosuppression, the strain of the virus, the alpha variant was good, the delta variant was very bad, the Omicron was very mild. So the most effective way to prevent the scars in COVID is to prevent COVID infection itself. That is the first thing. So face masking, social distancing, and hand hygiene and vaccination are still very important. But our Indian Prime Minister, under the leadership of the Indian Prime Minister, we had very good vaccine coverage. We had our indigenous vaccines, Covishield and Covaxin, and we were able to vaccinate all our healthcare workers in the first cycle, and then above 45. And we achieved a great deal. 250 million people are vaccinated, and it's a great successful vaccination story. And if you look at this is the second wave. If you look at the mortality in the second wave, this is the mortality which occurred during the peak of the wave. And if you look at this curve, this is the number of people who are actually saved because of the vaccine. And in the second wave, again, you see this huge proportion of people who are saved by the vaccine. And subsequently, this is how it works. But what we must remember is that the vaccine may not be effective further on. It has been effective up to Omicron, but after that, the strains which are coming now, probably they're not effective against the same vaccine. So in conclusion, why should we look back at the scars of the COVID? One is to review the extent of the damage of the pandemic created and learn pandemic preparedness. And second is to understand, track the capacity of the virus to mutate and evade the immune system. So this has been the most important thing. People have had COVID, they had recurrent COVID again. And to know the varying disease manifestations peculiar to each mutant strain. The first time we did not have any infection. Second time we had huge amount of COVID mucormycosis, COVID related. So each mutant strain was causing a problem. and to identify also the loss of vaccine effectiveness due to the new mutants. Then we must again promote vaccination awareness, having witnessed the important protective effects of COVID vaccination. So what should we be prepared for? We must be prepared for new disease manifestations. For example, the future effects of the damage of the immune system may not be evident now, but later on we may be seeing some cancers which are coming up, like for example, Burkitt's lymphoma, which went across Africa. So new mutants, the vaccines may be combined with the flu vaccine every year according to the new strains. And what we must still do is to continue face masking and social distancing, hand hygiene whenever it's appropriate. And this appears to be the only intervention that is safe and most effective. So finally, to conclude, do the scars go away? Yes, most of the scars go away. We see that in 6 months, most of the scars in the lung go away, leaving behind some amount of residual impairment, but that also goes with time when the conditioning improves. The static is very less common, and progressive fibrosis is very, very rare unless there is a underlying lung damage. So it is good. But unfortunately, there are some scars which will not go away. The scars on the heart, like a myocardial infarction that was sustained, or a stroke that was sustained during the COVID times, or a limb that was lost, this will not go away, unfortunately. So huge scars were made, but then compassionate medicine will always restore the patient's smile. These are our patients, and with God's help, we will prevail over COVID-19. Thank you.
Thank you, sir.
It's being an oration, there's no questions allowed. Thank you very much, Dr. Rudy.
Thank you, sir. For delivering the next talk in this session, I welcome Dr. T. Saravanan, sir, from Coimbatore to the dais to talk about the anticoagulation in COVID.
Very good morning to all of you, and should thank the organizers for this wonderful opportunity. Thank you, chairpersons. And I should thank Dr. Dominic sir for a wonderful presentation, making the impact of how the COVID has produced problem in the human being last 2 years or so. So what my presentation is going to be on anticoagulation in COVID-19 patients, an overview. Probably I would say like this topic may not be that much useful, because I hope and wish that we are not expecting such a severe pandemicity in the upcoming years. So it's only a probably. Please, sir.
Yeah, this Dr. Saravanan is working as professor and head of the Department of PhD Institute of Medical Science, Coimbatore. He is a chairman of the institution Clinical Audit Committee, the scientific coordinator of Coimbatore chapter of AP and EC member of state AP, life member of RSD, ISCCM, Hypertension Society of India, DFSI, awarded with the Best Teacher of the Year and Best Motivator Award. He authored 32 research publications in national and international journals, research guide for undergraduate and postgraduate medical students. Sir, I am from Karur. A lot of people know about you from Karur because of your service in COVID.
Thank you, sir. Thank you, ma'am. Let me continue with my presentation. So what I was talking about is the topic, the per se anticoagulation in COVID-19 patients may not be that much useful, I hope, because it should be only a scar what we faced. We don't want to face one more time this pandemicity. So what I'm going to do is in 15 minutes or so, my plan is to take you all through what really the reason for the coagulation cascade disturbance in COVID-19 patients, and showing some evidences for that, and how do we manage that, or how did we manage that. So as we all know that the first case of COVID-19 reported from China in 2019 end, And United Nations has called this as the worst global humanitarian crisis since World War II. And it's been noted that the elderly population with multiple comorbid illness like diabetes or hypertension or the cancer patients or chemotherapeutic agents exposed patients were at the risk of developing this infection. And it's been proposed that the weak immune mechanism along with cytokine storm, which is already highlighted by Dr. Dominic Sir, due to COVID-19 infection, one of the major reported causes of death in this population. And this COVID-19 and the comorbid illness, as he was highlighting now, the diabetes population is prone to develop this or succumb to this infection, along with multiple the comorbid illness like the heart failure patients, renal failure patients, or patients with cancer disease or the chemotherapeutic agents exposed patients were at the risk of developing serious illness. Most probably we defined it as critically ill or acutely ill patients warranting intensive care therapy. And as we all know that the viral infection per se is having the tendency to produce some sort of thrombotic episodes, it's more applicable to COVID-19 patients. And SARS-CoV-2 infection is that's a production of cytokine storm already highlighted by the previous speaker. I'll just try to highlight in the next slide how it's going to produce this thrombogenicity in the body system. We all know that the COVID-19 is a spiked protein virus, and the S1 component of this spike enters through the two pathways, TMPRSS2 pathway as well as our receptors, as well as the ACE2 receptor, or transmembrane receptor, and it undergoes inside the human being host cell, that is most probably the monocytes, and starts producing through its the effect on the nucleus of the host cell, and it's producing more amount of FGF, that's fibroblast growth factor or PLA2, or can also have effect on the bypassing the nuclear pathway, can produce more amount of TLR9 receptor or the factors, that is toll-like receptor factors, which can finally land up with increasing the stimulation of the inflammatory factors like IL-6 or IL-12 or TNF, and which can lead on to inflammation along with probably platelet activation. Interestingly here, the COVID-19, apart from this effect on the monocytes, it also has got direct effect on the platelets, and through its thromboxane A2 pathway, which can stimulate or increases the fibrinogen, as well as the serine protease enzymes are stimulated by this pathway, as well as it increases the platelet aggregation as well as vasoconstriction. Through this serine protease pathway, probably it stimulates the intrinsic the pathway of the coagulation cascade, along with the combined pathway, which can lead on to excessive clotting tendency in the human being, especially when they succumb to a critical type of illness, which can lead on to different parts of the body being involved, starting from, as already highlighted by the previous speaker, central nervous system, pulmonary circulation, or gastrointestinal tract, or even the peripheral vascular system. Very rarely it involves the direct involvement of the cardiovascular or coronary circulation. There are few evidences available last 2 years or so, the publications related to the thrombogenicity of the virus per se, as well as few evidences available in the research or in the literature related to the few of the markers as already highlighted by the previous speaker, especially the D-dimer, or you can say like related to the clotting cascade disturbance, platelet count, or prothrombin time, or APTT, or even the fibrinogen levels. So these are the few evidences available in the literature related to the markers can be used as a guiding tool to diagnose as well as for the treatment point of view. If you see the thrombotic complications, majority of the patients are having the macrovascular complications or macrothrombotic episodes, and nearly 30% of the people of the COVID infection affected patients developing these macrovascular complications, and mainly in the form of venous thromboembolism, and nearly 30% of people requiring intensive care. So I'd like to highlight here that most of the patients COVID-19 infections, those who have got the critically ill or acute ill patients, That is 30% of the people succumb to these thrombotic or macrothrombotic occlusions. It is not only that, it also leads to microthrombotic episodes, most commonly the TMAs, that is thrombotic microangiopathies, as well as it also can lead on to intravascular disseminated coagulation abnormality. And how do we go about with the diagnosis of this problem? I said that 30% of the acutely ill or critically ill patients, it's very important that since there are so many postgraduates, it's a very, very basic clinical subject or clinical point. The clinical judgment is very, very important. It is not guided by your investigations. It's only to add value to your clinical judgment of your basic assessment. So it's very basic important thing is here to just clinically make your judgment, followed by the basic blood investigations, that is as already mentioned, that D-dimer, fibrinogen levels, or platelet count, prothrombin time, or APTT values, along with imaging modalities will add value to your clinical assessment as well as the judgment of that we are dealing with macrothrombotic complications. It is not only that, the patient has to be stratified before subjecting the patient for imaging modalities. So every investigation has got its own cost as well as the adverse effect. It's very important clinical judgment, risk stratification, followed by blood investigations. I would like to make highlighting a point on the D-dimer. The D-dimer per se, if you see, has got a tricky value interpretation in the COVID-19 patients. More specifically, if you see, it has got the what do you call that, low false negative rate in the COVID-19 patients. Basically, the meaning of that statement is certain percentage of the patients of COVID-19 noted to have elevated D-dimer without much evidence for clotting cascade abnormalities. But when you note a normal values, probably you can say probably you're not dealing with thrombotic episodes, but caution with a clinical judgment, because that's the meaning of low false negative rate. Elevated value doesn't mean that you are dealing with, but if it's going to be normal value, clinical judgment also tells you that, not only that, risk stratification also tells you that you are not dealing with high index of suspicion of thrombotic episodes. Definitely the D-dimer is going to take a important value. And if you see the different parts of the body involved because of this clotting tendency or the cascade disturbance, the most common involved was the pulmonary embolism, followed by the cerebrovascular as well as the peripheral vascular occlusion and gastrointestinal tract. As I was mentioning, it's the least possibility to have coronary circulation involvement, direct involvement. And definitely the question comes, if we are dealing with the problem of clotting tendency, what is the role of anticoagulation? Yes, very important point here is the coagulopathy disturbance in the COVID-19 patients is being shown to have under the prognostic factors wise, it is carrying a poor prognostic value. And anticoagulation definitely playing an important role with the limitations, meaning that most of the patients, those who are requiring intensive care, that is critically ill or acutely ill patients, most of the time they'll be requiring after clinical judgment, guided by blood and imaging modalities along with risk stratification, you are justified to use anticoagulation, which has shown definitely 30-day mortality is brought down by the appropriate usage of anticoagulation, not at the cost of excessive bleeding. It also once again clearly tells you the evidence for anticoagulation therapy. Nearly 30% of patients decreased risk of death because of appropriate judicious usage of anticoagulation in the COVID-19 patients affected with macrovascular complications. And what is the evidence for that, and as well as guidelines regarding this anticoagulation therapy? If you take any forum in the international society, like you can say like Anticoagulation Forum or the American Society of Hematology or Chest Physician Forum or CDC or NIH or ACC, you take any higher bodies guiding us how to manage a patient with a specific disease, more specifically or precisely here the clotting tendency, it all clearly gives you an idea that we need to put the patient on anticoagulation therapy only if the person is being assessed properly, both clinical judgment, risk stratification, investigations in the form of blood and imaging modalities. Definitely, that is nearly 30% of the people of COVID-19 affected patients requiring intensive care, what we called as the critically ill or acutely ill patients, mostly they'll be requiring anticoagulation therapy. So different types of molecules or the class of molecules being used as a therapeutic for the anticoagulation. We call it as three category of anticoagulation therapy. One is the standard prophylactic anticoagulation. Number two is going to be intermediate prophylactic therapy. And third one is going to be therapeutic dosage of anticoagulation. We usually prefer to go for as an anticoagulation, the low molecular heparin or the unfractionated heparin, most probably with the patient having renal impairment with a creatinine clearance of less than 30 ml per minute, we go for unfractionated heparin. This is what I was trying to highlight. Most of the patients with a critically ill or acutely ill requiring anticoagulation therapy, but with a caution after proper assessment, both clinically and investigations wise with a proper risk stratification. So just it's a small flow chart which is giving a clear idea about how to go about the patient with the COVID-19. When we suspect that we are dealing with COVID-19 related thrombotic episodes, probably the major complications in the form of acute stroke or pulmonary embolism, or you come across it with the coronary event, myocardial infarction, probably very less percent of the patients will be requiring the thrombolytic therapy. Whereas the most of the patients requiring intensive care, the critically ill patients will be requiring anticoagulation therapy, and it's in the form of low molecular heparin or unfractionated heparin, depends on the clinical scenario. The another scenario we come across is patient is already on anticoagulation. So how do we go about if they get this COVID-19 infection? It very clearly tells us that the person is having walk-in patients to the clinic and treated as an outpatient, or the patient is having mild to moderate disease not requiring intensive care therapy, or we are not able to coin them as a critically ill or acutely ill patients, definitely those patients can be continued with usual dosage of anticoagulation for the primary disease for which they started. We can continue with that. There is no need for any escalation of the dosage. Whereas these patients already on anticoagulation for different disease, if they succumb to this critically ill disease of nature of the COVID-19, definitely we should think about and escalate the anticoagulation. The person is already on standard prophylactic dosage. What I meant by the standard prophylactic dosage is equivalent to low molecular heparin of 40 milligram of enoxaparin once daily, whereas intermediate dosage is going to be 1 milligram per kg body weight in a divided dose per day, and you can escalate the dosage based on the weight of the patient. Twice daily, the person is really requiring therapeutic dosage of the anticoagulation. So the person is going to be already on anticoagulation for different disease problem, and if they come across with COVID-19 requiring intensive care, it's a high time for us to escalate the anticoagulation based on the requirement. Definitely in the form of whatever the medications I mentioned about the low molecular heparin or the unfractionated heparin. So naturally the question comes, once we manage the patient in the intensive care, we are planning for discharge. Should we discharge the patient with or without anticoagulation as an outpatient follow-up? It all depends on the risk stratification of the patient. The person has been stratified that they are prone for high thrombotic episodes in the future. Definitely the patient has to be on 3 months to 6 months duration of oral anticoagulation. It's very important that from the initial investigations, it's very clear evidence of thrombotic episodes, especially for example, the pulmonary embolism or major vascular occlusions, proximal venous thrombosis or arterial occlusions patient has developed. Definitely the patient has to be on oral anticoagulation post discharge at least minimum for 3 months duration if they are not falling into high thrombotic category. the same type of information or same information is replicated here in this flow chart. So the medications which I was trying to highlight, low multiheparin, the different molecules can be used maybe in the form of enoxaparin or dalteparin or nadraparin or tenzaparin. And the unfractionated heparin is used only for the patient, those who are having the renal impairment where we cannot use this low multiheparin can be subjected with unfractionated heparin. The outpatient thromboprophylaxis, which I was just now highlighting about, only evidence of the thrombosis, major vascular occlusions at the time of discharge needs to be put on oral anticoagulation, minimum of 3 to 6 months duration. The person is having a major critical illness at the time of admission. Risk stratification tells you that you are dealing with a high prothrombotic status. Probably I would say like the patient's on hormonal pills, or the person is having the cancer or post-chemotherapeutic agents exposure. They're all prone to develop high thrombotic episodes. In those category of patients, probably patient might require post-discharge anticoagulation therapy. It's very important, as I was highlighting in my presentation regarding the limitation of the D-dimer. The D-dimer should not be used as a routine post-discharge follow-up investigation tool to get guiding you regarding the duration of the anticoagulation therapy. And I think that's all in this slide. Yeah, I think I've come to my end of my presentation. So summarizing my total presentation, last 15 minutes or so, it's a weak immune mechanism along with the cytokine storm due to the COVID-19 infection is one of the major reported causes of death, and the resultant high levels of the inflammation due to this cytokine storm is associated with coagulation complications in different parts of the body. And prophylactic anticoagulation is suggested patients admitted with COVID-19 to prevent thromboembolism. Probably if the person is being stratified as high tendency to develop thrombotic episodes or demonstrable proximal occlusive disease in the investigations wise, definitely they should be put on oral anticoagulation post-discharge. And the drugs wise oral anticoagulation is concerned, probably the Novak is going to be superior over the vitamin K conventional antagonist because of some reasons like the hepatic impairment or renal impairment. There may not be that much of issue with Novak. Number two, it's going to be the interaction with the antiviral therapy or whatever the therapy used for the viral infection may not be having interactions with the Novak therapy. So based on these two reasons, we prefer to go for Novak therapy than conventional vitamin K antagonist. With this, I'll conclude my presentation. Once again, thank the organizers and for the patient listening of the audience. Thank you.
Thank you, sir, for throwing much light on a very important and a very concurrent topic. Now, the floor is open for discussion.
No questions?
In present times, in the present epidemic, few cases are coming in, sir. Are you prescribing any anticoagulation for them to discharge?
It's only the same protocol that we follow at present also, sir. Based on the risk stratification as well as the imaging is going to help us. Then we are guiding start the patient on anticoagulation. And one more point I want to highlight that Dominic sir was mentioning about HLH. Recently, week ago or 10 days ago, we came across a patient with the COVID-19 infection with 2 cases, with very high antibodies and developed HLH, and we lost both the patients. Because of the persistent severe cytopenias, we could not proceed with the important protocol of HLH 2004 protocol. We could not follow, especially using of these chemotherapeutic agents. But still, the effect of COVID is still not gone away from our human race. We should be always very careful about the impact of COVID-19. The anticoagulation is concerned, still we follow the same protocols. We don't underestimate the intensity of the COVID-19 till date.
Thank you, sir.
Thank you, sir. Acceptable, sir. Definitely it's correct, sir. But even then, what I'm trying to highlight is there is no specific markers. It's only the risk stratification. It's available everywhere. The international guidelines everywhere is available. The risk stratify the patient, clinical examination along with the investigations of blood and imaging if required. Then you can think about anticoagulation. Definitely the intensity has come down. Acceptable, sir. Correct. Yes, sir. Those patients, definitely the D-dimer is not going to guide you, number one. Number two, anticoagulation may not be recurring those patients. Unnecessary anticoagulations to be avoided. Only in critically ill patients. Till now, we are seeing randomly one or two patients here and there. The critically ill patients, those who are really recurring oxygen supply, recurring ventilator support, recurring renal replacement therapy, recurring hemodynamic support. Definitely those type of patients really recurring this type of anticoagulation. It is not in all cases which we used to do in the phase 1 and phase 2 of the illness.
So, have you noticed any complications because of anticoagulation therapy in these patients?
Usually we don't see that. We don't see. It's only the judicious usage of the dosage will definitely reduce the complications, except for one or two cases which we have come across is thrombocytopenia, especially with unfractioned heparin. We do come across, but it's not very much sinister. We'll go for fondaparinase like drugs to avoid the unfractioned heparin related thrombocytopenia.
Thank you, sir.
Thank you.
Any
Thank
more
you.
questions? I think we
Thank
can
you,
close
sir.
this session.
I request Dr. Rajendran sir to felicitate Dr. T. Saravanan sir for his talk. I also request Dr. Saravanan sir to felicitate Dr. Rajendran sir for chairing the session. I request Saravanan sir to felicitate Dr. Anita ma'am. For the next section, now I request Dr. Gurumurthy sir and Dr. Vetrivel sir to come on to the dais to chair the session.
The topic for the next session will be management of hypertension in young. I request Dr. Chandani ma'am to come to the dais.
I now request the chairperson to introduce the speaker.
Good morning, everybody. Hypertension and diabetes rules the globe. The two twin epidemics, by the way of complications like coronary disease, cerebral vascular disease, and end-stage renal disease, produces havoc, and we are compelled to discuss on this Augustus forum about this hypertension in special populations. Today we are having our professor Dr. Santini Radhakrishnan to discuss on the hot topic of management of hypertension in young population. Professor Santini is a HOD of medicine and emergency medicine in Government Medical College, Kozhikode, Kerala. She has got Best Teacher Award in 2019, Master Teacher Award in 2021, Kairali TV Best Doctor Award, Government Sector 2022. She is the recipient of Fellowship of International Medical Sciences Academy 2015, FICP 2016, FRCP Edinburgh 2016, and FIMS 2017. Present organization responsibilities: she is the chairperson of RSS DI Kerala chapter, vice president of API Kerala chapter, member of Board of Studies Medicine, postgraduate member of Faculty Medicine. She has got lot of publications and she has presented several lectures in the national and international forum. And let us hear from Professor Dr. Chandini Radhakrishnan, please.
Respected chairpersons, Gurumurthy sir and Vichvel sir, dear senior members and friends. I know I'm chanting between you and lunch. I'll be taking you through a very important topic and very interesting topic to discuss, because there is a lot of things that we can do as a physician in the clinical examination part when a young patient comes to us with hypertension. So we'll be discussing, of course, management of hypertension in young. And I'm very thankful to the Tamil Nadu API for giving me this opportunity to present this topic before you. We know that hypertension per se is increasing in India. And we also know that most of the states and the nation as such is slowly coming down the screening age for hypertension. And we have started screening in 18 or above for hypertension as well as diabetes, because most of the younger people are getting affected with these two important diseases. And as we all know, being identified as silent killer, recognizing it early, we get a lot of opportunity for treating these patients, for preventing the risk factors in this group of patients so that the comorbidities and risks can be avoided in the future. And one of the study has shown that it is affecting 1 in 8 adults aged between 20 and 40 years. Stage 2 hypertension before 40 years was diagnosed with a significantly higher risk for all-cause mortality. Increased arterial stiffness due to renin-angiotensin-aldosterone system activation and sympathetic nervous system overactivity due to stress have been implicated as primary factors in hypertension in young, and this point actually helps us in approaching what will be the best drug in this group of patients to initiate. When we talk of hypertension in children less than 13 years old, the definition is based upon blood pressure, percentile based on the age, gender, height. So we have to see the chart, then that we can help us to decide what is the cutoff in children less than 13 years of age. But above or equal to 13 years old, the definition is aligned with adult guidelines. So the recording, documentation and cutoff all will be as per the adult guidelines. So why this is important? Because the recording and the diagnosis of elevated blood pressure is very important as far as the management is considered. So we need to have the recommended dimensions for blood pressure cuff in this situation, especially in children and small adult and young adults. We have to use the appropriate BP cutoff for the bladders for using the documentation of the blood pressure. Otherwise, we may get an erroneously high or low blood pressure, and that might give or may include a patient having hypertension. So this has to be calculated as per the largest arm size, and it would encircle at least 80% of the arm to get the best blood pressure recording. What are the risk factors for hypertension in young? We have listened to two very important sessions on COVID, and we have lived through a pandemic. And we have learned a lot during the pandemic than we might have learned during our entire medical education. But as the previous speakers promptly highlighted, we have lost the grip on some of the important comorbidities and many things that we should have been doing on a regular basis. And when we look at the risk factors for hypertension in young, that will definitely help us in managing these cases and preventing these cases as well. The top three were smoking, mental stress, and obesity. And it is interesting to see that these three are actually very much preventable. And the other risk factors identified were high salt intake, increased alcohol intake, sedentary lifestyle, and lack of adequate sleep. We know that this is there among our youngsters, and these are the preventable factors. And this is as per a study done in India, hypertension in young adults in India, perspective and therapeutic options amongst clinicians in a cross-section observation study. This has very clearly pointed out these are the factors that are leading our young into hypertension. And it is also very clear, we all know that how to prevent it, and it is possible to prevent this. When we approach a young patient or young person coming with high blood pressure, the important task as a clinician we need to do is try to differentiate whether it is actually a primary hypertension or secondary hypertension. And if we do a good clinical examination, we are all trained for that, it is usually easy to differentiate at bedside itself. We know that an obese person, overweight person with strong family history of hypertension in the post-pubertal age, with some of the criteria of metabolic syndrome like increased waist circumference, coming with high blood pressure, most of the time he will be asymptomatic unless there is some of the complications has not developed related to hypertension. We know that this is going to be into the category of primary hypertension. But in the pre-pubertal age, or in a patient having diastolic hypertension, or if there is fluctuating blood pressure and we are doing an ambulatory blood pressure monitoring and it is very clearly showing there is no nocturnal dipping, there is a nocturnal elevated blood pressure, we need to be suspicious. Is it something different than the usual primary hypertension that we are dealing with? And in patients, usually there won't be any family history, but in autosomal dominant polycystic kidney disease, we may be very clearly getting a history of disease in one of the family members as well. That gives us a clue that we need to examine this patient for abdominal swellings. And always we will be getting symptoms related to the underlying cause or what is the secondary cause that has led to the hypertension. And as I have already highlighted, in children with hypertension, we need to have the diagnosis of hypertension. This is for true for everyone. We need to record the blood pressure as per the guidelines. And we need to repeat the blood pressure, and we need to ensure that the patient has at least two values consistently with elevated blood pressure to diagnose as hypertension. And the next task is to examine in detail to distinguish between primary and secondary hypertension. And if we could identify any secondary cause of hypertension, we need to identify whether there are any treatable cause for hypertension, because some of the secondary causes, if we treat correctly and timely, the patient may be able to discontinue antihypertensive medication. And as well, we have to assess all the traditional and risk factors for atherosclerotic cardiovascular diseases like related to hypertension, diabetes, as well as the modifiable risk factors like smoking, alcoholism. All these have to be looked for and documented, and intervention has to be started, and we have to plan appropriate treatment. So that means a patient coming to us with high blood pressure or referred to us for management of blood pressure, more than writing an antihypertensive medication, we need to do a lot so that the patient will have good control of hypertension and patient will be motivated to avoid the risk factors or reduce the risk factors as much as possible, and patient will come to us for monitoring. Symptoms of hypertension. Usually we don't see any symptoms in hypertension unless there is a complication like hypertensive emergency or urgency. They don't come to us with symptoms. And that is the most important factor, that we have to record blood pressure. Nowadays, most of the laboratories are ready to get the blood pressure monitoring done, but we all know that most of the time it's not recorded. It's just writing a value like 120/80. So we have to be convinced with the our clinic based blood pressure recording, either we ourselves will do or somebody who is actually trained in recording the blood pressure. That is the importance of measurement of blood pressure. And what are the risk factors? What are the symptoms that we must be aware of, that we have to see more carefully in those patients with regard to management include headache, vomiting, seizures, focal neurological complaints, change in mental status, visual disturbances, cardiovascular complications like heart failure, chest pain, palpitations, cough, shortness of breath. And most of the time, when a young adult or a child comes with blood pressure, it is also usual that the child or the young adult might have gone from one clinician to second and third, because usually blood pressure is not very seriously considered as a vital, though it is considered as the most important vital. So we miss the diagnosis of hypertension. But we will get time to repeat the test, we will get time to manage the patient on a repeated visit, ensuring and confirming the diagnosis. But in children with hypertensive emergencies, we need to require pharmacologic therapy without delay and hospitalization for evaluation and ongoing care. And we know that acute nephritis and other situations where the child comes with hypertensive encephalopathy. Other important area we will get an opportunity to modify is always the drug history. There are drugs like corticosteroids, non-steroidal anti-inflammatory drugs causing sodium retention, sympathomimetic drugs, direct vasoconstrictors, estrogen and oral contraceptive pills. Drug withdrawal could be antihypertensive drugs or drug interactions, and herbal supplements. We should not forget, we have to ask any new medication. They may not consider it as a medication at all, has caused this increase in blood pressure. So this means that we have to have a detailed physical examination in all young hypertensives, including palpation of all the peripheral pulses, which cannot be overemphasized, and most of the diagnosis is made at the bedside, and we need to decide what are the investigations we need to plan in every patient, because we cannot order a battery of tests that will not give us a clear-cut diagnosis as well. The other important examination might be the ophthalmologic examination, where we will be able to see arteriolar AV nipping, hemorrhages, exudates, papilledema, and that will help us to decide whether the hypertensive retinopathy is mild, moderate, severe as per the fundoscopic findings. So once we decided whether the patient is having a primary hypertension or secondary hypertension, we need to plan. But the antihypertensive medications and the protocols and guidelines are the same, whether it's in a young or old patient with hypertension, unless there we consider the associated problems or compelling reasons that we choose hypertensive drug in a particular situation. But once we diagnose it as secondary hypertension, those most important point that I would like to highlight is only a small minority of patients are actually coming to the secondary hypertension group. And in that group, if we could correct the cause for hypertension, that may cure the hypertension and may provide insight into the etiology of primary hypertension. That is one important point. If we really study all the secondary hypertension patients and we understand why they develop hypertension, that will help us to identify the mechanisms of pathophysiology in primary, and we may get more insight into management of primary hypertension as well. So which are the secondary hypertension causes that will give us an opportunity to intervene? Some diseases, as we all know, thyromegaly may give clinical examination findings suggestive of hypo or hypothyroidism. Acromegaly, Cushing syndrome, facial plethora, it could be due to polycythemia, excess alcohol, xanthomas, xanthelasmas, nicotine staining. All these will give some important clues with regard to clinical hypertension. And the clinical clues might be intermittent sweating, anxiety, pallor, or weight loss, suggestive of pheochromocytoma. Tachycardia could be due to anxiety as well as hypothyroidism. Hypokalemia with episodic weakness, Corn syndrome or primary hyperaldosteronism, we all might have got interesting stories where they say that their tiredness goes away with fruit juices. So most of the time patient gives the diagnosis from the history itself. Abdominal mass. So we cannot leave a patient just by examining the blood pressure, documenting and starting treatment. We need, at least on first visit, we need to have a detailed, complete physical examination. Renal bruit, and it is very much known that the first presentation of renal artery stenosis may be like flash pulmonary edema. When to suspect renovascular hypertension? There are very many clear indications or situation other than flash pulmonary edema as well to diagnose or to identify this patient could be having renal artery hypertension, like age of hypertension less than 30 years or more than 40 on the extremes. Not in the usual age group of primary or essential hypertension. Abrupt onset high blood pressure. Acceleration of previously well-controlled hypertension happens in atherosclerotic renovascular disease. Refractory hypertension, where we are not able to control the blood pressure even at the optimizing the dose with 3 antihypertensive drugs, of which one is actually a diuretic. Hypertensive retinopathy worsening, hypertensive urgency or emergency hospitalization, systolic, diastolic, abdominal bruit, flash pulmonary edema, evidence of generalized atherosclerosis, and asymmetry of renal size on imaging studies, acute kidney failure on treatment with AC inhibitor or ARB. So we have very important clues, clinical clues that we can use to suspect or which are the patients should be going for evaluation of renal artery stenosis. And in young females, other important entity is fibromuscular dysplasia. It's less than 10% of all renovascular hypertension, but it happens in younger women. The classical description is beaded appearance on angiography. And among patients with fibromuscular dysplasia, the important point is if we make the diagnosis timely, we can do the percutaneous angioplasty, and most of the time it cures up to 50% and improves in 42%, and some may they develop a recurrence later, but definitely it gives a reduction in the antihypertensive medication, sometimes stoppage of antihypertensive medication if we could identify and do the procedure timely. Another point where we can do real management is sleep apnea. Sleep apneas in patients with interrupted sleep, snoring, daytime somnolence, fatigue, morning confusion, obesity. This is a very important described comorbidity with obstructive sleep apnea syndrome. And weight gain and the being at home, and most of us are working from home because of the pandemic, and that has given lot of opportunity to gain weight, and that has created lack of physical activity and excess food. And this is going to be a more challenging problem in the coming years, because managing obesity and diet and lifestyle intervention is really, really challenging to advise as well as to practice. Another area it's quite challenging and difficult is hypertensive disorders of pregnancy. So we have to know what are they and how best we can manage this. We know that in patients coming to us with less than 20 weeks of gestation, they could be normotensive or they could be hypertensive. If they come with hypertension at that point, we have to understand that this patient, as in diabetes, if I has a high HbA1c in the first trimester, we think this patient is having a pre-existing hypertension, pre-existing diabetes. So we need to screen every patient, every person with pregnant coming to us, because that is the most important time where we can decide whether this person is actually having a pre-existing hypertension. So blood pressure documentation is very important. After 20 weeks of gestation, if the person has got proteinuria and during postpartum, the proteinuria disappears, we include them in the preeclampsia group. But if the person has got hypertension and no proteinuria and resolution of hypertension, it could be transient hypertension of pregnancy. And if the person has no proteinuria with hypertension and the persistence of hypertension after pregnancy, it could be chronic hypertension detected for the first time during pregnancy. And in chronic hypertension, if the person develops proteinuria while on hypertension, we know that there is preeclampsia superimposed and persistent hypertension that we have to monitor and follow up these patients. So the correct diagnosis, whether the patient has got pre-existing hypertension or preeclampsia, will be decided only after 12 weeks postpartum. And these are the important clinical clues. We know that these are some of the points. This is the malar rash. We have the facial puffiness and typical systemic sclerosis, nose, neurofibromatosis, pallor, acanthosis nigricans, Cushing syndrome, and as I have shown, the retinal papilledema, flame-shaped hemorrhages, exudates of hypertensive retinopathy. Basic investigation we have to do in every patient, and some of the important ones will be serum potassium and renal function tests, and we have to get a basic ECG, echo, ultrasound abdomen, and renal Doppler if the person is young, and we have to have a resting electrocardiogram. And some of the important clinical clues will be the plasma levels of hormones where we suspect this, and the management includes lifestyle modification, excess alcohol used to be curtailed, contribute to resistant hypertension, smoking cessation, salt intake, and stress reduction and relaxation technique. And this is one entity I have already percutaneous renal artery stenosis. We can do the stenting, and that will actually clear the disease, or we can reduce the drug. As we said, it's not enough for the physician to do what is necessary, but the patient and the attendants must do their part as well, and circumstances must be favorable. So we have to treat the patient and not the number. Do not treat on the basis of isolated high reading. Meticulous clinical assessment is always important, and extensive laboratory and imaging evaluation for secondary cause of hypertension is not routinely indicated if no clinical clues are available. So we have to see in these cases if there is a refractory BP control or a definite clinical clues. Thank you for the patient discussion.
Thank you, madam. You very well explained about the young hypertensive in detail. I want to mention 1 in 8 people are affected. I want to mention two things here. The young hypertensive may progress to further into the complications, mainly cardiovascular, cardiac failure, coronary artery disease, and also prone for CVA. These are two complications which occurs in the middle age. Normally it occurs in the old age, but here if the young fellow is affected, he is vulnerable to get it in the middle age, which is a lifelong threat for him. Another one for particularly for women, it is the pregnancy in diabetes like that. Hypertension in diabetes in young women may result in miscarriage and other problems during delivery. So that is the importance of the PAH. These are two things I want to highlight. Otherwise, other treatment for hypertension is the routine. Thank you very much.
Thank you.
Doctor. Thank you very much.
Thank you, ma'am, for a vivid narration on the subject. Actually, the time will not be sufficient to cover such a wonderful topic. Which this condition is deliberately overlooked and underlined. That's an important concept of management of hypertension in the young. Warrants lot of discussion because you all know there is a community of young population which is about 27 million Indians are suffering from this disorder. Taken to India is having majority of young people because of so many things, because the young generation not having awareness about this condition, and the treatment and control also is difficult, and also scant information available on this subject. We have to recall the CSI chapter of Kerala, in their CSI Kerala coronary risk factor prevention trial, they have openly conducted a trial involving about more than 5,000 people, in which all the deliberated matters have been contained in the study. But one has to see the ground reality, the young generation, because of the risky behaviors like alcoholism, nicotine misuse, and energy drink misuse, and the sedentary life, the people are immovable because of their psychosocial factors. Not there. When we advocate the physical activity of 30 to 40 minutes by the stipulated guidelines, but one has to see they are spending more than 2 hours sedentary hours, which we call it as screen time. So not only we have to advise to do the physical activity, but also to shorten the screen time of 2 hours. People in IT sector and other modern jobs, they are always sitting and immobile. That is the culprit for accumulation of the abdominal fat, which is very highly risky fat. So, as Madam told, it is the abdominal obesity and the sedentary life, sugary food, salty food, the fast food culture, which contains Ajinomoto like anything, the monosodium glutamate, and other, they are not taking fibers at all. Lack of fiber food, sugary, salty, saturated fast food, these are the lifestyle, unwanted lifestyle measures which accounts for their contribution to the involvement of the young hypertension, which is going to lead subclinical organ damage, which they are not aware. Silent killer is hypertension. It is more suitable for the young hypertension. Madam, I like to know from you how much percentage of isolated systolic hypertension, which is pertinent to older individuals, how many percentage of isolated systolic hypertension occurs in this young age?
Actually, I couldn't find any study, but what they were mentioning is about diastolic hypertension, not about isolated systolic hypertension in young. So maybe we have to, as you rightly pointed out, we have to come up with the data of our own people.
One study done by a northern professor, Jamjet Dalal, he has told there's about 20% of people in young age having isolated systolic hypertension, because he underlines whenever any young person is having persistent sinus tachycardia and abdominal viscera, it's going to have a cluster of risk factors, which is going to be blown or Ravens or metabolic syndrome in future. But they found out brachial and aortic artery pulse wave amplitude is more in young age. In old age, it is aortic stiffness, as you know, contributes to isolated systolic hypertension. The isolated systolic hypertension in young age is going to more work on the cardiovascular sector and stroke sector. Yes.
Yes, thank you.
Any questions in the floor? Yes.
Study about mobile abuse and hypertension, and you got the late night sleep. And one more thing is you said about the obstructive sleep apnea.
Yeah.
It is actually the sleep on snoring. Everybody think that snoring is we are sleeping very nicely with making a loud noise and we are sleeping very deeply. But unfortunately, the obstructive sleep apnea is a hidden area, and there is no awareness among the public about the sleep study, and also they talk, because now the people come only for the secondary prevention, not
Yes.
for the primary prevention.
Yes, that's
So this has
very
to be
right.
highlighted everywhere. It's one of
Yes.
the cause for refractory hypertension also.
Yes, very rightly pointed out, because there are many studies saying that obesity is increasing in the young. So that actually indirectly giving us a clue that we are going to face this as a huge pandemic.
If there is no other questions, thank you very much, madam.
Thank
Thank
you,
you for
ma'am.
the audience.
Thank you so much, ma'am, once again for your talk. And I also thank the chairpersons to chairing the session. I request Dr. Gurumurthy sir and Dr. Vetrivel sir to felicitate Dr. Chandni ma'am for her talk. Now I request Dr. Chandni ma'am to felicitate Dr. Gurumurthy sir and Dr. Vetrivel sir for chairing the session. Thank you, sir. Thank you, ma'am. Next, we are moving on to the next topic, hepatology. Now, I request Dr. Shanmugarajan, sir, to come on to the dais for chairing the session.
And the topic for this session would be non-alcoholic fatty liver disease, a ticking time bomb. And I request Dr. A.C. Arun, sir, to come to the dais to deliver his talk.
I request the chairperson to introduce the speaker.
Good afternoon, friends. I am happy to introduce Dr. Arun. Dr. Arun is completed his MBBS in 2001 to 2007 in Madras Medical College and MD General Medicine in Chandigarh in 2008 to 2010 and he did in DM Gastroenterology at Chandigarh in 2012 to 2014. He is a former Associate Professor of Gastroenterology, Vellamal Medical College, Madurai. His achievements is advanced endoscopic training in Florida Hospital, Orlando, USA. Performed more than 50,000 endoscopic procedures, numerous publications in index journals, including PubMed index articles, reviewed in PMC Gastroenterology. He is a medical director now in the Lily Mission Hospital, Madurai. Welcome, Arun. Thank you.
Thank you, sir, for the kind words of introduction. Good afternoon, one and all. So I would like to thank the organizing committee for giving me this opportunity. It is a very well organized, meticulously planned conference. So going to the topic, whenever we think about non-alcoholic fatty liver disease, the picture that it's a very benign disease without much consequences comes to our mind. But the scientific committee has given this topic ticking time bomb to highlight the seriousness of the underlying pathology behind this non-alcoholic fatty liver disease. So that will be the highlight of my talk. I will be discussing predominantly why this NAFLD is important and serious in this current scenario. Let me open with an eye-opener. By eye-opener, I am not meaning this kind of eye-opener, but I am telling about a real-time story or real-time incident which was a real eye-opener for me. 52-year-old gentleman, he came for a routine master health checkup. He was a non-diabetic, no comorbid illnesses, no history of any alcohol intake ever. He was 65 kg with a height of 172 centimeters with a BMI of 21. His lipid profile was essentially normal. However, his LFT showed an elevation in the SGOT and SGPT. You can see that. His hemoglobin A1C was 6 and ultrasound showed a grade 3 fatty liver. So to evaluate this grade 3 fatty liver, we went on to do a fibroscan which showed a liver stiffness measurement of 12 kilopascal, which is significant. And in fibroscan, the cutoff is different for various etiology. If you can see that. Can I have any pointer? So for hepatitis B, this is the fibrosis scores 1 to F1, F2, F3, F4. F4 is cirrhosis. So the cutoff is different for different etiology of liver disease. And for our patient, it was 12. So it falls into the F4, NAFLD F4 category. So meaning by he has already reached a stage of cirrhosis. So to confirm that, we did a liver biopsy, it again showed a diffuse steatosis along with that fibrosis and cirrhotic changes, confirming the cirrhosis in that patient. So now he is being labeled as a compensated liver cirrhotic patient. So apparently healthy looking asymptomatic male with no comorbid illness, clean habits with a normal BMI has been diagnosed to have and compensated cirrhosis. So welcome to this new world of lean NASH, which is ruling the world right now, and many of us might be victim to this lean NASH in this forum also. So today I will be discussing about the spectrum of NAFL, recent trends, and why we are calling it as a ticking time bomb. However, I would not be discussing about the pathogenesis part or treatment of NAFL, which is beyond the scope of this 20 minutes time period. So before going into the topic, just revision of facts for the postgraduates. So what is fatty liver? It is the accumulation of fat inside the hepatocytes. Which fat? It's predominantly triglycerides. How much fat? It's more than 5%. Is it harmful? Yes, it is. It can lead to cirrhosis. And is cirrhosis the only problem? That is the important question today. No. Fatty liver is the hepatic manifestation of the systemic illness called metabolic syndrome. So that is the underlying fact for my current talk. So this is an important slide for us to understand. If you do ultrasound scan for all the people, around 25 will be having this fatty liver in the scan findings. So those people will be labeled as a non-alcoholic fatty liver disease. This is a big group of patients. And within that, there is a subset of patients who will be called as NASH. There is active inflammation going on in the liver with SGOT and SGPT elevation. In NAFL, there may not be an SGOT, SGPT elevation, and though active inflammation in biopsy. The third subset will be within that NASH, some will go on to develop cirrhosis. And within that subset, some will go on to develop hepatocellular carcinoma. So this is the entire spectrum of non-alcoholic fatty liver disease. Though there are many facts within this slide, just follow the numbers. When you have a patient with non-alcoholic fatty liver disease, among those, 80% will be having isolated fatty liver, not progressing to NASH or cirrhosis. That is a big chunk. And follow number 3, less than 20%, around 15 to 20% will develop non-alcoholic steatohepatitis, inflammation, active inflammation. Number 4, around 11% over 15 years will develop cirrhosis. And among those who develop cirrhosis, around 31% will develop decompensation over a period of 8 years. And number 5, around 7% or even 1 to 2% per year will develop hepatocellular carcinoma. And there is another pathway, patient developing hepatocellular carcinoma in NASH, not even developing cirrhosis. So we might be having only NASH patient and suddenly he may come up with a hepatocellular carcinoma even without going into a cirrhotic stage. So this is a natural history of NAFL patients. So since this is serious, we should be knowing who should be screened. We all know that this NAFL has many facets. For some patients it may present with a hepatic manifestation, some others it may present with a different disease. So whom should be screened? All patients with features of metabolic syndrome, any one feature, if the patient is having any one feature of metabolic syndrome, should be screened for NAFL. And all patients with deranged LFT should be screened for NAFL. So unless and otherwise we have a definitive reason, they should be screened for NAFL. And all patients with NAFL should be screened for metabolic syndrome. It's vice versa also. So this is few interesting facts. If you see the general population, around 25% will be having NAFL in ultrasound scan. But if you screen all the morbid obese patients, around 80% will be having this NAFL. And in type 2 DM, up to 70%. In patients with hyperlipidemia, at least 50% will be having this NAFL in the screening. So we can say that the NAFL is a hepatic manifestation of insulin resistance. And this is the alarming increasing prevalence. See, previously only it used to be a Western disease. Now we can see that in Asia, it's still higher, even higher than the Europe and the North America. So the prevalence is even higher. This is the recent data 2021. So it's even higher than the Western population. And after recent understanding that it's mainly a metabolic derangement, not just an absence of alcohol, now there is a change in nomenclature that is coming up. So previously NAFL, now they are trying to name it as a metabolic associated fatty liver disease, MAFL. So we will be seeing more of this terminology in the recent future. This is the landmark article which was proposing this new nomenclature. So we have a recent definition for MAFL in APACEL. So fatty liver with either one of them, diabetes or obesity, this is obesity, or metabolic dysfunction, any one or two parameters in the metabolic syndrome like triglycerides, hypertension, any two should be there. So fatty liver with any one of them makes MAFL. So this is a recent definition that is given for metabolic associated fatty liver disease. So just to keep you interested, which is the most common cause of death in NAFL? Whether it is HCC, complication of cirrhosis, acute liver failure, or cardiovascular disease. Yes. So since it's a physician forum, I think everyone will be answering correctly. It's a cardiovascular disease. So that's why today's talk is important. NAFL is a ticking time bomb in various senses. So we are discussing multi-organ involvement in this talk. It can involve from each and every organ in the body. Why? Because the underlying pathogenesis is the same. It's insulin resistance, endothelial dysfunction, gut barrier disruption, and disruption of antioxidant mechanisms. So these are the same pathophysiological mechanisms in various disorders. You can take any organ, brain, heart. So these are the same pathophysiological mechanisms. So that's why this underlying pathology involves not only liver and also all the organ systems. So I am presenting recent data for different organ systems. This is the NAFLD risk in cardiovascular disease. Various studies have been enumerated from 2003 to 2019 have been enumerated in this article. And you can see that the ratio, hazard ratio, odds ratio, or risk ratio, everything is high in patients with NAFLD compared to the control population. So clearly saying that cardiovascular risk is significantly higher in patients with NAFL compared to the age-matched controls. This is even an AHA statement. So now coming to the next important aspect, NAFLD as a cause of hepatocellular carcinoma. Previously, NASH as a reason for or underlying etiology for hepatocellular carcinoma used to be very less, 10 to 20% or even less. Now it is rapidly increasing. These are Western data starting from 14% to 58% of all HCC are caused by NAFLD. And here we can see the Indian data also. Around 21 to 38% of all hepatocellular carcinoma are having underlying pathology as NAFL. Previously, hepatitis B and C used to be high, and now NAFL is overtaking those viral etiologies. So this is the prevalence of HCC with NAFL as the etiology. So which is even less in Western countries compared to Asian countries. So it's very alarming for us that NASH is producing more and more of HCC in our parts of the world and country. This came in Nature Reviews 2020. Another very astonishing fact is that NAFL not only increases the risk of hepatocellular carcinoma, it also increases the risk of other extrahepatic malignancies. So this is the recent data in GUT 2021, where we can see that the incident rates per 1000 patient years in general population is 4.8. It's almost double in patients with NAFL. So extrahepatic malignancies, the incidence is significantly higher in patients with NAFL compared to the general population. You can see the hazard ratio also. One more astonishing thing, NAFLD as a risk factor for CKD. So again, this is a recent article came in Journal of Hepatology, and it says that after eliminating all confounding factors like obesity, diabetes, hypertension, even then NAFLD is independently associated with increased risk of CKD. So NAFLD is an independent risk factor for CKD even after eliminating diabetes and other confounding factors. So almost I was surprised to see more than 20 articles in this aspect also. And coming to the all-cause mortality, so we have seen different organ system involvement, and this is the all-cause mortality. And again we can see in control population the incidence is 16.9 and it is 28 in NAFL group, which is again significantly higher. So overall all-cause mortality in patients with a simple ultrasound finding of fatty liver is significantly higher than those who are not having it. There are other few organ involvement like obstructive sleep apnea, PCOD, hyperuricemia, osteoporosis, sarcopenia, erectile dysfunction. They are all part of this multi-organ system in which NAFLD is part of it. So since I am not going into the treatment part, just a fact, the newer treatment modality that is shown to be useful in NASH is saraglitazar, vitamin E, weight reduction, fecal microbiota transplant. The answer remains and will remain the same in the near future also, and that is weight reduction. So I'm coming to the final aspect of the ticking time bomb, the entity called lean NAFL. Here the definition is hepatic steatosis with a BMI less than 25 or in Asian population less than 23 in the absence of significant alcohol intake. We call it as lean NASH. And what is different in lean NASH compared to the actual NAFL? So I have put a comparison table. The prevalence of lean NASH is higher in male population, even in normal NAFL it is higher, but if it is higher in lean NAFL. And the rate of diabetes, hypertension, hyperdyslipidemia are lesser in lean NAFL compared to the actual common golden variant of NAFL. Central obesity is lesser. AST elevation, ALT elevation is lesser compared to the usual NAFL. But the hepatic fibrosis, inflammation, and all-cause mortality is significantly higher in lean NASH compared to the usual NAFL. So that is the difference between these two. And some have even differentiated it into two types, type 1 and type 2. In type 1, it is due to visceral adiposity, insulin resistance with significant genetic ethnic predisposition, more so in our population, Indian and Asian population. In type 2 is predominantly a monogenic variant due to a single gene disorder. So these are two types of lean NAFL in this category. So lean NAFL can definitely be called as a ticking time bomb, because many a time we don't realize that the patient is actually having NAFL, and only after the bomb blast, that is a occurrence of hepatocellular carcinoma or cirrhotic with its complications, we realize that actually this patient was harboring lean NASH. So that's why it can be rightly called as a ticking time bomb. So coming to summarizing my talk, NAFL is becoming the most common cause of liver disease nowadays worldwide as well as in our part of the country. And it's important to know, it is important for us to know that there is a nomenclature change that is coming up because of the better understanding of the pathogenesis. That is, metabolic associated fatty liver disease is a new nomenclature. And we have to understand this underlying concept. It's a hepatic manifestation of a systemic illness called metabolic syndrome and not just an isolated disorder. And we are calling it as a ticking time bomb, NAFL as a ticking time bomb. Why? Because it increases cardiovascular risk. Why? Because it increases cerebrovascular risk. Why? Because it increases cirrhotic rates and as well as its complications. Why? Because it increases hepatocellular carcinoma risk. Again, why? Because it increases the CKD risk. Why? Because it increases the extra hepatic cancer incidence, and ultimately it increases the all-cause mortality. So next time when the take-home message of my talk would be, next time when we see a patient with an ultrasound scan showing a fatty liver, we should not think that it's an insignificant finding. Rather, all these complications should be running in our minds. Thank you for your patient listening. Thank you.
Congrats, Arun. It's a wonderful presentation. It's a NAFL. We always see as a physicians, patients, common patient, we send to ultrasound abdomen, the finding is fatty liver only. The patient asks, "Sir, anything, any problem is there?" No problem, liver, fatty liver is there. But now onwards, we tell the patients, you have so many problems upcoming, so you are ready to face it. So please reduce the weight in the always. Okay, one question, Arun. If any symptoms, patients nowadays we come to the patient with symptoms of right hypochondrial tenderness or abdominal pain, we send for ultrasound abdomen. There is no other finding except fatty liver. Any fatty liver can cause abdominal pain or right hypochondrial pain. Is there?
Usually, no, sir. So usually, whenever there is a very massive hepatomegaly only, they may feel right-sided discomfort. Usually, it is usually asymptomatic. Maybe some dyspeptic symptoms or other bloating may be mistaken for fatty liver related symptoms, but actually fatty liver may not produce any symptoms. Usually asymptomatic only.
Next, you are first initially you said mainly due to the obesity patients and other comorbidities is there. But finally you said lean NAFLD is very dangerous than obesity is there. Why? Because the lean NAFLD patients having no comorbidities like obesity or diabetes or hypertension. On the investigation also the liver enzymes are normal, but it is very you are serious than. What is the reason?
The hepatic inflammation is significantly but higher in these patients, which in turn lead to increased fibrosis. It is predominantly due to the genetics, which leads to increased inflammation and fibrosis. So though the SGOTPT may not be highly elevated, but when we do a liver biopsy, the intensity of inflammation and fibrosis will be higher in a comparative individual in lean NAFL compared to the normal NAFL patients.
Final question. If all patients, because we send the patient, 50% of the patient having ultrasound guided fatty liver, all fatty liver patients undergo fibroscan are necessary?
No. Initially, we will do routine investigations in the form of liver function test. Liver function test, lipid profile can be done, and if we find any abnormality, then we can go for a fibroscan. Fibroscan may not be available in all the places, and it is not immediately warranted. First, routine investigations with a simple liver function test and lipid profile will do, sir.
Thank you, Arun. Any forum open for discussion? Any questions, please?
Yes, sir. There are many natural history studies which have been conducted in the Western population. And we have seen, they have shown that the average duration is around 20 years. From the simple NAFL to cirrhosis, the average duration is 20 years, plus and minus, but average is 20 years. But in the presence of active inflammation, when the patient reaches a stage of NASH, this significantly reduces. It becomes around 5 years, 5 to 7 years. When the patient becomes NASH, the duration is significantly reduced. So then the natural history completely changes. And NASH directly can go to hepatocellular carcinoma also without going into the pathway of cirrhosis.
Sir, how to prevent a lean NAFLD, sir? How to prevent?
The same precautions that we take for obesity related NAFL. with adequate physical activity, healthy diet. That's what we can do. And periodic checking, and if the SGOT PT are elevated, any eligible drugs that can be used can be tried.
Sir, question, one more question.
Yes, sir.
There is a plant extract by name Silimarin.
Yes.
From the plant Cebum marianum. It's said to be a potent anti-fibrotic, anti-inflammatory, antioxidant.
Yes.
What's your opinion about that, sir?
We have few studies on this Silimarin milk thistle, especially in alcoholic hepatitis, and very few in non-alcoholic fatty liver disease also, sir. However, we don't have any significant evidence for regularly using this Silibon or milk thistle in non-alcoholic fatty liver disease. The results are not supporting its regular use. We don't have any significant results with these drugs. It's not recommended to use regularly in non-alcoholic fatty liver disease.
Good afternoon, sir.
Yes.
We routinely find out the fatty liver from the ultrasound. Many
Yes.
times it's an incidental finding. Could you tell me the earliest indications for doing a fibro scan?
Yes. If though there is no definitive guidelines, what we can say it, if the fatty liver grade is 3, if the sonologist is mentioning fatty liver grade 3, we can straight away go for a fibro scan because they are finding it very significant. But it's very subjective thing. Fatty liver 1, 2, 3 is very subjective. But when there is an LFT elevation in the form of SGOT, SGPT elevation, or if there is a morbid obesity, or if the dyslipidemia is very high, disproportionate, then we can go for fibroscan. But not all fatty liver patients immediately need not undergo a fibroscan. If it is a fatty liver grade 3 or associated with any LFT derangements or lipid profile derangement, we can go for a fibroscan. Yes.
Sir, is there any relation between familial dyslipidemia and lean NASH, sir?
I'm not very sure, sir. I have not gone through any such studies directly comparing familial dyslipidemia. You are asking about familial dyslipidemia, like familial chylomicronemia, something like that, with the lean NASH. Yes. I am not exactly aware about those studies. I have not gone through those studies.
Diabetic, non-alcoholic, grade 1 fatty liver, normal liver function test. Should it be worried?
We have to keep in follow-up only, sir. We may not give any drug at this point of time with a normal liver function test with only grade 1 fatty liver. It's very common. As we saw in the presentation, it is more than 50% will be having, diabetic will be having this fatty liver. With the normal LFT, we need not worry, but definitely we should keep in follow-up with a 6-monthly LFT and an ultrasound follow-up.
Do they need high dose statins?
Statins are useful to some extent, sir. It's not high dose, but the usual dose can be prescribed.
Thank you.
Yes.
Nowadays, in very young age persons, like in a 21 years or 19 years, most of the time they will took a outside fast food. Their lipid profile shows triglycerides around 600 or 700. So how we need to approach, how to start the statins? Initially with the high dose, or slowly we need to step up the dose, or we need to work up the metabolic profile?
Yeah, sometimes we see more than 500 very commonly nowadays, but usual dose will suffice. If there is along with dietary restriction, if they are not responding to the usual dose, then we have to work up for any familial pathology also, and then we can hike up the dose along with that. But usually we start with the usual dose and dietary modification only, whatever may be the dose level of triglycerides.
Also the 60 plus and 70s, they are also routine ultrasound. They're showing a grade 2 or grade 3 fatty liver. We need to do any interventions or need to start
More than 60 years.
60 plus.
Yes, definitely, because that is the age in which we see more and more cases of non-alcoholic fatty liver disease related cirrhosis. So we might not have picked them up in their 40s. So now they might have developed the cirrhotic stage. So in this stage, if somebody is having grade 2 or 3, we should further evaluate with fibroscan and routine investigations and other things.
Thank you, sir.
Okay. So no more questions. We'll move to second section. Thank you, Arun. Okay, next session.
Thank you, sir. So next, for delivering the talk on liver transplant, is it feasible to all? I welcome Dr. Joy Varghese to the dais.
I am happy to introduce my friend Dr. Joy Verkis. He is my colleague in MD General Medicine 2001 to 2004 in Madurai Medical College. Now he is a director of hepatology and transplant hepatology in Institute of Liver Disease and Transplant in the Global Health City, Chennai. He is the head of transplant hepatology for more than 10 years and have managed more than 1,500 liver transplantation, including 300 pediatric liver transplantation. Has played a vital role in setting up liver transplant program in both government as well as the private institution in Tamil Nadu and Kerala. First person in India started using therapeutic plasma exchange in various liver conditions. Received Tamil Nadu Medical Council Award 2022 from Honorable Governor of Tamil Nadu. Medical Excellence Award 2019 from Honorable Governor of Kerala. His publication is research publication and been assessed WW Research Gate, then and more than 100 publications in several national and international journals, author of 4 book chapters. Jai, thank you.
Thank you, Chairperson, and my dear friend Dr. Shanmugarajan. At the outset, my sincere thanks to the Trichy chapter of Tapicon organizing secretaries, Dr. Ranita, Dr. Muthumani, and Dr. Ponnaya, and the scientific committee members, Dr. Narasimha, and Dr. Selvaraj, and the state level APA chapters, Dr. Seduraman sir, and Dr. Palniappan, and Dr. Chandra Shekhar. This is not my topic, it's technical topics for the next 15 to 20 minutes. 15 years ago, whenever the transplant related talks, either in state or other state, whenever I am going to deliver in the various societies, mostly I will talk about indication for liver transplantation. What about the outcome of liver transplantation? What are the complications of the liver transplantation? What are the types of liver transplantation? So mostly that kind of the talk mostly they will like. But now we all agreed, we know in acute liver failure, whenever the patient fulfills the King's College criteria, definitely they need a liver transplant. So the treating doctors, they will refer to the transplant center. Similarly, in a decompensated chronic liver disease, maximum medical therapy we have to support. At the same time, if their MELD score goes high, more than 50, or the child disease status, so we straightly we are started to tell to the family better to go for liver transplantation. Now, interestingly, this topic is given by the organizers, whether is it feasible for all. So really, we have to think about it, and I'm going to show some of the data. So this is the liver transplant roadmap in not only in India, in the world. It started in almost 45 years ago in 1967, but the successful liver transplantation in India done in 1998. But next 10 years, there is no much centers. But if you look into that 2022, almost more than 100 liver transplant centers across India. But in Tamil Nadu, if you ask me how many centers has been officially registered in the Tamil Nadu government, 49 liver transplant center. But if you just look into that India, mostly the centers will be close to 400 plus. But the centers doing the more and more liver transplants might be less. Second thing, the expertise. Earlier expertise used to travel to abroad to get the training. Nowadays, either the post-DM or post-MCH and anesthetists, they are going for the fellowship program in India per se. After the completion of the fellowship, they are going into that, joining the new center. And the cost, even India, it comes around 20 to 30 lakhs. But if you look into that, what is the demand of liver transplant globally, it will show more than 2 lakhs. But in India, if it comes, need is 25,000 to 30,000 per year required. But at present, even though we have more than 400 transplant center across India, they are doing 1,500 to 1,800 liver transplantation per year. So the need is almost more than 10 times. That's why there are the more expertise are coming out, and the more and more the transplant centers are coming out. And what about the cost? This the question comes. If this is the cost in India, it comes around 25,000 to 35,000 US dollar approximately. But if you look into the other countries, mostly the cost is several times higher than India. And if you look into that worldwide, even though if you compare the neighboring countries, so India is at present is the lesser cost for the liver transplantation. But the question is it possible, affordable to all? So this is our data in our unit. So except the COVID time, there is almost, we are crossing 100 liver transplantation every year. So in the last 4 years, we have done 380 plus liver transplantation. If you look how many of them, they self-paid. So almost 52% of the 380 plus. So the remaining, almost the 48% of the patients depend on some of the support. What are the supports? How without self-funding, they are coming for liver transplant and undergoing for liver transplantation. So the mostly 140 is these are the Tamil Nadu Chief Minister's Health Insurance Scheme. So those who are eligible for that, they are approaching and they are getting the approval that covers entire the cost of liver transplantation. Not only the entire cost, and after liver transplantation, first 2 year immunosuppression, medical therapy, and if the patient require for any admission related to the liver transplant related complication, everything is covered. So normally after liver transplantation, 2 years later, their expenditure per month might be due to the medication cost will be either 2,000 or the sometimes lesser than that also. So the first 2 years as the government is supporting, and the entire cost for that, either the living donor, family donor, there is the cadaver, everything is covered. That is the main chunk. The second is the Andhra government scheme. So similar to Tamil Nadu government, Andhra government also giving the 10 lakhs to 15 lakhs per transplant, but it is not covering the post-liver transplant, the scheme. Apart from that, ONGC, so either Karaikal or wherever the employee is working in the quasi-government, it is covered. And similarly, NLC, Neyveli Lignite Corporation, the employees. So these are some of the other states. So what I'm trying to tell here, the transplant is still feasible, but we have to look into that whether it's supported by the either Tamil Nadu government or either any other quasi-government purpose organization. And this is the private and public and the partnership, because we did almost 148 transplantation under the government scheme. So we call, if you look into their individuals, the background, almost all are very poor. Most of them are the pediatric. Out of the 148, 106 are pediatric transplant referred from the ICH Egmore Hospital, Children's Hospital. So that's the way it is very important. And the second thing, what other sources for applicable for to undergo liver transplantation? We know there are so many crowdfundings are now in run for not only the transplant, so many medical purposes. If you look into that, we know MILAP, Keto, and the Impact Group, Give, GoFundMe, etc. This is the Indian data. For liver transplant alone, they given 100 crores. They have been generated through government fund across India. And if you look into that, our center alone, almost 7 crores has been generated. It has been helped to the 60 plus transplantation. So who is going for this kind of the crowdfunding? Definitely affordable people, they feel shy. They can't go. But poor people, pediatric or the malignant disease with adult disease, those who are not affordable to pay, that also, this is the crowdfunding the way also it is feasible. So, I mean, I am the ladies and gentlemen, so how we can make liver transplantation is affordable to all. Number one, public-private partnership. How the Tamil Nadu government is and as well as the Andhra government, similarly the same model, other state government also started to support the liver transplant program. That time, even though they are not affordable, they can go ahead for that. Second, MOU with the national and international NGOs. So there are the NGOs, even the Tata, the company is supporting their employees, and there are this ITC, so Indian Tobacco Corporation, they are supporting their employees. So some of the industrialists, they are supporting through their social fund. So that MOU is important. Third, crowdfunding, as already mentioned, even one single hospital is generating 6 crores or 7 crores for the liver transplantation alone. It is possible by the other hospital also, they can generate and they can help to the needy peoples. The fourth, the inclusion of the liver transplants by the various, the hospital and the national and international corporates, that's they can help. The finally, now it is in Tamil Nadu is doing by supporting the government hospital. The private institutions are started to support in Stanley Medical College, and now it's going to the Madras Medical College. This kind of the way the private institution, they can support. That time no need to government pay or anything to the patient. It is the government hospital, the patients can get the equally effective treatment like a private hospitals. So thank you so much for giving kind opportunity.
Thank you, Jai, for your wonderful presentation. Jai, your hospital, if a patient came to for liver transplantation, the poor patients, you are guide the patients about the schemes for the liver transplantation. Any patients come without some poor people from remote villages come to liver transplantation.
Mostly whenever the patients coming from the poor socioeconomic background, if they have the government, the scheme card, that is, we know the Tamil Nadu Chief Minister Health Insurance Scheme, that time we have the coordinator, we will refer the patients to go and meet the coordinator. They will check the document, because the documents wise, if they provide all the things, then easily we can forward to the government. There are the two committees are there. One in the DME and another one in the DMS committee. So there are the stipulated time they will give. That time you have to submit all the documents. Based on the documents, they will give the clearance. So, but sometimes the middle class family will come. They can generate around 10 lakhs, but they can't have, because already the IT return something they will file it. They are not eligible for the getting the government the CM's card. So that time we will ask their whether working place area wise, that organization will they support or not. Some of the organization will support with the minimum, not like one, as they are able to pay 10 lakhs. So total cost of the transplants come 18 to 20 lakhs per living donor transplant. So few lakhs they will generate, and at that time we will ask the crowdfunding. Some of the family will agree the crowdfunding. Some of the family, they feel shy. Okay, why, how I can put my photos and other things. But that is the issues of the things.
How now the donation, organ donation, the liver donation, how is the people are interesting? What is the improvement in any donation? People voluntarily donate the liver after his death. In corporate hospital, patients ask, sir, I want to donate I want to donate my eyes after my death. Please, where I go? If patients ask, I want to donate my liver after my detention, how they are approached? How they will approach to your organization or corporate hospital?
See, but in India, the system is different from Western world. Western world, we can decide, we can declare that after my death, my organ I can donate. So the card always they will have, even though after any RTA, because it's not possible by any cardiac arrest or death or anything, because that is this all the organ donation is brain death. It's not a cardiac related or a disease related, only the brain related, brain death. So that time, most of the hospital, whenever the individual got admission, they have the card. So based on that, they will start the process. But in India, so even if individual is willing to donate the organ, at the time of the brain death, the family member has to give the consent. They have to sign. Not only the first degree relatives, anyone, if the object, okay, that time it is not possible. So it is the donation at the brain death in India is totally depends on their family members. So family members without their consent, even though an individual has taken a decision, it is not possible. If the family members that time, if they accept at the brain death time, so that time only that has the hospital, concerned hospital will intimate that transplant. We have so there is the NGO like the things, the government is running the program. So that people, they have to go to whichever the hospital, that hospital authority has to inform, we have one brain dead patient, the family members are accepting to donate their their beloved one person to donate. That time they will ask which are the organ you are willing to donate. So suppose one the organ, if you take the body will become disfigurement, that worry will come. So that's why the hand transplant is not popular nowadays. So after the hand transplant, the body will not look nice. So nowadays the processes are coming. So they will hand over the body with attaching the processes, and they will hand over. So this all after the cornea donation, how they will appear after the liver operation. So mostly the non-MLC individual after the brain death, they are mostly reluctant to donate. But the MLC related, the brain death, because we know what are the MLC cases. That time anyway it is going to the postmortem. So that time they are keen to donate most of the families are willing to donate the organ. So everything is a systematic process. Second level will come, even though we are donating, which organ, what about the quality of the organ to take it? Even though they are willing to donate, the quality of the organ, our assessment wise not good, we shouldn't take it. That's the way we'll go next step.
இப்போ patient is admitted or registered in your hospital for a liver transplant, minimum average time we will get liver for that patient. Any?
So mostly in our center we are doing living donor liver transplant. In acute liver failure, because we know rattle, poison, etc., there are acute liver failure. Once they comes, we will take the case within 24 hours, not more than 24 hours.
Very nice.
The family donor. So they will get admission. Casualty time to OT shifting time will be 19 hours. Even though I'm telling with getting the government fund, we know the process, but the government is supporting very well. With the help of government, we can get the almost free transplant with the retal also. But if you look into the cadaver transplant, so usually we have to register their name. Whenever the good quality of the organ comes, that it will take minimum 6 months nowadays. Even though the more and more cadaver donation happening in Tamil Nadu, but average waiting list time it will go to 6 months. But that also based on the blood group. And the second thing, that also based on the center. Some of the center which have the waiting list less, they will get a quick, and which of the center generating in-house organ, they will get more. So there are so many factors involved in the waiting period in cadaver organ, but the living donor with acute liver failure less than 24 hours.
Donor with the family members is okay. If any friend or any legal problem, is there legal workout, is there?
Actually, in India, the unrelated, not the family, either first degree, second degree, third degree, that relative, the evidence should be submitted. But in some of the states, some of the case reports, the family, for example, the nuns, okay, they don't have the family, monk, they don't have a family. So that time, the friends has donated, but it is not a direct donation. They went to the court, they filed the case, they proved that they don't have the suitable family donor. So that's why my friend or my distant, one of the well-wisher, so after getting the court order, they have gone for the living donor liver transplantation. But unless, otherwise only the family donor only at present in India, it's possible.
The audience.
Okay.
So no more questions. Thank you, Jai.
Thank you. Thanks.
Thank you. So
Thank
move
you,
to next
sir.
session.
Thank you, sir. And next, for delivering the talk on liver kidney crosstalk, I welcome Dr. Pandurangan Basmani, sir, onto the stage. I request the chairperson to introduce the speaker.
Welcome, Dr. Pandurangan Pasmani, sir. He is a consultant gastroenterologist from Apollo Hospital, Greens Road, Chennai. He has worked in NHS for 20 years, practicing gastroenterology Chennai since 2013, areas of special interest in IBD and therapeutic endoscopy. Proceed to Dr. Pandurangan. Thank you.
Thank you, sir. Thank the Trichy team, Dr. Anita especially for inviting me. It's a real honor and it is heart-warming to see so many people still here, not at the lunch hall. So I'll be as quick as possible. I won't stand between you and the lunch. So again, another interesting topic, crosstalk. As postgraduates, we all know when kidney and liver can be simultaneously affected. For example, if somebody has got acute MI and cardiogenic shock, there can be ischemic hepatitis and pre-renal or acute tubular necrosis related kidney injury. But that is not a crosstalk, it is a simultaneous talk. Crosstalk happens when the liver is sitting with the disease and kidney is sitting away without disease, and this diseased kidney like scene-defying vadivel, no, come, no. So be sympathetic to me, go into some kind of functional strike. That is called crosstalk. During the cirrhotic lifetime, the most important negative milestone is development of ascites, and another negative milestone will be spontaneous bacterial peritonitis. And both ascites and bacterial peritonitis are a harbinger of this crosstalk in an acute setting. But like Arun said, chronic inflammation in cirrhosis, any form of cirrhosis, can give rise to silent chronic kidney disease, and that is a different form of crosstalk. So in my opinion, all cirrhosis is already a kidney disease. So you don't need to even think. A cirrhosis patient is kidney disease, and I get worried if their serum creatinine is even normal. A cirrhotic patient with a low muscle mass should have creatinine of 0.4 or 0.6. When it hits 0.8 at 1.0, I get worried. So my bulletin point for this talk will be normal creatinine is abnormal for a cirrhotic patient, like a pregnant patient. So you can see serum creatinine grossly overestimates GFR, but we have nothing else to go by, so we still use serum creatinine to define acute kidney injury. The new definition alone you will focus. If it's serum creatinine rise more than 0.5 milligram, 0.3 milligram within the last 2 days, or more than 50% rise within the last 7 days. This definition is very useful because it gives lot of freedom for the physicians to make a quick diagnosis of acute kidney injury. This is the first term you should remember. Acute kidney injuries, if you have data, are presumed within last 2 days or within last 7 days. And as soon as you label the patient with cirrhosis and ascites having acute kidney injury, then you can stage how severe it is. If within the stage 1, if the absolute creatinine value is more than 1.5, it's called stage 1B. If it is less than that, it is stage 1A. If the serum creatinine is more than 1.5, 2 to 3 fold, then that is stage 2. And if it is more than 3-fold or the absolute value is more than 4 milligram, it is stage 3. So acute kidney injuries, 2 days or 7 days, not more than that. Acute kidney injury can be staged into 3 levels depending upon the value of creatinine. And why it is important, because like ascites, like SBP, acute kidney injury imparts prognostic implications, and it is progressive. Between stage 1A, 1B, 2 and C, you can see the rising mortality. And in all comers of hospital, if your cirrhotic and ascitic patient develops acute kidney injury, then the 30-day mortality is going to be around 30%. So that's the second point. If you have a patient who develops acute kidney injury by this criteria, 2 days more than 5.5 milligram, and 7 days more than 0.5 fold rise, then there is a 30% chance that the patient will die at 30 days. But this is for all acute kidney injury. So, if you look at the special population, because so many people are living with cirrhosis in the community, but they pre-select themselves to come to the hospital. That's why Harrison calls itself as internal medicine. The moment the patient, for some reason, comes to hospital, things change. They are sick. I think because they realize they are sick, they come to the hospital. So, if this is an Indian data, you can see around 20% of people hospitalized with cirrhosis and ascites will develop a kidney problem. Fortunately, only 1% will have chronic kidney disease, and others will be having acute kidney injury by the criteria. Within that acute kidney injury, 2/3 will be pre-renal, which is raised plasma renin activity and volume responsive. If you stop their diuretics, if you replace their volume, if you treat their sepsis, they will improve, and it is very easy. They improve and then they come out of this. Whereas if they don't respond to 2 days of volume trial, then you need to think. If the acute kidney injury is within 7 days, we call it hepatorenal syndrome type 1, and if it is more than 7 days, it is called non-acute kidney injury. So HRS, non-AKI. So this is important because I told you in acute kidney injury the mortality is 30%, but if somebody qualifies this criteria, they are acute kidney injury, but they have not responded to 2 days of volume replacement, then they have 60% chance of dying at 30 days, and 100% will die at 10 weeks. At 3 months, none of these patients who fulfill this criteria will be alive without definitive treatment, which was the topic of Joy's talk, which is liver transplant. So, the crosstalk between the liver and kidney is through the altered hemodynamics. It is a renal microcirculation, loss of autoregulation, and splanchnic vasoconstriction. It is already there in all cirrhotics. It only gets magnified during this acute crisis. That's all you should remember. All patients have already the setting. Once it gets magnified out of control, all you need may be a dose of diclofenac, just one dose. That may be enough to tilt the balance. So, we need to separate the terminology now. Acute kidney injury is all encompassing criteria, and within that the non-volume responders are HRS, and within that the time frame of 2 to 7 days is HRS type 1, and anything beyond that is HRS non-AKI, and within that type 2 non-AKI, if it is less than 3 months, we call it HRS AKD, and if it is more than 3 months, it is HRS CKD. In HRS AKD, the setting is it is not acute. There is no precipitating event. Usually, in patients with HRS type 1, the HRS AKI type, there is a precipitating event like SBP or large volume paracentesis, and the liver function is more under child C or advanced MEL score, whereas in HRS type 2, the mortality is better. They have longer time to process them for liver transplant. They have relatively better preserved liver function. There is no precipitating event, but one thing that stands prominent is they all have diuretic resistant ascites. So, on one hand, you have a person with a precipitating event and coming with 2 to 7 days, and another person takes 3 months to evolve, but in the backdrop of diuretic resistant ascites. So, I think we are all clear that acute kidney injury can be mostly pre-renal. Luckily, nothing is 1% post-renal. And within that, 2/3 is pre-renal and 1/3 is renal. And with the renal, if the short duration is AKI, if it is longer duration, 3 months is AKD, more than 3 months is CKD. And the precipitating event and the outcomes are different. So the diagnostic criteria for HRS AKI is they should all have cirrhosis and ascites. There can be sepsis, but no shock. There is no septic shock. and all the nephrotoxic have been removed, and you have tried 2 days of volume without improvement, and the renal parenchyma should be normal by surrogate marker. Olden days, the histology was normal, but now we should have a normal parameters for parenchymal disease, which is absence of significant proteinuria, bland sediments, normal ultrasound, and very rarely histology. So, pre-renal is easy because they respond to volume. HRS is difficult to diagnose because there is nothing to go specific. And ATN, which is another intrinsic renal disease, is the only condition that needs separating because it's very difficult to distinguish between these two. And this is where NGAL comes in. If you look at the bottom left corner, HRS is a functional AKI and NGAL will be normal or low. The NGAL does not say this is HRS, but raised NGAL says it's more likely ATN. So NGAL has got more positive predictive value for intrinsic renal disease. So if you look at the pathophysiology, the key word is portal hypertension means splanchnic vasodilatation. That means decreased effective circulating volume. So the effective circulating volume raises the peripheral resistance as well as the renal vascular resistance. And it is very interesting, like adenosine is a renal vasoconstrictor, endothelin is a renal vasoconstrictor, leukotriene is a renal vasoconstrictor. It's a constant interplay between increased vasoconstrictors within the kidney, and the kidney tries to counteract with prostaglandin and nitrous oxide. So either vasoconstrictor overpower or vasodilators are decreased. We don't know what happens, but at one fine point, the renal vasoconstriction proceeds to a tilting point and causes decreasing renal function. And the ongoing chronic inflammation, both at the gut level, the gut liver axis, as well as at the liver level, only add to this injury and aggravate the development of HRS. And this is the single picture that depicts. So as the liver disease gets worsened, there is progressive renal vasoconstriction and increasing disturbance of the renal autoregulation. So having understood the pathophysiology, the treatment options are give vasoconstrictors after replacing the volume, because as you know, basically if the volume is not fulfilled, your vasoconstrictor is not going to work. So you have to give vasoconstrictor which will counteract the basic altered physiology, which is splanchnic vasodilatation. Of course, liver transplantation is the treatment for this poor prognostic condition, and Joyce convinced us it is going to be feasible for majority, if not all. Unfortunately, renal replacement therapy does not serve the purpose except as a bridge to transplant. So there is no point in initiating renal replacement therapy for HRS per se, but if there is acidosis, if there is hyperkalemia, if it is volume overload, you do it for nephrological indications, but not for the liver kidney crosstalk purpose. So how much albumin? You replace it with initially up to 100 gram, and then you can continue the maintenance dose, and you have choice of vasoconstrictors, of which we have a midodrine octreotide combination. If the patient is in HTU or ICU setting and the cost is an issue, you have a norepinephrine albumin combination, and the last but most important is the terlipressin. But the studies have shown that terlipressin is way better compared to other choices, and because it is got a selective V1 action, which is twice. The splanchnic vasoconstriction is major pathophysiology, and terlipressin goes and specifically counteracts the vasodilation at the splanchnic level, and the whole altered pathophysiology is reversed in a patient's favor. It can be given IV boluses or at a lower dose at IV maintenance. And this study, which got the FDA approval for terlipressin in this condition, shows that both HRS reversal initially, even in the SIRS subgroup, as well as the 30-day reversal, is significantly better than the placebo. So the other important point is while we are processing the patient for liver transplant, if you reverse the HRS before transplant, then they recover faster in the post-transplant period with a lesser requirement of renal replacement therapy. Because even without that, if you replace, first 3-4 days the patient will suffer with worsening renal failure, and we need to be careful with the post-transplant immunosuppressive regimen, avoiding nephrotoxics. But by day 6 they start improving. But if you had the opportunity, window of opportunity to bridge them with the terlipressin, then they have less stormy post-transplant course. But everything comes with a price. Terlipressin is contraindicated if the SpO2 is less than 90. So remember this point. If your patient has got hepatopulmonary syndrome, pleural effusion, sepsis, and if they are hypoxic, then you need to go for noradrenaline and albumin rather than terlipressin, because respiratory failure related deaths and multi-organ failure related deaths are unfortunately higher in the terlipressin group than the other group, and thus reflects in the 30-day overall mortality. Even though the first 2 weeks look like a honeymoon period with terlipressin and the HRS AKA patients, if you treat them, even when the 20% they relapse, and if you treat them, they respond. But if you prolong this temporary vasoconstriction of the splanchnics, but it does not translate into long-term survival. Therefore, it goes without saying that eligible candidates should be referred to the transplant center as soon as possible. So, such an abysmal prognosis, prevention is better than cure. We all know that cirrhosis, portal hypertension, and ascites are the prerequisite, and SBP and large volume paracentesis are the precipitating event. Even though we know that after massive GI hemorrhage from varices, they can develop acute kidney injury. Most of them is pre-renal or ATN than HRS, but HRS is mostly related to SBP and large volume paracentesis. Even if you diagnose and treat SBP promptly, 20% of them will develop HRS. Even if you are doing large volume paracentesis without albumin cover, 10% will develop HRS. So these two situations, you cover them with albumin, and then you try to use the preventive strategies. Sometimes even after SBP, secondary prophylaxis with Norflox or Ciproflox. So prevention is better than cure, and I will say pre-prevention. Alcohol, fatty liver, even preventing cirrhosis itself is a prevention of HRS. So to summarize, friends, acute kidney injury in cirrhosis is common, if not ubiquitous. Progressive impact on survival depending upon the absolute level of creatinine. The 2 days and 7 days criteria are important to diagnose AKI, but all AKI is not HRS, only 1/3 is HRS, and they should fulfill the criteria of normal urinary sediments, normal no parenchymal disease, no shock, no nephrotoxic, no response to volume expansion. And once you diagnose, liver transplant in the background and temporary treatment with terlipressin and albumin should be the choice, except hypoxia and other contraindications. Unfortunately, liver transplant remains only definitive therapy, and if you treat them before transplant, they have a better post-operative course. Thank you very much for your attention.
Thank you, sir, for your wonderful presentation. Thank you, sir. Sir, one question, sir. Then in our days, in the chronic liver disease, the decompensated state, the spontaneous bacterial peritonitis occur. This 1 year survival rate is very, very low. That's like the acute kidney injury, the otherwise hepatorenal syndrome first occur in the decompensated liver disease. The prognosis, if renal transplant is must, no?
Yes, sir.
Yes, sir. Any?
So what happens is, if you have the opportunity to monitor them serially, once their mean arterial pressure keeps going down towards 60, if the serum sodium starts coming down, called dilutional hyponatremia, that shows that the sympathetic system and ADH is already kicked in. So they are impending or warning of this death syndrome. HRS is a death syndrome. if everybody is going to die within 10 weeks, then it is a death sentence. If you have access fractional excretion of sodium, if it is going down below 10, below 5 milliequivalents. So these are the sort of harbingers or warning signs. But if you want to prevent SBP even before primary prevention, if the serum ascites albumin is very low and if they have a poor MELD score, then you can start even primary prophylaxis with this ciprofloxacin, even rifaximin. Rifaximin is coming. So this kind of situation, and even varicose bleeding, primary prophylaxis with beta blockers, you can only do so much. But once they tip into the balance, like I said, it is already going on. And what happens in the acute crisis is only a magnification of what is already going on.
Audience?
They are all hungry, I think.
Yes. Okay, no more questions. We can.
Thank you, sir.
Yes, sir.
Now I request Dr. Shanmugarajan sir to felicitate Dr. A.C. Arun sir to kindly come onto the stage for his talk. Let's give a big round of applause. Thank you, sir. Next, I request Dr. Shanmugarajan sir to felicitate Dr. Joy Varghese sir for his talk too. I request Dr. Shanmugarajan sir to felicitate Dr. Pandurangan sir for his talk. I request A.C. Arun sir to felicitate Dr. Shanmugarajan sir for chairing the session. Thank you, sir.
We'll move on to the next session. Let's begin our next session on Learn from the Masters, starting with Dr. Apandraj's talk on imiglamin. I request Dr. M. Nadarajan sir, Dr. Venkatesh sir to chair this talk for the next 6 topics together. Please come over to the dais. I request the chairpersons to introduce the speaker.
Good afternoon, everybody. And we are going to learn from the masters of all the newer drugs which are come into vogue in the treatment of diabetes. And for the first topic, I invite Dr. S. Appanraj sir, who is a professor and head of the department in MAP IMS Mel Maruvattur. And he is a member of API, RSDA, IMA, and ESH. He is the organizing secretary and scientific committee chairman, MIT Tapicon 2022, resource faculty for revised basic course workshop, CISO, and curriculum committee member since 2018. He is an executive council member in TN API and had won first prize in ECHO workshop in 2012. He has many 15 international papers publications presented so far, and his areas of interest are diabetology and clinical cardiology. And over to him for introducing the newer drug imiglamin in the treatment of diabetes mellitus.
Good morning, good afternoon everyone. I thank the organizers for giving me the opportunity and chairpersons for wonderful introduction. Novel approach for diabetic control. Glimins, the mitochondrial dysfunction, is considered as the heart of type 2 diabetes mellitus. It increases the beta cell dysfunction, it decreases the glucose reuptake, and increases the hepatic gluconeogenesis. Hence, mitochondrial dysfunction plays a major role in the formation of diabetes. And this omnious octet and complications because of the fat cells, there is accelerated lipolysis, gastrointestinal tract, increasing deficiency and resistance, and alpha cell, hyperglucogonemia. All these are going to cause mitochondrial dysfunction, which leads to hyperglycemia and endothelial dysfunction, which leads to the cardiac steatosis. And metabolic inflexibility and mitochondrial dysfunction is at the heart of the matter. Genetic factors and the environmental factors together causes the mitochondrial dysfunction, and this mitochondrial dysfunction in turn causes beta cell dysfunction, and it increases the insulin resistance. This leads to type 2 diabetes mellitus. And metabolic inflexibility, when it is flexible, it has a very good functioning of the hepatic, smooth muscle, pancreas, and the cardiac tissues. But alternate switching of metabolic fuels is lost whenever there is a chronic fat or carbohydrate feed, obesity, and in type 2 diabetes mellitus. Because of the metabolic inflexibility in type 2 diabetes and adiposity, there is decrease in the glucose substrates, and this causes increase in the gluconeogenesis. This increases the fuel substrate availability and increase in the reactive oxygen species. This causes increase in the acetylation. This reduces the cellular energetics, decrease in ATP-ADP ratio, and thereby decreases the insulin sensitivity as well as insulin secretion. A drug that acts on this and reverses this is going to be a boon for diabetic patients. So metabolic dysfunction by means of decreased substrate utilization for the ATP generation leads to macrovascular and microvascular complications. It increases hyperglycemia, dyslipidemia, and hypertension. So imiglamin, it goes beyond the metformin. It is a triazine compound. It is the first one of the glymin groups. It has been introduced in 2007, and it has been approved in China and Japan for almost more than 1 year. And imiglamin contains a biguanide structure bearing similarity with the metformin, but it has additional C atoms with the cyclopentane ring. And these structural similarities and differences makes it to give complementary effect to the metformin when it is used with the metformin. Imiglamin has dual action on insulin resistance as well as beta cell dysfunction. It increases the insulin sensitivity. It decreases the oxidative stress. It decreases the gluconeogenesis. It increases the beta cell function, and it increases the mitochondrial function. By all this means, it improves the insulin resistance and insulin secretory defect by modulation of the mitochondrial function. So it modulates, it decreases C1 complex and it increases the C3 complex. So whenever there is increase in the C3 complex, it has positive NAD equilibrium. Because of this, increase in the K plus ATP closure occurs. So the calcium channel influx takes place. So when the calcium channel influx takes place, there is insulin release from the beta cells. This mediated insulin secretion is found to be beneficial for the patients. Imiglamin impacts the insulin sensitivity. It increases insulin receptor substrate activity. It increases the downstream signaling. Thereby, in future studies, it can give decrease in the micro and macrovascular complications because of decreasing the reactive oxygen species. So it has a positive increased cellular energetics by increasing the GLUT4 activity, and this causes increase in the glucose transport and in turn insulin sensitivity. So it increases insulin secretion as well as increases the insulin sensitivity. So imiglamin is considered as a mitochondrial re-energizer. It decreases complex 1. So by decreasing complex 1, it decreases the reactive oxygen species, thereby the complications. By positive NAD equilibrium, it increases the cardiac energetics and insulin secretion. By increasing the C3, it increases the insulin sensitivity as well as insulin secretion. So hemoglobin modulates the cellular energetics, so it increases the bioenergetics, it increases the fat oxidation, it decreases the glucose production, it increases the insulin secretion and also the glucose uptake in turn. So when it compares with the metformin and sulfonylurea, it modulates big effects. So it not only do what metformin and sulfonylurea does, it increases the mitochondrial ETC, so NAD salvage pathway, which is not present in the metformin or sulfonylurea. It causes increase in the ATP closure, which is found only in the sulfonylurea and metformin. So when it has been used with others, there could be a possibility of better HbA1c reduction. And anything has to be substantiated by the studies. We have studies times 1, times 2 and times 3 in the Japan population, and all three are randomized control study and completed the phase 3. And the dose that has been approved for this is 1000 milligram twice daily, because 500 milligram BD is found to be less effective in reducing the HbA1c. And consistently it gives better HbA1c reduction than the placebo. And it shows decrease in the HbA1c, decrease in the fasting blood glucose, and also reduced adverse effects even when compared to that of the placebo. It has benign adverse effects. And it also reduces the pro-insulin ratio and also the pro-insulin C-peptide ratio, which is a favorable outcome. And when it also reduces the HOMA-IR and HOMA-beta cell function and insulin resistance. Imeglimin is a novel glimmin oral antibiotic. It exhibits a good efficacy and safety in type 2 diabetic patients in all these studies, and with the low intensity and frequency of GI adverse effects when compared to that of the metformin. And times 2 study also have proven beyond doubt the HbA1c has been reduced from 0.5 to 0.9% as an add-on therapy. And times 3 study also decreases the HbA1c by 0.6 to 0.7 even in the extended period as an add-on therapy. Significant decrease in the fasting blood glucose also has been seen, and also the reduction in the total LDC. So insulin sparing also has been seen, because the dose has been reduced more in the hemoglobin arm when compared to that of the placebo arm. And a study has been done with the glucose sensed by the intermittently scanned continuous glucose monitoring, which has increase in the time in range with very minimal increase in the time below range. So that means even the hypoglycemia effect with the good favorable outcome is very less. So hemoglobin, there are 1555 patients have been enrolled in the 8 studies, and this meta-analysis shows it has very low adverse effects, very low hypoglycemia and other GI outcomes when compared to that of other placebo or other drugs. Hemoglobin, the highlights, it is the first in this class. It is dual acting OAD, novel mechanism, and it modulates the cellular respiration or oxidative proliferation, phosphorylation. It modulates the big effects. It reverses the beta cell function, it increases the beta cell function, decreases the hepatic gluconeogenesis, and increases the glucose reuptake. It is safe and well tolerated, which has been supported by many studies and meta-analysis. Thank you.
Thank you, sir. Discussion we'll have at the end of the session. For the second talk, I request Dr. D. Selvaraj, sir, to please come to the dais to talk about SGLT2 inhibitors.
Good afternoon. It gives me immense pleasure in introducing Dr. D. Selvaraj sir from Tuticorin, who is a senior most member of API, to give his talk on SGLT2 inhibitors. Sir needs no introduction. Sir is a consultant chairman at SRRA Hospital, Tuticorin. Sir is a present chairman of APA Tuticorin chapter and vice chairman RSSD Tamil Nadu. Has conducted one-day medicine update at Tuticorin 3 times and conducted one-day ECG workshops at Tuticorin. Has conducted regular screening camps for hypertension, diabetes, heart disease on December 23rd, Physicians Day regularly. Conducting diabetes screening camp for complications on November 14th, the World Diabetes Day. Is conducted Tapicon at Tuticorin in 2016. As a conducted TNet RSSTA conference track at Tuticorin in 2011. So over to you, sir.
How to make full screen? Okay. At the outset, I am extremely thankful to the organizing committee for giving me the opportunity to take part in this Tapicon 2022 at Trichy. And my topic is SGLT2 inhibitors. This is a very big topic, very difficult to cover within 10 minutes. Anyhow, I will give you the bird's eye view of SGLT inhibitor. What Dr. Sanmuel, my friend who spoke yesterday, is again the repetition. And again there is so many repetition in the hall A also. So SGLT2 inhibitor is a group of drugs that reduce the renal glucose reabsorption in the proximal convoluted tubule, leading to increased urinary glucose excretion. The drugs commonly available are dapagliflozin, canal, and empagliflozin, and again the etugliflozin. The commonly used drugs here are the dapa, cana, and empa, and rimogliflozin, one of the Indian discoveries. And the etugliflozin is not available in this country. So SGLT inhibitors, normally the glucose is reabsorbed by SGLT2 receptors and no glucose is available in the urine. By the proximal convoluted tubule it is absorbed. Where when you are given the SGLT2 inhibitor, the glucose reabsorption is blocked at proximal convoluted tubule and your urine shows a lot of glucose. And there is a pharmacological difference between SGLT inhibitors. The half-life is almost very long in etugliflozin, which is not available, and oral bioavailability is also very long in etugliflozin, and volume distribution is almost equal in all the drugs, and plasma binding capacity is more with canagliflozin, and all these SGLT inhibitors are metabolized, hepatically conjugated and excreted in through kidney. And SGLT2 inhibitors, if you take the binding capacity, 2500 times more powerful in as far as empagliflozin is concerned. And again, if you take the renal consideration, efficacy decreases with the worsening of the renal function, and the risk of renal adverse effects is increased in elderly people and people with a comorbid condition, and acute kidney injury is recorded in people using canagliflozin and dapagliflozin. The drugs available dose is empagliflozin 10 milligram and 25, dapa 5 and 10, and cana 100 and 300. But we normally use 100 milligram. And when eGFR is less than 20 to 30 ml in both dapa and canagliflozin, it's not recommended to improve your glycemic control. And empagliflozin again is eGFR less than 20, and it should not be recommended for initiation of treatment. And also it can be used as 10 milligram to reduce the eGFR decline in kidney disease and end-stage renal disease, CV death, and hospitalization for heart failure. It is again contraindicated patients on dialysis. And dapagliflozin is also not recommended in improving glycemic control patient with the type 2 diabetes when eGFR is less than 25. But between 25 and above that, the initiation is not recommended. Can continue 10 milligram once a day to reduce eGFR decline, end-stage renal disease, and again for heart failure administration and contraindicated people with the dialysis. Canagliflozin again is not recommended less than eGFR less than 30 to 60 for people with diabetes for control of blood sugar. It is the one more important indication is it is indicated people with albuminuria, again contraindicated people on dialysis. What is the pharmacological difference between the SGL inhibitors? The FDA approved indications for these drugs are cardiovascular and renal consideration, and empagliflozin is mainly approved for the prevention of cardiovascular disease in people with type 2 diabetes and the increased risk factors. Again, it is recommended in people with heart failure for the decrease of the cardiac risk factors and admission due to the cardiac failure. And again, it decreases the progression of renal disease. Again, the dapagliflozin is also to reduce the risk of hospitalization for heart failure in patients with increased risk of CV risk, and again heart failure to reduce the admission to the hospital. Again, this is recommended in people with CKD and for the decline of EGFR and hospitalization for heart failure in patients with renal disease also. Canagliflozin is mainly used in people to reduce the 3-point MACE. Again, it is people with the diabetic nephropathy and there is albuminuria. This is mostly indicated. And difference in adverse profile is very important. It will cause all these drugs will cause urinary tract infection and genital myocardial infection. These genital myocardial infections are more common in females than compared with males in all these drugs. And if you take the empagliflozin, apart from that, it will cause upper respiratory infection and dyslipidemia and arthralgia, where dapagliflozin will cause back pain and dyslipidemia and constipation. And canagliflozin, if you take apart from the genital myocardial infection, of the 3 drugs, it will cause more of genital myocardial infection. It will cause nausea and also cause vulvovaginitis pruritus in female. Again, the sodium glucotransporter inhibitor, it is hypoglycemia is less, weight, there is a definite loss of weight loss, and you should use with caution in people with urinary and genital tract infection. It is neutral in gastrointestinal adverse effect, and the cardiac and atherosclerotic cardiovascular disk and CV death, it is beneficial. In bone disease, it should be very careful in using the drugs will cause fractures. Again, it must be you must use with careful in people causing decay occurring in volume depleting conditions. And there is changes in metabolic outcome in patients on SGL inhibitor in various EOT trials. If you take HbA1c, the maximum reduction occurs in canagliflozin, and body weight is again also maximum reduced in EMPA, and systolic blood pressure is most reduced in canagliflozin, and composite renal outcome and measures are decreased in that is dapagliflozin. And again, the progression of albuminuria is mostly decreased in patients on the canagliflozin. And for the benefit of postgraduates, these are all the trials. When we entered into the diabetic era some 30 years back, we were told the DCCT trial and the Eucapides trial. Still we are learning about this trial. Like that, if you remember this trial, that is declare TIMI, DAPA-HS and DAPA-CKD for the empagliflozin, dapagliflozin, and CANVAS trial and credence trial for canagliflozin, and EMPA-REC and Emperor reduced trial for empagliflozin. You remember these 5 trials, it will stand in the field of medicine for another 20 to 30 years. And changes in cardiovascular outcomes in these trials are if you take the declare TIMI, that is dapagliflozin, and the 3-point MACE is reduced. Again, the empagliflozin, the hazard ratio is favorable in 3-point MACE reduction. Again, the CV death and non-fatal myocardial infarction, non-fatal stroke, all are favorable in empagliflozin. If you take all-cause mortality, again reduced in empagliflozin, and again the heart failure for admission also in favor of empagliflozin. This is the favorite slide everybody must have seen. Again, the European Society of Cardiology and other task force says it is used in heart failure and type 2 diabetes with high cardiovascular risk factors and chronic kidney disease. This is again do's and don'ts when you use this glucose lowering drug, and you should take caution in risk in volume depletion condition. Be careful in complicated UTI, history of recurrent UTI, and improper genital hygiene. Again, these are all the benefits and risks of patients with it. The ICE phenomenon in diabetic cardiomyopathy is the hyperglycemia will cause, there is a advanced glycation end products, mitochondrial dysfunction lead to increased oxidative stress. Again, all these along with hypertension and diabetes go to heart failure and benefited by the these SGLT inhibitors. Again, there is empagliflozin offers early risk reduction, CV death, and the overall reduction is 38 point relative risk reduction. Subgroups there is 58 point relative risk reduction. And chronic disease in type 2 diabetes, this is patient on healthy kidney and diabetic kidney. There is a difference of basement membrane and other podocyte loss. Again, the hypertrophy is decreased. The patient put on patients on SGLT inhibitor, there is a definite decrease in hypertrophy. Again, the EGFR decrease is very much in patients on SGLT inhibitors compared with the placebo. The kidney outcome by baseline, that is albuminuria increases by the increase of albuminuria in patients on the patients with the type 2 diabetes and albuminuria. Again, the empagliflozin serum potassium is in favorable when compared with the placebo. These are all the various dedicated TKD outcome trials like the Credence trial in 2018 and Fidelio and Fiderio trials in patients with Phenerenon. Again, Emphara kidney in 2022 and 2024, the latest trial, flow trial using semaglutide, where Dr. Shanmel is going to talk to you. These are all the treatment algorithm patient type 2 diabetes CKD. The main one is lifestyle changes, physical activity, nutrition and weight loss. Then first line drug metformin SGL2. Metformin should not be used when AGFR is less than 30, careful below 45. SGLT inhibitors less than 22, 20 should not be used, also contraindicated in dialysis patients. Then additional drug therapy includes GLP-1 receptor agonist, DPP-4 inhibitor, sulfonylurea and insulin according to patient convenience and selection. Thank you very much for your patient hearing.
Thank you, sir. We'll now move on to the third talk on semaglutide. I now request Dr. M. Shanmugavelu, sir, to come to the dais. I request the speaker, chairpersons to introduce the speaker.
No problem, sir. So now, sir needs no introduction, and he's a very well-known speaker. He is going to speak on semaglutide, both oral and injectables.
Sorry. I have already given my pre. No, this is not. This is not. The thing is, I have given to your colleague in preview room to get it uploaded, and he said he's done it.
Okay. So now, over to the next speaker on the talk on Finrenone.
I call upon Dr. S. Priyadarshini to deliver a talk on Finrenone.
Good afternoon, all. Thank you, the organizing team, organizing secretary, Dr. Muthamani sir, to giving me this wonderful opportunity. It's quite difficult to compress the whole drug, especially the newer drug, which is on the catwalk in the diabetic forum, within 10 minutes. Let me try to finish this. Next slide. Okay, so this is a short preview of what I'm going to talk in the 8 to 10 minutes with a few words on the burden of diabetes, CKD and CV disease in India and about the pathogenesis of progression of DKD, the association between the CKD and the cardiovascular disease, the available pluripotent drugs available. We can go to the topic proper of finerenone, its structure, pharmacokinetics and pharmacodynamics, the studies establishing its potential role in diabetic and CKD patient, then comparison with the other mineralocorticoid antagonist which is available, dosing and side effects finally. So with the introduction, we are all very well aware that India has become the second capital of diabetes. This is a very bitter truth. And in the low and the middle income countries, CKD is diagnosed only at the end stages. So the affordability in our country for RRT and transplant is very less. And this is the commonest cause for CKD in our country. So despite the adequate glycemic control and the BP treatment with the RAS inhibitors especially, there is more than 30% of patients with type 2 diabetes who develop CKD. So this needs to be addressed. That is why there are a lot of innovative drugs which is on the go for the ramp walk on the diabetic dais. So prevention is definitely better than cure. All the international forums like the ADA, KIDCO and the EASD has given us guideline recommendation for how to screen and to whom to screen. So all the diabetic patient, the screening has to be done with the urine albumin creatinine ratio and eGFR measurement yearly. And in patient with GFR between 30 to 60, twice it should be done. So with this, we will see the pathogenesis of DKD progression. Yes, we know the drivers of the CKD in type 2 diabetes, especially the hemodynamic factors, where we were very well aware of the rise in the intraglomerular pressure, which is caused by the afferent arterial dilatation, efferent arterial constriction, thereby the raised intraglomerular pressure causes the fibrosis. Apart from the AGEs, that is the advanced glycosylation end products, and other the reactive oxygen species that can directly impact the kidneys by causing fibrosis. So with the hemodynamics, the metabolic profile and the inflammation which is associated, it progresses to the end stage renal failure. So what is the association between the kidney and the heart? So apart from the traditional risk factors like the advanced age, hypertension and diabetes mellitus and dyslipidemia, the presence of CKD, especially in the albuminuric stage, itself carries a cardiovascular risk. That is what that needs to be addressed now. So along with anemia, increased vascular stiffness and the prothrombotic milieu that happens with CKD, there is a direct impact on the coronary arteries. So this is very well shown by the UK CPRE trial, which is a very large study with around 1 lakh population. In the 30,000 population with CKD and diabetes has been taken into, and the CV morbidity which is associated with the following data, that is the MACE plus, incidence of heart failure, the myocardial infarction and the ischemic stroke has been increasing with progressive decline in the eGFR. So this has also been documented with the other study CRIC with around 4,000 patients where the adjusted risk of death, the adjusted risk of cardiovascular events with decrease in slope of eGFR has been well documented. So pluripotent drugs, that is which can affect or address multiple parts of a diabetic population, is under use now. So to that, our new drug has been introduced. So apart from the RAS inhibition, we have the SGLT2 inhibitors, which is very well elaborated by two speakers yesterday and today. And GLP-1 analogs, we have the newer non-steroidal mineralocorticoid antagonist. So with the credence trial, the DAPA DKD, again showing impact with the decrease in the progression of CKD to ESRD. Still, the population with the usage of RAS inhibition, the canagliflozin, dapagliflozin, the percentage of patient going for ESRD is more than 15%. So what else we are left with? Yes, there is a potential role for mineralocorticoid antagonist. Others are all steroidal, so this can have a sex steroid receptor binding that can cause the other side effects like the gynecomastia and all those things. So we have come with the non-steroidal antagonist, which does not have much impact on the other receptors. So we all know that the MR is being present in the cardiac myocardium, which is well documented by the incidence of myocardial fibrosis in patients with hyperaldosteronemia or the Conn syndrome. So the mineralocorticoid receptor present in the kidneys and the CVS is being taken care of by this mineralocorticoid antagonist. The other being will be discussed later. So coming to the pathology or the mechanism of action of mineralocorticoid receptor antagonist, apart from sodium retention, there is an impact on the ventricular remodeling and hypertrophy, along with decrease in the fibrosis and inflammation on the kidney tubules. So this slide shows the mechanism of action of the mineralocorticoid antagonist, our finerenone, or the other, apart from the other available MRAs like the eplerenone and the spironolactone. So with mineralocorticoid activation, there is increased NADPH, more reactive oxygen species has been formed. With decrease in nitric oxide, there is a progressive renal inflammatory and fibrosis. So the left side of the slide shows with the usage of phenylephrine 10 milligram per day, there is a decreased incidence of tubular inflammation and fibrosis. Thereby, the progressive decline in GFR has been addressed. So this is like sir has already mentioned about the two sister trials, the Fidelity and the Figaro DKD analysis, which is a very large randomized control trial, double-blind trial. The patients with a mean age of 65 years has been taken with an HbA1c of approximately 7.7. The patient on tolerable dose of RAS inhibition with an adequate BP control. These patients have been selected. The primary endpoint of this analysis will be the renal. That is, the progressive decline in eGFR has been taken into account, which is shown to have a very good impact with the usage of phenylephrine of 10 to 20 milligram per day. The secondary endpoint being the composite cardiovascular outcome event. So this is the analysis where it had shown that there is a decrease in 23% of relative risk reduction of kidney outcome event versus the placebo, and less than a decrease in 20% relative risk reduction of the ESRD versus the placebo. So to conclude, definitely the primary outcome of decreasing incidence of the decline in eGFR has been come to some extent, and there is a chances of reversal of albuminuria. So most of the patients are albuminuric in this study. The other one positive point is that this decreases the incidence of atrial fibrillation and flutter, which has been taken as one other positive point from this study. So coming to the Figaro DKD, this is the other sister trial. Again, it's a RCT, double-blinded. All the type 2 diabetic patients has been taken with a mean study period of 3.4 years with patients on adequate RAS blockade with a maximal tolerable dose, and adequate BP control has been taken into, the primary endpoint being the cardiovascular event outcome. So phenylephrine again with 10 to 20 milligrams, it has shown to decrease the relative risk reduction by 13% of CV events. That is a MACE plus. And the secondary outcome being the decline in the eGFR. So the baseline characteristics compared to both will be the trial duration approximately 5 to 6 years, and diabetes duration approximately 14 to 16 years with average HbA1c of 7.7. And of course, being a MR antagonist, we are worried about the potassium level. So patient with a normal potassium level has been taken into account. Anything more than 5.3 has been excluded. So the eGFR in the Fidelo will be around 25 to 60, and from the Figaro they have taken the higher eGFR around 90 with albuminuric patients. So this is a comparison where the 17.8% the phenylephrine group has got a progressive decline in eGFR advantage over the placebo, and in the Figaro predominantly it is the incidence of MACE plus events by 12.4% in phenylephrine group compared to the 14.2% in the placebo group. So compared to other mineralocorticoid antagonists, that is the eplerenone and the spironolactone, phenylephrine has got more MR selectivity. It has got a different mechanism of action. Being a non-steroidal drug, it does not cause other side effects like the gynecomastia, and it has got equal distribution in the heart and the kidneys, where there is a skewed distribution in both the spironolactone and eplerenone, which gets concentrated more in the kidneys. So the renal excretion will be less than 1%. So there is a bit different mechanism compared to the other available MRs. That is, it is an inverse agonist. That is, it inhibits the cofactor binding even in the absence of aldosterone. That is one advantage. Whether an extra pill is really needed or not with this cost, already the patient will be asking so many questions to add a new drug, which is of course economically a bit difficult also. Yes, the AHA, ADA have come out with the current guidelines in the June, where they had shown a definite role in patients with the diabetic kidney disease in the albuminuric stage with the GFR more than 25, decreasing the incidence of ESRD and patient going in for RRT. Along with AACE, what they have told us, any person having GFR more than 25 with a normal serum potassium and albuminuria, that is urine ACR more than 30 milligrams with maximal tolerated dose of RAS inhibition, it comes as strong 1A recommendation. So elimination is exclusively through cytochrome P450. So needs to be aware of the drugs that inhibit cytochrome P450. So grapefruit juice, as it inhibits the CYP, it has to be avoided. So coming to the dosages, more than 60, it is 20 milligram once daily. 25 to 60, it is 10 milligram once daily. Less than 25, it is definitely contraindicated. Of course, normal potassium has to be maintained. If it is like more than 5.5, definitely stop the therapy. So coming to side effects, the presence of hypotension, anemia and hyperkalemia, even though the DKD study group Fidello have shown that the incidence is very less, it has to be kept in mind. Coming to anemia, there is a decrease in the mean HB of 0.14 gram per deciliter and mean hematocrit reduction of 0.46. Even though it is insignificant, this has to be taken into account. So hyperkalemia, obviously it's a contraindication. So coming to few contraindications, concomitant treatment with other strong inhibitors of cytochrome P3A4 has to be stopped. And patients with Addison's disease, they are more prone for hypotension. So along with hepatic impairment, it is contraindicated in the other scenarios mentioned. And coming to pregnancy and lactation, it is excreted in the human milk. It is shown by animal models. There is no big indication or contraindication that has been established till now. So to summarize, capital of diabetes being India as the second, the CKD, the reason behind will be the predominantly the type 2 diabetes in our country. Despite adequate glycemic control, the DKD progresses. So a lot of pluripotent drugs are available. It has to be individualized in every patient. Definitely prevention is better than cure. Thank you.
Thank you, ma'am. We'll move on to a talk on semaglutide by Dr. Shanmugavelu, sir.
What is the problem? No, no. But it's not appearing. So I need to look this side. As a respected chairperson, senior doctors, my doctor friends, I feel extremely happy to make a presentation on semaglutide. We have two formulations. One is injectable formulation as well as oral formulation. Currently, it is the oral formulation that is available in our country. Of course, injectable formulation of semaglutide will be available soon. But the thing is, the indication is going to be changed for the management of obesity. So for the management of hyperglycemic patient in the type 2, we have oral semaglutide. So my focus will be on evidence and outcomes. I thank chairperson for his introduction. Also thank organizing committee members for giving me an opportunity to talk in this forum. My disclosures, of course, I have no conflict of interest in relation to my presentation. Type 2 diabetes is a multi-causal, heterogeneous, progressive cardiometabolic condition. The progressive nature is one of the major challenges. So getting the patients to goal become challenging as the disease progresses. Early intensive therapeutic control has proven benefits in clinical outcome. And agents like SGLT2 inhibitors and GLP proven to reduce adverse cardiovascular outcomes in patients has triggered a major paradigm shift from one of glucose-centric approach to one of patient-centric approach, taking into consideration all the relevant comprehensive CV risk reduction. So thin fat Indian phenotype, so thin fat Indian with high visceral fat, high insulin resistance, high risk for diabetes related complication and high cardiovascular risk. So newly detected patients with type 2, they have elevated levels of DPP4 enzyme in the fasting state and an exaggerated response rate in the postprandial period. So there is a definite role for incretin-based therapies. The efficacy, safety and magnitude are encouraging and more pronounced. These are the myriads of effects of GLP in human body. The action on the liver, heart, blood vessels, brain, muscles, kidneys, GI tract, and pancreas. So if you look into patients with type 2 diabetes, inadequately controlled on 2 OADs, what next? We have insulin, other OADs, and GLP-1 receptor analogs. So treatment intensification with the GLP-1 receptor analog provided significant benefits in terms of glycemic control, weight, composite outcomes, and even pill burden with additional OADs or insulin respectively. So GLP receptor analogs, we have injectable formulation, which can be given twice daily, once weekly, and we have oral formulation also. They differ in terms of the structure, duration of action, mechanism of action, time, metabolism, and elimination, dosing, and administration. Overall, they differ with reference to size, with reference to structure, pharmacokinetic, and dynamic profiles. So the quest for an ideal anti-diabetic drug continues. But here is a GLP-1 receptor analog which showed improvement with reference to glycemic parameters, associated with the low risk of hypoglycemia, weight reduction, cardiovascular benefits, tolerable side effects profile, and approved with a variety of indications. So next is multifactorial mechanisms and final effects. So the targets, Mainly, it stimulates the pancreatic beta cells to secrete insulin in a glucose-dependent manner, suppresses glucagon released by the alpha cells again in a glucose-dependent manner, and the intermediate effects are predominantly on the beta cell survival, protecting a potential neuroprotection with a favorable impact on postprandial lipids, LV function, coagulation. The final effects are improvement with reference to glycemic control, weight reduction, CV benefits, blood pressure, and reduction in albumin excretion. So the challenge, large molecules, the fear of injections may still remain a barrier to the use of GLP-1 receptor analog in both patient as well as physician. So patient-related as well as physician barrier. So what do patients prefer? Increasing patient convenience when we move from vial and syringe, including injectable delivery device, to oral tablet formulation. So patient needs a safe, non-invasive, convenient mode of therapy with improved patient compliance, early commencement of treatment, as well as address the barriers with reference to subcutaneous administration. So the quest for first ever oral GLP-1 receptor analog. When we take peptides orally, what happens? There is a degradation in the stomach in view of low pH and proteolytic enzyme, limited permeability across the gastrointestinal epithelium, and very important thing is low oral bioavailability. These are all the challenges we come across when peptides are taken orally. So semaglutide, the availability as peptide in a pill, which shares 94% homology to human GLP-1 receptor analog with a half-life of approximately 1 week. So you are seeing the primary structure of GLP-1 analog. Certain modifications are made in the primary structure to get this particular drug in this oral form, in injectable formulation. Now we have the semaglutide, which is available as a co-formulation, the most effective GLP-1 receptor analog tested today, in combination with a snack. That is nothing but absorption enhancer. That is sodium N-hydroxybenzoyl aminocaprylate, which promotes semaglutide absorption across the gastric epithelium, enhances semaglutide oral bioavailability. So scientific breakthrough, first in class, Novo Nordisk, they have brought this particular innovative molecule, a new oral route administration, possibly with an absorption enhancer, and mitigated by 1 week half-life, once daily dosing, several treatment doses. So exposure response. So given subcutaneously, that is 0.5 and 1 milligram. Given orally, that is 3 milligram, 7 milligram orally. If you look into the exposure response relationship, overall the various trials clearly shown the exposure response, that is a population for similar. The exposure range was wider with oral, but very important thing is there is an overlap. This exposure response showed greater A1C and body weight reductions and more GI-related side effects with increasing semaglutide exposure. It is convenient for you and your patients. No dosage adjustment recommended, regardless of the renal and hepatic impairment. No dose adjustment recommended in elderly patients associated with the low risk of hypoglycemia. Then how to administer? Take when you wake up on empty stomach with 120 ml of water, and then wait at least 30 minutes. So it has to be administered on an empty stomach, followed by post-dosing fasting for 30 minutes. These are mandatory to ensure sufficient serum exposure to initiate its pharmacodynamic as well as kinetic action. Advise patients that if they miss a dose, they should skip the missed dose. So peptide innovation, file in clinical trials, so many subjects exposed to oral semaglutide, 24 clinical pharmacology, 1 phase 2 trial, and 10 phase 3A trials. So Pioneer trial comparing this particular oral semaglutide versus placebo versus SGLT2 inhibitor, DPP4 inhibitor, next is other GLP-1 receptor analogs, as well as Pioneer 6 add-on to insulin, and we have Pioneer S in renal impairment, and so on. In all the trial, the primary endpoint, change in A1C, change in body weight, and with reference to Pioneer 6, that is time to first 3-point maze and time of first expanded composite CV endpoint, and proportion of patient achieving the A1C target less than 7, as well as the change in body weight. So if you look into all the trials, change in A1C across global Pioneer trials, oral semaglutide achieved A1C reduction of up to 1.5%. Across Pioneer trials, 7 out of 10 patients achieved the A1C reduction of less than 7 with oral semaglutide. In post-hoc analysis, with baseline A1C greater than 9%, oral semaglutide resulted in A1C reduction of up to 2.6%. And next is time spent in glycemic control. 40% greater time spent in glycemic control with oral sema compared to SGLT2 inhibitor EMPA. Next is change in body weight, end of treatment. Across global pioneer trials, oral semaglutide achieved weight reduction of up to 5 kg. Next is proportion of patients achieving the body weight loss of more than 5%. That is significantly more number of patients achieve the weight loss of greater than 5%. Next is A1C reduction more than 1% and body weight loss of more than 5%. Again, oral semaglutide 14 milligram. Higher proportion of patients achieve the A1C reduction of greater than 1% and weight loss of more than 5%. Next is A1C reduction of more than 5% and body weight loss of greater than 5% compared to placebo, EMPA, Citar, Lira, as well as other placebo. With oral semaglutide, odds ratio were significantly higher to achieve A1C reduction of greater than 1% and weight loss of greater than 5% compared to placebo and comparators. Next is with reference to cardiovascular outcome trial. That is the time to first occurrence of CV, death, non-fatal MI, non-fatal stroke. Pioneer 6 overall summary shown in this particular panel. So oral semaglutide achieved its primary endpoint of MACE reduction versus placebo with a 20% non-significant risk reduction. So efficacy outcomes, change in A1C, change in body weight. A1C and body weight decrease more in the oral semaglutide group compared to placebo group. So pooled cardiovascular outcome data comparing Sustain 6 with injectable formulation and Pioneer 6 oral formulation. And if you see the Sustain and Pioneer combined, semaglutide showed consistent effect on MACE with a 24% risk reduction versus comparators across varying CV risk. So ideal patients for initiation of oral semaglutide. Patients taking one or more OAD with adequate, that is including metformin with inadequate glycemic control. Patient for whom weight loss would be beneficial. Patient in whom hypo is concerned. Patient already receiving injectable GLP-1 receptor, not achieving glycemic target, and patient with established CVD or high risk, and patient with established renal or hepatic dysfunction. So starting, always titrate the dose progressively. Start low, go slow. Patient education, side effects, dietary advice, very important. Smaller meals, eat slowly, stop before feeling full, reduce food consumption. These are all the measures that we need to provide. That is patient education, helps address potential GI-related side effects. And of course, they are the GLP-1 receptor analogs among the most effective medication. Oral semaglutide is a scientific breakthrough in innovation across global pioneer trials, proven its efficacy and achieved A1C reduction. It has been found to reduce A1C more than SGLT2 and DPP4. In patients with greater A1C, that is more than 9%, it resulted in A1C reduction up to 6%, and it has proven CV safety in Pioneer 6, and efficacy was established when given early in therapy and late in therapy, and regardless of renal or hepatic impairment. Thank you very much for your nice listening.
Thank you so much, sir. We'll move on to the fifth talk of the day, Patiromer by Dr. S. Srinivas. I call Dr. Srinivasan, sir, to the dais.
It's a talk on Patiromer. Welcome Dr. Srinivas from Trichy. Sir is MD FRCP Glasgow, consultant physician Srinivas Hospital, Tilanagar, Trichy. He's the best outgoing student during PG course, medal holder of Cardiological Society of India during PG course, completed short course in diabetology, Newcastle University, conferred fellowship of Indian College of Physicians, January 2017, conferred a diploma of fellowship from Royal College of Physicians, 2021. Over to you, sir.
When I was talking to some of my colleagues in general medicine, I think most of them were a little unaware of this compound, including me, because I came to know just a year back about the availability of this compound. This Patiromer is nothing but, we'll be talking about the compound in due course. Actually, for the sake of the PGs, some bit of applied physiology, As all of us know about potassium homeostasis, because most of the potassium is intracellular and only 2% of the potassium is distributed outside the cell. Out of this 2%, most of it in the skeletal muscle, as all of us know, and out of the total intake of 60 to 140 milliequivalents of potassium per day, 90% of this potassium is excreted through the kidneys, and only 10% of the potassium comes out through the stools. This molecule, which I am just talking about, exploits this excretion of potassium through the stools, because this drug acts on the stools and the bowel and facilitates the elimination of potassium. This is a new drug which is used for hyperkalemia, and the indications, contraindications we will discuss in due course. As all of us know about physiology, the colonic enterocyte, which is seen in the center, the basolateral membrane, which contains the ATPase, that is the ATPase and the sodium chloride ATP co-transporter, both these enzymes push the potassium into the cell, and the potassium goes out. Sorry, I don't have a pointer, but the potassium comes out through the cell and goes to the apical part of the membrane, cell membrane, where it is pushed out into the lumen through the big potassium channels, which is denoted by this KCNMA1. So this big channel pushes out the potassium from inside the cell to the outside, to the colonic mucosa. This is the mechanism by which potassium comes out into the colonic mucosa. And another peculiarity of potassium is that this ion stays in the colonic lumen for a much longer time than any other location in the gastrointestinal tract. So this property of potassium is being used by this drug to facilitate the elimination of potassium. Especially in CKD and hyperkalemic patients, the secretion of this potassium into the lumen, colonic lumen, proportionately increases up to 8-fold through these big potassium channels. So sodium potassium ATPase and the sodium chloride co-transporter aids in the movement of this potassium, as just now I alluded to. This is the diagrammatic representation for every 3 sodium ions, 2 potassium ion comes into the cell. This all of us know in the physiology. Of course, a basic overview of this hyperkalemia, as especially we see in day-to-day practice, the commonest problem which you see is a diabetes, and basically patient being a diabetic itself, is prone to develop a potassium which is on the higher side. By mere uncontrolled glycemia, potassium shift out of the cells, and hyporeninemia, this hypoaldosteronism, all these factors give it a hyperkalemic tendency, and of course most of them have a mild CKD, mild moderate CKD, so renal failure contributes. And of course antibiotics which you use in patients with which you use day in and day out, they also tend to increase potassium. Heparin, especially in patients with ACS, and NSAIDs, which most often we forget. Most of the NSAIDs which we use nowadays in all these connective tissue diseases and rheumatological diseases, they are prone to land up the patient with a hyperkalemia. This has to be kept in mind practically also. Then collecting tubule dysfunction, of course the regular use of ACE inhibitors, ARB, ARNI and MRA, which is very common nowadays, and then reduce sodium excretion from the distal nephron. This is the contemporary approach to treat hyperkalemia which we practice day in and day out. Of course, potassium can be eliminated from the body through various mechanisms. Of course, one is through the membrane stabilization, which is done by the calcium gluconate, which we give for acute hyperkalemia. Of course, the down I have written as emergency management, intermediate and maintenance. Our drug comes into play only in the maintenance management. There is a patiromer comes in the maintenance management of hyperkalemia. Of course, in the emergent and intermediate phases, this drug doesn't have action. Of course, membrane stabilization done by calcium gluconate injection, which you give in the ICU, and potassium redistribution is done by insulin infusion and beta-2 adrenergic agonists like salbutamol, and potassium elimination is facilitated by this dialysis. Of course, that is well known. And of course, these drugs like sodium polystyrene sulfonate, patiromer, and sodium zirconium cyclosilicate, these are the newer drugs for potassium binding. They also help in elimination of potassium through the stools. Dialysis helps through the dialysis membrane. And of course, the other last one is the removal of and reduction of drugs that increases potassium, especially these RAS inhibitors. One of the RAS inhibitors, most of our patients are on one of these RAS inhibitors nowadays because the cardiorenal syndrome is quite often very common. So these are the ways by which we can handle potassium and aid in the elimination of potassium to avoid hyperkalemia. This new era in the treatment of hyperkalemia with the novel potassium binders came into focus some many decades ago, because this K bind which you use often in these patients with hyperkalemia stayed for quite a long time. And of course, the new drugs have come into play only for the past 5 years. This drug has been approved in 2015 by FDA, but unfortunately, this drug is still not widely available in our country. And when I inquired my nephrology colleagues in Trichy and even in corporate setup in Chennai, and they procure these drugs from maybe Singapore and UAE and things like that. Even though this is an excellent drug with a good safety profile, the unfortunate thing, it's not widely available. Of course, it's a little costly, but when considering dialysis and other treatment, this is worth buying. These patriromer and sodium SCZC have a role in managing chronic hyperglycemia, as I just told you, and sustained normokalemia up to 1 year can be maintained with these drugs. And optimization of RAS inhibitor therapy in CKD, heart failure, and diabetes can be done when the patient is put on this patriromer simultaneously. When the patient with RAS inhibitor develops hyperkalemia, when you exhibit this drug, these drugs prevent them from developing dangerous hyperkalemia and arrhythmias. They are very well tolerated, odorless and tasteless. Of course, coming to the drug proper, this is a novel, that is a spherical compound which is non-absorbable from the colon. So it gets excreted as such. When it's excreted as such, it binds the potassium in exchange for calcium. So calcium, this patriromer is nothing but a sorbitol calcium. This calcium in that patriromer get exchanged with the potassium. That's how this is a very potent potassium binder, approved by FDA, as I told, and it has a much better capacity of potassium binding than the other resins, and equally effective when taken with or without food, and most effective in patients with CKD, cardiac failure, and patients especially on RAS, one of the RAS inhibitors. It can be mixed with water like apple juice to form a suspension, and it stays in the intestine colon for a long time, where it exchanges potassium for calcium. The other drugs, other binding agents exchange potassium for sodium. So this sodium gets into the system and patient may become volume overloaded in the longer run. That side effect is not there in this particular compound. That is one advantage, especially in patients with decompensated cardiac failures. By binding potassium, it increases fecal excretion of potassium, thereby lowering the serum potassium. And since no patriromer is absorbed, it is excreted as such, it could affect the absorption of other drugs, especially this is important in clinical practice with metformin, thyroxine and ciprofloxacin. These drugs are better avoided when this drug is given along with patriromer, and they have to be spaced around 2.5 to 3 hours in between to prevent drug interaction in this colon. Of course, there are recent trials about patriromer right from 2015. These are many trials, like AMBER trial, OPAL trial, which has proven the efficacy of patriromer in the long run. Patriromer given for a longer period of time, maybe 2 months, 3 months, it helps the patient to stay on RAS inhibitor and aldosterone ARBs for the cardiac benefit. So that when normally what we do when patient lands up with hyperkalemia, we try to withdraw ARB. We try to withdraw one of these drugs on the RAS system, so that the cardiac side is in a disadvantage. So simultaneously you can exhibit RAS inhibitor and you give patriromer, they stay better, they are having the benefit of both. So this is a very big trial, this is a diamond trial by patriromer. The hyperkalemia with the heart failure, reduced ejection fraction. This patriromer, there were about 1,200 patients enrolled. It's a big trial. RAS inhibitors, patients on RAS inhibitors were enrolled. There were a 12-week run-in period and 26 weeks follow-up. Concurrent use of patriromer and high-dose MRA reduced the risk of hyperkalemia. The dosage of oral patriromer is around 8.4 per packet. It comes in multiples of 8.4, 16.8, 25.2. So, of course, the main thing, it can be titrated at weekly interval. The dose should not exceed this 25. Of course, side effects are gastrointestinal, mainly constipation, distension, hypokalemia, hypomagnesia, and flatulence. Absolute contraindication is, of course, hypersensitivity, and pregnancy and breastfeeding is a contraindication. As I told, drug interaction is there, so this is contraindicated in patients taking. Not contraindicated, the timing of the drug should be spaced accordingly when patient is on the other drug. Patriromer, a word about patriromer and cardiac failure. As just now I told, patients in cardiac failure who are on RAS inhibitor medications, they continue to stay on RAS inhibitor medication when they are exhibited patriromer. If this drug is not there, maybe we tend to withdraw one of those drugs like ramipril and other things, so that they are at a disadvantage from the cardiac side. So non-emergent management, FDA, just 1 minute please. FDA approval of patriromer was given in 2015. Mechanism of action, as I told, calcium, potassium, cation exchange, formulation, oral suspension, And of course, the prescription is of course oral. There is no other form available. Oral is 4.2 to 16 gram once or twice a day. Common adverse effect is of course gastrointestinal, just as now I told. The serious adverse effects are none have been described. Especially nowadays, what we use is K-bind. Commonly we use is sodium polystyrene sulfonate. One of the dangerous side effects is colonic necrosis. So you should be aware, especially in patients with post-operative patients, those who are in ileus, and those who have got intestinal infections. Of course, this is my last slide. Of course, this is what so far what I told is a symptomatic management of hyperkalemia. Of course, in chronic renal failure, obviously there will be hypokalemia, and most of the patients in GFR is less than 30. One word of caution to all the junior colleagues is whenever there is hyperkalemia, you have to evaluate for causes of hyperkalemia, find out what is the reason and eliminate those reasons to give a complete cure. Of course, ARBs, ACE inhibitors, all of us know, potassium sparing diet, all of us know. And the other thing, two things I just wanted to tell. One is NSAID, just now I told, patients who are on long-term NSAID, like COX-SIBs and other things for rheumatoid arthritis, so many other things, they reduce the aldosterone release from the adrenal, and that's how they cause hyperkalemia. And non-selective beta blockers, especially atenolol, propranolol, which patients come on, they also tend to develop hyperkalemia, which most of us maybe don't think about. So these are very common practical points I thought I'll mention in the last slide. Thank you very much.
Thank you, sir. To deliver the sixth and the final talk of this session, I request Dr. Malavali ma'am to come to the dais. The topic is on S-adenosylmethionine.
So now over to Malavali madam, who is going to speak on S-adenosylmethionine. And madam is an associate professor in KAPV Government Medical College, and she is a medical gastroenterologist and hepatologist, and practicing for 12 years as a gastroenterologist. Award of Excellence from Chennai District Collector for exemplary services in COVID pandemic. She has published papers in Indian and international journals, co-authored a book on preventive care in post-COVID patients, working on book on all about hepatitis B, physician's perspective. Over to madam.
Thank you, sir. Thank you for your kind words and introduction. Good afternoon to one and all, to respected chairpersons and my fellow physicians. My talk is on S-adenosylmethionine. I bring greetings from Mahatma Gandhi Memorial Government Hospital, which is attached to KVPV Government Medical College, Trichy. What is S-adenosylmethionine? I don't expect you to remember all the biochemical reactions. It's basically a essential fatty acid which is present in the food, methionine, which combines with the ATP of the cytosol of the cell to form S-adenosylmethionine. So, the physiological reactions you have to remember is transmethylation, that is the single carbon methyl transfer, sulfuration, where a cysteine gets converted into glutathione, and polyamine synthesis. So if this is the way where the S-adenosylmethionine gets donates its methyl group and becomes a S-adenosyl homocysteine. So this transmethylation reaction is important in the neurological disorders, where it is the single carbon methyl transfer helps in the degradation of monoamine neurotransmitters like noradrenaline, dopamine, and serotonin. This can be helpful in the treatment of dementia and minor depressive illness. However, with the advent of SSRIs, the role of same in treatment of major depressive and maniac illness is limited. Coming to liver. Why liver is important here in S-adenosylmethionine metabolism? It is a seat of metabolism. Methyl adenosyltransferase transferase is an enzyme where it helps both in the synthesis as well as in the degradation of S-adenosylmethionine, which means it maintains the balance of S-adenosylmethionine. So this S-adenosylmethionine levels is decreased in a chronic liver disease. So we have spectrum of chronic liver disease, viral induced, non-alcoholic fatty liver disease, especially it is on the rise post-COVID, and cholestasis, especially intrahepatic, and one thing missing is a drug-induced liver disease. So in a chronic liver disease, the spectrum of liver disease is in hepatitis, then it becomes, first it is a steatosis, then steatohepatitis, then it becomes a chronic liver disease. But what is very important here is the progression from a steatohepatitis to a cirrhosis. The major thing is the oxidative stress. So, and this oxidative stress only increases the ROS production, cell death by apoptosis, and promotion of fibrogenesis. So what is the role of SAME here? SAME will increase the hepatic glutathione levels, which is very important for this increased oxidative stress. So the dose of SAME is 400 to 800 milligram. You can be given up to 1200 milligram in divided doses, both oral as well as intravenous. And why I have compared N-acetylcysteine? It is a better antioxidant compared to SAME. And all of you as physicians must be using N-acetylcysteine. It is a better anti-inflammatory compared to SAME. Both are precursors of glutathione. So what is the role of SAME? It's basically the symptomatic reduction of asthenia, fatigue, excessive daytime sleepiness. There will be an improvement of cognitive dysfunction, orthostatic hypotension. All these will be in the early part of liver disease. So there are few randomized controlled trials which show there is reduction of serum bilirubin and ALT levels. This is because of an anti-inflammatory. This is through interferons, an antioxidant effect, but whether it is having an anti-fibrotic effect is questionable. This is the reason why it does not improve the prognosis or the survival benefit once it becomes a CLD. So to conclude, is it the same? My answer is partly yes. In the understanding of this molecule, it is a methyl donor. So in that, it can be used as for minor depressive illness. Because it is a precursor of glutathione, it reduces an oxidative stress. Maybe it is a supportive treatment in chronic liver disease, especially in early stages. Maybe it could add along with, there are trials which shows that vitamin E, pioglitazone will help in progression. Maybe it may be an additive effect along with these drugs. So it does not have much survival benefit in the outcome, but combined with other drugs, it can prevent progression of the disease. Ladies and gentlemen, thank you for your patient listening.
Thank you, ma'am. Today we have listened to 6 important drugs from heard from our 6 experts. Usually in conferences, we come to learn about all these drugs, where to use, when to use. And even though if you know the drugs also, what is the indication, clear-cut indications, and we will be having the courage to use these drugs in our practice. So now over to the audience to ask doubts regarding the session, the 6 drugs that they have spoken about. Sir, regarding imiglamin, sir. Sir, you have said there are more mode of actions. It is helpful in the secretory defects. It addresses the insulin resistance.
Yes, sir.
So it can be used as an insulin sensitizer. It is much better than metformin you have compared, sir. So it is it an ideal drug to be used because it is a Japanese molecule not yet approved by FDA?
Yes, sir.
And where it stands in the guidelines, sir, when to use?
Sir, actually, in India it has been approved, sir. Now, so the market it has been given. So FDA is yet to approve, but it increases insulin sensitivity as well as it reduces the insulin resistance. So it is better than metformin, and even the side effects, gastrointestinal side effects, are better than side effects. And many of the studies as of now is as an add-on therapy. And HbA1c reduction as of now is moderate. It's not very high, but it is comparable with most of the DPP inhibitors. So what DPP inhibitors have achieved in 24 weeks has been achieved by them in 8 weeks. So definitely in future it will be better. And we all know most of the molecules that have been successful in Japan has been successful in our country also, like teneligliptin. So hopefully it will be better.
So it is 1000 milligram BD, sir. It is a
Yes,
1000 milligram BD.
BD.
Okay, sir. The sustained reduction in HbA1c level with this drug, sir.
Yes, sir. Yeah, it has been told in the studies. It is 0.5 to 0.8, sir, up to the maximum of 0.8, and this has been consistent even in the 16 weeks, 36 weeks, 54 weeks, and in the extended study after 52 weeks, 34 weeks has been extended. Even in that, the HbA1c reduction is consistent.
With add-on therapy with DPP-4 inhibitors, they absorb maximum reduction in A1C. So when you combine this drug on the top of DPP-4 inhibitor, the A1C reduction is much greater compared to combining this particular drug with other oral antidiabetic drugs. That's one. And as pointed out by him, it is available in Japan.
Yes,
So
already.
US FDA, the regulatory authority, they are very strict, including Japanese. So that medical agency authority equally, they are the regulatory authority getting an approval for a particular drug is more tough in Japan.
So it should be definitely a good insulin sensitizer in the future.
Actually, not only sensitizer,
It also secretagogues, dual action.
It's a mitochondrial energetics. That is, it improves the mitochondrial. Especially, it modulates the respiratory chain 1, 2, 3, 4, 5. So that respiratory chain modulates it functions. Thereby, it helps to stimulate glucose-stimulated insulin secretion. One. Second important thing is it has an action also on the vascular endothelial cells. It offers distinct protection. Not only it improves insulin secretion, but also it improves insulin sensitivity because the mitochondria that is located in the hepatocytes, mitochondria that is located in the skeletal muscles, they may also get improved. So it favors glucose uptake by the liver as well as glucose uptake by the skeletal muscles, more than metformin. See, again,
Yes. Sir, as of study with the insulin is not there, but definitely since insulin resistance is going to be reduced, definitely it will have usefulness. And LDL-C reduction has been found in one of the trial, but yet to come large randomized trials, then only we can say about that. So as of now, they have found out it will be helpful in reducing the endothelial dysfunction. So definitely it will be better, it will be giving protection against the macrovascular complications.
Next is HOMO beta and HOMO IR, markers of insulin resistance and beta cell function. With reference to quick key, there was a drastic reduction, number one. Second thing is with reference to beta, that is they have estimated the pro-insulin C-peptide level
ratio.
Yes.
So regarding semaglutide, sir, and oral semaglutide has come into market, sir. Whether it will be useful for euglycemic morbid obese patients, sir?
Euglycemic?
Morbid obesity.
As of now, the recommendation is only for the management of type 2 diabetes.
It is not still recommended.
We are going to get a different formulation of semaglutide. That is injectable formulation, 2.4 milligram. And
Weekly
DCGI, they have given approval for this particular molecule. And soon we are going to get. As of now, for the management of obesity, we have liraglutide 3 milligram. So the regular liraglutide for the management of type 2 diabetes should not be prescribed for the obesity. So 3 milligram liraglutide should be prescribed only for obesity, not for the management of diabetes.
The patients are afraid of injectables. So I was asking regarding oral.
No.
It is not indicated.
So in all the trials, clearly shown, reduction is more than 5%. And it is sustained for a longer period of time. As of now, there is no orally available semaglutide meant for the management of obesity.
Due to the cost, if the patient stops, what will be the HbA1c level in the...
Sorry, currently my patients are regularly taking. They have not discontinued. I have gone up to 7 milligram. That's all. I have not tried 14 milligram. So 7 milligram, over a period of 3 to 4 months, there was a reduction of 4 to 5 kg.
Okay.
How early we can go to this 14 milligrams, sir? You have showed all the slides mentioning about 14 milligrams.
Start with 3 milligram, wait for a month, then increase it to 7 milligram, wait for a month. Start low and go slow. And 14 milligram if you want to achieve further. But basically, if you look into all the RCTs, the difference between 7 and 40 milligram is less. On the other hand, weight reduction is more with 14 milligram.
Yes, sir. And regarding patiromer, sir, so what is the place of patiromer in malignant hyperkalemia, sir?
Sir, as literature say, patiromer is used for a maintenance of potassium. That is in the chronic hyperkalemia, especially in states of acute hyperkalemia like what you tell. I don't think there is a role, and there are no studies as far as I know in malignant.
Only dialysis will help. Yes.
It's just a potassium binder,
Yes,
which
sir.
takes care of the 10% excretion of potassium through the bowel.
Bowel.
Remaining is mainly we go through the
And it has to be given long term, sir.
Yes, long term. Of course, one disadvantage they say is a cost. Of course, I exactly don't know the cost because we are not using it practically for each sachet. But another thing, it has to be used for a longer time.
Yes.
An up titration of patriromer, another thing which I didn't tell is a weekly intervals. Every day we need up titrate. Weekly intervals, you estimate the potassium again. If it is not satisfactory, then you have to up titrate.
But the problem is flatulence.
Yes, flatulence, bowel disturbance, those patients we have to be careful.
Thank you, sir.
Thank you, sir.
One minute. Regarding the finerenone, that is we prescribe for the management of patient with the type 2 diabetes and CKD. It is not indicated for the management of CKD in patient with the type 1. It is not indicated for the management of patient without diabetes. So non-diabetic CKD is, as of now, it is not recommended. Only for the management with a view to reduce the progression of CKD, number one. Progressive decline in EGFR, number two. Number third thing is heart failure, hospitalization, and severe death. So I am prescribing this particular molecule. I am following all my patients, 12 patients as of now. So I am giving only 10 milligram. I have not gone into 20 milligram. With 10 milligram, there is no increase in the potassium level.
Yes.
I have not come across. So for the past 4 months, no. Nephrotic syndrome due to diabetes. Nephrotic syndrome due to diabetes. Yes, massive proteinuria. The thing is, it reduces albumin, urinary albumin excretion, and also the decline in EGFR, because both are important for assessing the prognosis in patient with the CKD. Yes, sir. Yes, sir. It reduces the urinary albumin excretion. No, I don't know. That I don't know. Yes, because if you look into RCTs, there is a decrease in the albumin excretion. Some of the patient presenting with that is macroalbuminuria, say for example 300 to 600 milligram, it has been reverted to microalbuminuria.
Yes.
And patient with microalbuminuria, it has been reverted to
Normal.
normoglycemia. Right.
Yes.
Thank you, sir. Now it's time for the felicitation. I now request Dr. M. Natraj, sir, to felicitate Dr. Apandraj, sir, to kindly come onto the stage. Next, I would like to request Dr. Venkatesh, sir, to felicitate Dr. D. Selvaraj, sir. I request you to kindly come onto the stage. I request Dr. M. Natraj, sir, to felicitate Dr. M. Shanmugavelu, sir. So it's for today's session, sir. I would like to request Dr. Venkatesh, sir, to felicitate Dr. S. Priyadarshini, ma'am. Next, I invite Dr. S. Srinivas, sir, to kindly come forward. I request Dr. M. Natraj, sir, to felicitate Dr. S. Srinivas, sir. I request Dr. Venkatesh, sir, to felicitate Dr. Malarvili, ma'am. I now request Dr. Malarvili, ma'am, to kindly felicitate Dr. M. Natraj, sir, and Dr. Venkatesh, sir, for chairing the session. Thank you so much, sir. Thank you, ma'am. Now I request Dr. Kalayarasan sir and Dr. R. Aravidi to kindly come onto the stage to chair the next session.
The topic for the next session would be adult vaccination. I request Dr. S. Chandrasekhar sir to come to the dais. I request the chairpersons to introduce the speaker.
Good afternoon, everyone. As a formality, we are introducing because he is our prestigious office bearer, treasurer of Tamil Nadu API chapter, and he is professor of medicine, and he is diabetes, and sir is academically so interested, and we can't miss the topic too. He was the best doctor recipient also from Tamil Nadu. So, because I think more postgraduates are there, the topic is much more important for your at least exam point of view and possibly in future for the practice point of view. Though the in general public perception and receptivity regarding adult vaccination is low, even we have to almost pick the patients for even for COVID vaccination. That's what happened. But this is important to have scientific backup to have a vaccination for every adult too, and if it is indicated. Welcome to you, sir, to Trichy.
Thank you, sir. Thank you for the kind introduction, ladies and gentlemen. I think we have started this session on time, almost on time. This is my outline. So we all know that the COVID has taught us many lessons. The one important thing is the importance of the adult vaccination. So the COVID is definitely on the decline. We do have almost 5,800 cases recorded till today, and within a period of 2 to 2.5 years, like we were able to achieve this a huge success to tackle this pandemic. That is only because of the advent of these vaccines. So at least people come to know that the adults also can be vaccinated. And this is one good lesson we have learned from COVID. So why we should know about the adult vaccination? So unfortunately in India, like most of the aging populations, the aging population is becoming bigger and bigger, and we do have more than 50% of our population is in the aging population. So more than 60 years kind of thing. So these are all some of the data which I am trying to project. Of course, these data were like a bit of pre-COVID era. Like it was saying that like almost people who are more than 15 years, they constitute around, represent around 72% of the India's population. Unfortunately, still there are certain diseases like the communicable, maternal, neonatal and nutritional diseases. They account for almost 30% of the deaths that is happening annually. Unfortunately, the unvaccinated adult also can spread diseases to the infant, and that helps the disease foci to spread to a epidemic, endemic, and of course to a pandemic situations. India has got the dubious distinction of having some of the infectious disease. Say, for example, the diphtheria is the commonly you do see 60% of diphtheria in India, and almost Japanese encephalitis to the tune of 44%, and tetanus 40% in 2017. This is again a national data. So we all know that like the H1N1 is almost it's becoming a perennial problem for most of the cities in Tamil Nadu. So this was a small data which was taken during the pre-COVID era between 1st of January to February 4th in 2018, and they were reported almost 133 outbreaks, mostly due to measles followed by varicella, food poisoning and acute diarrheal diseases. So the one best thing is most of the diseases are preventable. How we can prevent, that is through the vaccination. So this is one simple but a strong message that most of the diseases, infectious diseases nowadays are amenable to a vaccination, and it's preventable. There is yet another sad story. This was a study conducted between 2009 to 2012 among 890 women, and found that 12% of the populations were found to have HPV positive, human papillomavirus positive, and 4 were borderline positive. So in India, like almost close to 60,000 people, 60,000 women die of the cancer, cervical cancer in India. So this is a very unfortunate situation. Then we know that so these diseases are practically like it's preventable. So one thing, so again, I just wanted to reiterate the importance of these adult vaccinations. So of course, the COVID has taught us, but of course the basis, like what we have learned from the success of the childhood and adolescent immunization program. So we all know that so this infectious diseases can be preventable through vaccination. Of course, these things can have a positive impact on the individual, as a family, and as to the, of course, to the entire community, and it also helped to reduce the healthcare cost. One thing we need to remember that most of the diseases, newer infections are coming up. So we do have fungal infections, we do have newer viral infections. All these things, it's quite posing a stiff challenge. Of course, many diseases again amenable to a vaccination, and these vaccinations are recommended throughout the life. So there is no age bar. So say I'm 65, I'm 70. So do I really require a vaccination kind of thing? So no, I'm 35, I'm hale and healthy, I'm otherwise a robust individual. Do I require a vaccination? So it's not so. So the vaccinations are required for almost all the age groups, which I show you little later. What are all the categories? So of course, we do some booster doses. Say for example, the very simple thing is the tetanus toxoid, like what we do. It's a booster dose. Sometimes we do the vaccination in order to give you a booster protection, so that we can give. So similarly, the second one, the typical example is how we were trying to eradicate the polio, and of course the COVID also. So this is aims to create a herd immunity and interrupting this transmission and covering the non-immune cohorts. So this is another thing where we can use these vaccinations. Of course, these vaccinations again can be used in multiple different settings in people with a different risk factor. Say for example, somebody with cardiac failure, COPD or CKD, or even a chronic alcoholism. So these are all some of the risk factor where it poses a significant threat of developing infections which could result in mortality. So these are all some of the things which you could see. So we have eradicated smallpox, of course polio in most of the countries, of course rubella in US. But still there are certain diseases which are quite challenging. Still we do see cases of, recently we had a small outbreak of diphtheria in Kerala. Of course, even in Chennai, we had cases. And rabies is continued to pose significant threat to the humankind, because it's devastating and there is no treatment for rabies. It's 100% death when somebody develops a rabies kind of thing. And of course, varicella. So sporadically, we often get packets of these chickenpox, varicella cases here and there. So these are all some of the things. On one hand, we have eradicated certain diseases with vaccination, and even despite vaccination, some of the diseases still posing some challenges. So the vaccines have made some history. So we don't see these cases nowadays. This is a case of tetanus, and of course, these cases are also, we don't see now, this is a case of polio. So there was an interesting journal, it's not a kind of, it's interesting to read. So a guy written an article in American Journal of Medicine saying that how the 10 secrets of a healthy long life. So he has put, one is the genetic, which we cannot modify much, but they can be influenced by various factors, including the environmental factor. The second is the antibiotic, public health, and vaccine. So this is a very innovative thing what this guy has written. So the vaccines, they play a very important role. Of course, the various things. So almost it precedes the cardiovascular risk factor interventions. Of course, exercise and nutrition and other things, cultivating optimism. So this is a very wonderful article. If some of you can find time, you can also get through this. Interesting article. So that can give some kind of the lateral thinking, how we can tackle a disease or how we can face up with a big challenging health crisis. Why adult needs a vaccine? We all know that once somebody develops a immunity. This immunity, unless a person develops a natural infection, it may not last long. So it's not a durable immunity. The immunity can vanish over a period of time, vanish with aging. So old age, of course, it's a risk factor for many diseases, commonly the pneumonia. So the pneumococcal pneumonia is the worst culprit, like which can cause devastating outcomes, in particularly in patients who are elderly. And for the sake of to protect our younger and elder, so this is what happened with COVID. Somebody develops a COVID, so they can infect all of them. So this is what happened. So if somebody is vaccinated and protected, the entire family is protected. And like diet and exercise, the vaccines are also going to be an important factor to stay healthy. How we can, approach a patient with who are all the patients who require adult vaccination. So this is an approach called a halo approach. This is a very simple approach. So depends on the health factor and the age factor and the lifestyle factor and the occupational and other factors. Say for example, somebody is having a health factor. So say for example, somebody is having a chronic diseases like diabetes or kind of the COPD or CKD or CLD, chronic liver disease, cancer or something like that. So they need to be vaccinated with all these kind of things. So annually with influenza, pneumococcus, hepatitis B, A, and meningococcus. Similarly, the age factor also. So as the patient, the person ages, like the virulence, the immunity comes down, the virulence of the organism goes up. So they need to be necessarily vaccinated. And the lifestyle factors. And nowadays, travel is a very common phenomena. Like people even travel to exotic disease. How we got scrub typhus. Scrub typhus were once, it was a decade ago, it was not known to many of the people. But it got, people had travel history and got from the oriental countries. So this travel, the people who does the travel also, they need to be vaccinated. I'll brief you in a short while, like what are all the vaccines to be given to a traveler, international traveler. Of course, occupational health thing, like we are all exposed to as a medical professional, particularly the hepatitis B, so which we need to know. So these are all some of the vaccines like which need to be given, depends on the health factor, age factor, lifestyle, and of course the occupation. I think this is a very common slide. I think most of you can browse it, like you can get it from your internet. Like this is a very commonly available slide, like which can give us some idea about the common vaccine preventable diseases and how these things can be given. Depends on the age wise, okay? So again, this is the same slide continues, in fact, okay? So this also, you can download it very easily. But remember that in pregnancy, most of the, not most, like almost all the live attenuated vaccines are contraindicated during pregnancy. Of course, you need to exercise caution. So the MMR and the varicella and the HPV were contraindicated in pregnancy. Otherwise, like you can have the non-pregnant lady, like they can have all the other vaccines. The one thing which I wanted to take you is, this is a guideline from the CDC. What they have mentioned is the end-stage renal disease, the next one, the heart and lung disease and alcoholism. So this is a very common phenomena in at least in our part of the country, like where alcohol madness is a very common phenomena, where the patients are at risk of developing chronic alcoholism, they are at risk of developing certain infections. So remember that it also reiterates the importance of vaccinating our alcoholism. People with chronic alcoholism, they need to be vaccinated with at least with the common, preventable infections with vaccinations. I think this is another thing, the transplant and other things where like most of the setup, like we do have almost many centers, they have started taking up organ transplant. And again, a person who needs to be transplanted ideally should have all these vaccine, pneumococcal, COVID, hepatitis B, influenza, herpes zoster, Tdap, HPV, particularly in young people, and MMR and varicella. So these are all some of the things which we should know. But another thing, as alcoholism, we do have another problem, non-communicable disease, that is more common in our part, that is diabetes. So this is again a recent guidelines from the ADA. What it says is like, so in addition to the influenza, pneumococcal and Tdap and shingles and HPV, they need to be administered with hepatitis B also. So this is a newer addition to all our patients with diabetes. So all our patients need to be vaccinated with hepatitis B also. So they given some recommendations. All adult less than 60 years of age with diabetes, they need to be given 3 doses. That is 0, 1, and 6 months dose. So this is the recommendation. And if somebody is more than 60 years, you please consider about giving a hepatitis B. So these are all some of the recommendations which again reiterate the importance of, even the global guidelines also now come to say that the importance of this adult vaccination. So what are all the vaccine preventable diseases? So this is the set of bacterial and viral. Of course, we cannot have a single antigen that can mount a significant immunological response against a fungal infection. So it's still in the pipeline. We don't have any vaccines for the fungal infection. So we do have a battery of diseases where the vaccines can be covered. So this is the travel vaccination for all destination hepatitis A, B, tetanus, typhoid, and influenza, and varicella. So these are all some of the vaccines to be administered in people who travel much. So this is the H1N1. I just skipped this. This is the government of India guidelines for the H1N1. Like of course, we all know the categorization, category A and B. So look at the recommend. Yeah, look at the recommendations. For A, the recommended treatment is only vaccine. Of course, for the people with B with minor symptoms, which are minor, along with comorbidities, again the treatment of choice is vaccine. So again, the entire government of India reiterates the importance of the vaccination in such individuals. I'll take you to the another one. So the rabies. The last 3 minutes of my talk on rabies. So rabies, we all know that like it's a viral disease, like where the person developed a rabies, like they are 100%, the mortality, it has got a 100% mortality. And still we do see almost 20,000 deaths in India dying of these rabies. Of course, nowadays we started using the cell culture rabies vaccine and the post-exposure prophylaxis. We all know that the Essence regime and the modified, the updated Thai Red Cross regime. So in our hospital, we do use, of course, all of us started moving on to the Thai Red Cross regime, where we give it as an intradermal dose, the 0.1, and the dosing is reduced, as well as the duration is also, the dose is also reduced. Dosage and dose is also being reduced, 0, 3, 7, and 28. Of course, the pre-exposure prophylaxis is a must in patients, all people in the healthcare industry, including the veterinary professionals and the people who are in the wildlife wardens. So this is also another common problem. We all know that like this is the different categories of the dog bite. I just read the category 2. So where there is a nibbling of the uncovered skin or minor scratches or abrasions without bleeding. So this is category 2. And category 3 is a single or multiple transdermal bites or scratch. So this is the very common scenario where we come across these rabies cases, like somebody bitten by a dog. So this is a very common scenario. Either they fit into category 2 or 3. So which we need to remember. Remember that a single or multiple transdermal bite comes under the category 3. So that we need to know. So once the patient is in the category 1, like wound washing is important. So the guidelines say that like washing the wound for up to 5 minutes, like a minimum of 5 minutes is very much essential. Even it can be extended to 15 minutes. So this is just to get rid of the virus particles from entering the nerve terminals. For patients in the category 2, in addition to the wound washing, we need to give the post-exposure prophylaxis. Of course, all category 3 patients should receive in addition to all these things like rabies immunoglobulin also. So this is a very common scenario. Like again, somebody comes to our clinical establishment. They say that like they walking past a dog and a dog has scratched. Or sometimes they say that like stepping on or bumping into a dog or interfering with a dog fight kind of thing or feeding the animals. So these are all some of the common situations, or handling a dog which is a surprising dog or which is sleeping. So these are all some of the situations where they come across a bite. So the government of India has categorized as provoked bite. Okay. So the unprovoked bite is attacked by a dog for a unknown reason or from an unknown site. Okay, so that is the number one. Or it is being bitten by a victim's own dog, which has no prior history of dominant aggression. So these are all two categories which Government of India has given. But what does it say further is like a dog bite was provoked rather than unprovoked should not be considered a guarantee that the animal is not rabid. This is a very important message. Further, it says that vaccinated animal can do so if the vaccination of the biting animal was ineffective for any reason. Yeah, history of rabies vaccination in an animal is not always a guarantee that the biting animal is not rabid. So it essentially means that whatever the immunological, the vaccination status of the animal, like we need to vaccinate. So this is what the recommendation say. Any kind of bite, we need to categorize, and for all patients with category 3, we need to give RIG. In addition to that, for patients with the category 2, wound washing and the routine post-exposure prophylaxis. So this is what we should do. Of course, we all know about the COVID vaccines. There are different types of vaccines are available. Of course, yesterday the DCGI has approved for Incovac. That is the first intranasal vaccine for COVID. So this is what the recommendation is. They can have a booster dose. So this intranasal vaccination can be given as a booster dose to all our patients who have already received 3 doses. So this is going to be the recommendation sooner or later. So this is the first of its kind. Only in China they have done this intranasal preparation, that is through a nebulizer. But in India, through Bharat Biotech, they have prepared indigenous, because we are the major exporter of vaccine throughout the globe. 75% of the world gets vaccine from our India. So this is another innovation. So we have the intranasal vaccine also. It has been released yesterday. So I'll end up with this slide. Patients who are more than 65 years, the flu shot, pneumococcal and zoster is a very important vaccines to be administered. For healthcare workers, the flu shot, MMR, hepatitis B, TT and varicella. People who are in the diabetic, CAD and COPD, of course, we need to include alcoholism also. They need to be administered flu, pneumococcal and HPV. Pregnant women, flu and DDAP. And for college, young people, like MMR and meningococcal vaccines are the most important things to be administered. I think as our chairperson has said, like it's picking up late. So the awareness is low. But I'm very sure that sooner or later, we may have the importance of this adult vaccination will come up in a bigger way. Of course, it may take a long way to come, but definitely in a decade or so, like the importance of adult vaccination definitely will reach every citizen of this country. So with this, I also invite all the physicians and postgraduates to our the annual conference and all in the postgraduate training for postgraduates, which is going to be held at Chennai in both the 2 destinations, one in Government Stanley Medical College, another one in Hotel Savira, between 2nd of December to 4th. I invite you all to join us. Thank you.
Thank you very much, sir, for your elaborate lecture on adult vaccination and stressing the hollow list and whole list of vaccine. And even in the starting itself, you have categorically said it not only prevent infection, but also prevent malignancy. Thank you, sir. Any questions from the floor?
Is there any questions? Thank you, sir. Thank you for the wonderful talk on your adult vaccination. I now request Dr. Kalayarasan and Dr. R. Aravidi to felicitate Dr. S. Chandrasekhan, sir, with the memento. I now request Dr. Chandrasekhar, sir, to felicitate Dr. Kalayarasan, sir, and Dr. Aravidi, sir. Thank you, sir. Next, we are moving on to the next topic, rheumatology. To chair the session, I now invite Dr. Siva Subramaniam sir and Dr. K.R. Ramanathan sir Pudukkottai to kindly come on to the stage.
The topic for the next session is current pathway for polyarthritis. For this session, I call upon Dr. N. Subramanian sir to come to the dais.
I request the chairperson to introduce our speaker.
Pleasant good evening. Really thank Tapicon for having called us for the chair the person session. I welcome all and I welcome Dr. Subramanian, rheumatologist from Tirunelveli, and his achievements are there in the screen. And he is going to talk on arthritis, polyarthritis pathway. And it's a routine cases we get right from pediatric to senility, all joint pains and other thing, and especially when more than 5 joints are involved, polyarthritis, and we have infective, age-related, and autoimmune, all these things. And very frequently in all OPDs we encounter, and the present scenario, current pathway, our rheumatologist Dr. Subramanian, sir, welcome, please.
Thank you, Chairperson, sir. So, at the outset, I would like to thank Professor Anita ma'am, Dr. Setharaman sir, and all the APA Trichy chapter for arranging an excellent program for the last 3 days. So, really nice to see the postgraduates who are all standing in the back. So, I think the previous talk was more on immunology also, with the vaccine for infectious diseases. So next 2 topics will be again immune based. So most of us at some point of life, we would have joint pains, but they are all more non-inflammatory. But we are looking more of inflammatory specialists, so we look at more inflammatory diseases. So this is a teaching slide. We have to localize what kind of diseases or what of symptoms do we have for painful joints, because generally our rheumatology diseases are about 206 in number, and the major groups are arthritis group, CTD group, and a vasculitis group, and the other 4th one is the miscellaneous group. So the common ones you do see is rheumatoid and psoriatics and Angst-Pond and IBD related arthritis. So these are all more inflammatory arthritis. So patients have to localize the symptoms where exactly they are, or you have to have a role in adequate history taking, because that will give you the diagnosis. These are all because rheumatology disease is a multi-system disease. So our history is always head to foot. Similarly, we also look at immunology side of things. So if you have a joint swelling, then that is arthritis. Then you look at whether it's monoarticular, whether it's oligoarticular, which is 1 to 4, or polyarticular. So if it is polyarticular, it's more rheumatoid, psoriatics, and ankylosing spondylitis. And of course, rheumatic fever also can be part of it. And if it is more lower limb involvement, then you get inflammatory bowel disease and spondyloarthritis manifest with more lower limb arthritis. And if it is monoarticular, think about sepsis. Next is crystal arthritis. And third one is an infectious arthritis or sarcoid and other things. So this is more for undergraduate and teaching sessions. So you all know the signs of inflammation. So early morning stiffness, swelling, lack of or activity makes it better, and also stiffness with inflammatory mucus. So they do characterize the inflammatory symptoms, and that is very important. So to fix whether it's rheumatology or non-rheumatology. So rheumatoid is a telltale or a classical manifestation with a small joint polyarticular disease. Usually it's upper limb dominant, and MCPs and the PAPs are involved, not DAP. So that is very important to know, because DAP is more seronegative group. And early morning stiffness and inflammatory features are there. You can get lower limb involvement, but large joint involvement is less common.
So, so why do we get inflammatory arthritis? So there is definitely a genetic background and also other risk factors which make the predilection towards developing inflammatory disease. And of course, women have more inflammatory disease than the men. In most of the rheumatic diseases, that's the possibility. And family history is high, five-fold risk. Apart from tobacco, alcohol, and periodontal disease also have been found to have a high risk of developing rheumatoid. So in the last 2 decades, the cytokines have been looked into, and every year you do get cytokine blockers in various diseases. So TNF alpha, interleukin 6, interleukin 1, interleukin 17, and VEGF, and you name many of them. So they are all involved in the pathogenesis. We're not going to go into that now. So as I said before, it's systemic disease. So it's not only joint problem, and it doesn't settle with symptoms getting better. So it comes out like scleritis, then lung disease, or even renal disease. So we don't want to see these deformities with the current therapy and current approach to intervention. We want to be more aggressive in early identification, but you do get to see patients who have left. So you get scleritis, you get interstitial lung disease, and you get long-standing untreated vasculitis in the legs, and also what is the kidney lesion? PGs, what is common in chronic inflammatory disease and renal disease? Somebody said, oh, it's a renal amyloid. Okay. So the clinical diagnosis is important. That is the diagnostic tool. The inflammatory markers will support the diagnosis. But if you are unsure, then yes, radiological tools are there. Ultrasound can be beneficial. Definitely in Western countries, every rheumatologist use ultrasound. But here we do get the radiologist to do, or you can do MRI imaging, quickly focused imaging. So you can get a power Doppler signal in the MCP joint, which like patients also can see it's a burning inside kind of approach. So they do understand that is a definitely concern to treat. So the diagnosis is clinical, small joint polyarthritis and the factors for satisfying it. This is more research based, but yes, we do practically use them as a small joint disease, positive rheumatoid factor, which again is only 45%. So we do use anti-CCP antibody. I think most of you are aware. That is highly sensitive and specific for 96%, and duration of disease about 4 to 6 weeks, and CRP and ESR raised. ESR raised is first, CRP next, but CRP is acute, but ESR is could be a subacute. So we do need help from general physicians and also the primary care doctors, because they are the ones who identify these patients and consider appropriate investigation and referral and get to the treatment. And allied specialties, occupation therapy, physiotherapist, and very rarely we do get involved with orthopedic surgeon. So how do we manage it? Steroids have been used for many years, since 1930s, but DMARDs have been used for last 5 decades. The last 2 decades, we do have MAPs. So methotrexate is the anchor drug, weekly once. Remember that, don't give every day. We do see occasionally high risk behavior with this methotrexate usage. It's a weekly once drug, and we don't go beyond 20 milligram per week. And all of them need monitoring. All the drugs except hydroxychloroquine, which again needs retinal monitoring. Leflunomide can be used, and sulfasalazine and hydroxychloroquine, ugiratimab, these are all commonly used, which you are all aware. Maybe the new PGs yet to learn. So biologics, what are biologics? They are small molecules. So the protein, since 1998, we do have MAPs. MAP is monoclonal antibodies. So there are many cytokines, and the blockers have been identified. So they specifically target the cytokine and block it. So you can read it, it's there, and every year you get new MAPs. Anybody know who is on the top right? Can anybody answer? Who is that man? He is the inventor of Wonder Drug. Is Philip Hench, who invented corticosteroids back in Nobel laureate. So, so initially gold and other drugs were used, subsequently steroids, and then DMARDs, and now MAPs, and even oral JAK inhibitors have come about in the last 5 years. And we have seen the usage of NIBs in COVID also. JAK inhibition as a new treatment strategy for COVID-19. So I'm not going to go into this. This is the Sankey diagram for management of rheumatoid and how they are efficacious, and how do we switch therapies from one monoclonal antibody to another one. Okay. And we do have shared our data from Madurai Velammal in international forums. Just few cases to illustrate about the diagnosis. So 64-year-old male, diabetes for 2 years, and he presented with fourth toe painful swelling for a year. And initially thought as neuropathy, subsequently thought as could be osteomyelitis. But the detailed history gave a clue as a dandruff in the scalp. So that should give you a clue that it could be psoriasis. So I gave a clue there anyway. So this is another patient who had a painful index finger, MCP swollen, and you can see the fourth toe. Oh, something happened. It's better here. So fourth toe, what do you call them? This whole digit is swollen. So dactylitis is a specific feature of psoriatic arthritis. The psoriasis is a cutaneous inflammatory disease, and usually there are 5 different types. Because it's a skin disease, it affects the nail and also DIP joint. So DIP joint involvement is more common with psoriatic arthritis, and it is not single disease, it is also again a spectrum of diseases. So 82% people will have psoriasis first, whereas 15% will have arthritis first before the psoriasis. And the family history is very important. And childhood history, no symptoms, then when they become adult, they can get psoriatic arthritis. The common 3 subtypes are oligoarticular, predominant DIP involvement, and also polyarthritis pattern like rheumatoid with psoriasis. The other 2 are because we don't let them develop arthritis mutilans. So early diagnosis is the key, because within 2 years they can erode the joints and damage and deformities can happen. So that is the key. So when I try to open up these discussions with the primary care or physicians, the important thing is we need to identify. Even we have gone to the extent of combining with the dermatologist to get to the diagnosis early. You can get a screening questionnaire with the dermatology to pick them up. So this is a patient who is 17-year-old, thigh and a back pain for about 3 weeks. So the image is better here. That is a bit more darker, but anyway, it's better. You can see the bright spots. What is the diagnosis there? Something around the hip. Sacroiliitis possible, yes. And this image shows more of a trochanteric bursitis. So that is again a feature of enthesitis, is a feature of psoriatic arthritis. So heel, Achilles tendon, trochanteric bursitis, and also olecranon bursitis are very common with psoriasis. So remember that when you get symptoms. This is a dactylitis, patient is a dactylitis, an MRI, and a DIP joint involvement. So there are many areas of enthesitis. Enthesitis is the site of inflammation where the ligament attaches to the muscle, bone. And there are 2 more pictures with the dactylitis too. So these are 5 different types of psoriatic arthritis, which I have already alluded to. And this is one of our Indian studies showing polyarthritis is more common, and distal IP joint and asymmetric oligo is also common. This psoriatic disease or any inflammatory arthritis is not arthritis per se, and it is a high risk of cardiovascular disease. So it does reduce our age, our lifespan, and the burden in the systemic disease is also very high. So uveitis, quite a few referrals come from ophthalmology. So uveitis is one common manifestation with the seronegative group. The seronegative means is rheumatoid factor negative, that's it. And the behavior is also different. And you get bowel disease, inflammatory bowel disease, bloody diarrhea, abdominal pain, weight loss due to Crohn's or colitis, and also back pain with the spondyloarthritis, which is more sacroiliitis, and the nail changes too. And hypertension, diabetes, dyslipidemia, all metabolic derangements can happen with any inflammatory disease. And this is just a slide showing psoriatic involvement. So this is a management pathway given by Dr. Lara Coates, who was my colleague. We've together written this in one of our journals in India. So peripheral arthritis, different pathway, axial disease is different, enthesitis is different, dactylitis, skin and nails. So they all behave slightly different, and their cytokines are also different. So you need to pitch which cytokines is more specifically beneficial. But baseline, if it is peripheral disease, methotrexate works very well, and the flutamide can be tried. Cyclosporin also can be tried, and beyond that, we may have to go on to biologics. So never to ignore the eye inflammation. So we are trying the ophthalmologists nearby also to always think about uveitis, granulomatous and non-granulomatous. Consider referral to rheumatology. Still, I remember this man who was 27 at the time, but that was 6 years ago. Recently married, hip and back pain. He was unable to stand. He was admitted in orthopedic hospital. So when I was seeing him, his wife was on one side and his sister was on the other side, and they were bombarding with questions, because they're recently married. It's a quite a lot of issues. But so the next slide shows very classic rip roaring sacroiliitis. We have to think about infection, Rita syndrome, and other issues also. But it is bilateral, more on the right side, less on the left side. So this is classical sacroiliitis. So ankylosing spondylitis, which is a spectrum of spondyloarthropathy. One end is psoriatic, the other end is ankylosing spondylitis, and you have uveitis and bowel disease in between. So it's sometimes difficult to diagnose, but anybody who is young, developing back pain, which is inflammatory in nature, think about angstpond. And always collaboration with other specialists, and MRI imaging, HLA-B27 do help to categorize when to intervene and how fast do we intervene. So Nature's Review Rheumatology does suggest the spectrum of diseases. So genetic factors, environmental factors, shared epitopes, and also other unknown factors in the environment. So they do have psoriasis, uveitis, sacroiliitis, peripheral joint involvement, enthesitis, and a bowel disease. Few images with the uveitis with B27 and keratic precipitation granulomatous uveitis. So rheumatology is fascinating. You get to keep revising all the systems. So gut biosis or dysbiosis. So that is again it's coming up. The Western studies are now looking at Indian food, whether that can modify the immune system, because the good bacteria, bad bacteria, all gut flora. So one of them is curcumin, and a lot of other our Tamil foods will have all the important connections. So definitely B27 also has an influence on this gut flora. So skin disease is commonly useful for us to be diagnosed. Psoriatic plaques, keratoderma blenoragicum in reactive arthritis, rash in lupus, which will be covered by Professor Tamilchelvam next. Juvenile arthritis with still disease, and rheumatic fever with erythema marginatum, and erythema nodosum with sarcoid. This is another patient who is retired veterinary surgeon, 67 female, painful swollen ankle for 2 years, and at this age group, both ankles are painful, and they had quite a few MRIs, and they all said, it's OA with needing surgery. Yes, imaging showed degeneration, synovitis. But because there was some bone marrow signals, I thought we'll look at the rheumatic side of things. And she had anti-CCP positivity. And we did offer oral DMARDs, but they chose quick action. And so I offered tocilizumab, which is IL-6 blocker. And within 3 doses, she recovered. She's walking. After 2 years of wheelchair use, this is 4 years now. So she's walking fantastically now. So treatment recommendations, different countries have different recommendations, like EULAR, ACR, APLAR, and BSR. So predominantly for any inflammatory arthritis, history is important. Subsequently, inflammatory markers and appropriate imaging, and a friendly advice from a rheumatologist. So that is, and the compliance with the patient and also family to be involved, because it's a chronic disease, it's going to be long-standing. So family needs to be explored. That's quite a lot of situations we manage in these. So we do write in different journals. This is myself and Dr. Vinod Ravindran in IJR. So one more patient with the psoriasis and a diarrhea. You think about IBD. Think about IBD first, and if it is other diagnosis, that's well and good. This is you can treatable. So ulcerative colitis and the biopsy, and the stools for calprotectin also can be used as a marker, and the patient is fine with mesalazine. So other forms of polyarthritis, remember polyarticular gout, although most occasions you do get knee arthritis with gout and also podagra, which is the MTP joint involvement. You cannot escape with the post-chikungunya or post-viral arthritis, and a reactive arthritis with infection like COVID or post-COVID. Occasionally we do see hemochromatosis, hemophiliac with the knee arthritis, and unusually Western patients you get gonococcal. So this is the questions to the patient. Does your patient does your patient have inflammatory features greater than 30 minutes of morning stiffness, neo-adjunct swelling or effusion, symmetric distribution, 3 or more joints, and symptoms getting better with activity? So that will give you a clue whether they have inflammatory or non-inflammatory. And if it is inflammatory, think about extra-articular. So what is in the skin, what is in the eyes, what is in the bowel, what is in the nail, and Raynaud's and other features which will be covered in the subsequent topic, and also family history of autoimmune disorders. So that is very important. And remember, in boys, inflammatory back pain is important, and that again improves with activity. So if you have answers in these questions, you can focus which arm they do go. So diagnosis is the key, and a clinical diagnosis. Again, I reiterate, the imaging and the inflammatory markers do support to an extent. So anti-inflammatories, steroid or non-steroidal, but steroid try to keep it under 3 months. Disease modifying drugs, oral and also biodemars, and injectable and oral biodemars. Physiotherapy is important to keep them going. Arthroscopy occasionally, and the multidisciplinary approach is important. So early inflammatory arthritis, early diagnosis, you can lead a normal life. So devoid of damage to the joints or systemic disease. Lots of myths historically in rheumatology, and I tend to say, every disease has 3 or 4 drugs. They don't talk about drugs, they do talk about their health when they visit a doctor. But rheumatology வந்தா மாத்திரம் டாக்டர் எப்போ பேஷண்ட் மருந்தை நிறுத்தலாம் அப்படி தான் கேட்பாங்க. ஸோ டிசீஸ் எப்படி இருக்குது, ட்ரக் எப்படி கண்ட்ரோல் பண்ணுது அப்படின்னு கேட்க மாட்டாங்க. ஸோ தெர் இஸ் ஆல்வேஸ் அ ஸ்கேரி திங் ஃபார் தம். So we need to educate them, because they are all friends. The joints are all friends. They keep us moving active, A to B, to the dinner hall, to the lunch hall, to the hotel, and all around. So I would like to sincerely thank the organizers and all of you for a patient listening, and the chairpersons. So next year, Tapicon 2023, so this same one will be in Tirunelveli. So I sincerely welcome one and all for another academic feast next year. And we do have a stall in Lipan Center for early registration from today onwards. So kindly make use of it. Once again, thank you.
The discussion will be at the end of the session.
Thank you.
We'll move on to the next topic, sir, of the day. SLE, the hidden epidemic. I call upon Professor Dr. T.N. Tamilchelvan, sir, to come to the dais.
Welcome, sir. Now, you would have seen an OP and classes and everything, a few cases of SLE rather than many cases, but actually it is not, and especially in the southeast. And is it a hidden epidemic? Is there a epidemic in this? And what are all the hidden features of SLE, systemic lupus erythematosus? Your Professor Tamilchelvan from Chennai has come. Welcome, sir. Please get.
Good evening to everyone. Thanks for the chairperson for the nice introduction. Respected senior colleagues, junior colleagues, postgraduates, former dean of the KAP Medical College, Pranita ma'am. Good evening to one and all. The topic is lupus, hidden lupus. Lupus itself is hidden. there is nothing to obviously reveal because Dr. Subramani has played a 50-50 over, like how India played yesterday. 306, they were very sure, confident that we will win. But New Zealand subsequently played like 20-20 over and finished. So lupus behaves in such a way, we don't know how it behaves. Some days I wear a black and red shirt. They ask me if I belong to a particular party. Next day I wear an orange color shirt. The entire MMC asked me, why you are wearing an orange shirt? So likewise, like our appearance, the lupus keeps changing its picture. The lupus, what is lupus? Lupus means, lupus is derived from the Greek word lupus, which is a wolf-bitten like phases. It is not only the skin. First, they concentrate on the skin, how it affected the skin, like wolf-bitten appearance. But later, like diabetes, it starts affecting every organs. The first manifestation of lupus can be a lupus nephritis, it can be lupus retinal vasculitis, it can be lupus arthritis, it can be a avian of a hip in a 35 years old female. It can be anything. It can be anything. Don't expect a butterfly rash, photosensitivity, according to the ACR, ULR, slick classification criteria. Don't expect all those things. That's why it's hidden. Systemic lupus is one of the most studied diseases in medicine. Predilection for the young females in the childbearing age. Why childbearing age? No one is. In my UG stage, I used to say at Tanjavur Medical College, estrogen is the most wonderful substance on the earth. But the same estrogen plays the havoc in the childbearing age. How? It predisposes some sexual factors, especially the estrogen predominance, helps the female patients predispose to this disease. The same hormone which gives the females the beauty also predisposes some susceptible individuals to this particular very, very harmful disease. Physical, cosmetic disfigurement, significant morbidity, and if improperly treated or untreated, mortality too. Here, what matters is inflammation. Wherever you go, there is inflammation. Subramani talked about ESR and CRP. Yes, ESR and CRP both are acute phase reactants. What is the difference? ERP is done with the fresh sample. CRP can be done with the stored sample. ESR is cheap. CRP is costly. ESR start elevating several days after the insult has started and persist even after the insult has ceased to exist. Whereas CRP starts within few hours after insult onset and subsides as soon as the insult subsides. These are the basic differences. In SLE, ESR is always elevated. Even with adequate control of disease activity, SLEDI less than 20 or something like 12, something like that, the ESR will be 60. Don't try to treat over with immunosuppression. You have to take the count of CRP. CRP is always normal in SLE. CRP will be elevated only in severe lupus, neuropsychiatric lupus, lupus vasculitis, severe lupus nephritis, and septicemia. Why a hidden epidemic? Quite large number of cases remain unsuspected and undiagnosed. Being a multisystem disease, the initial presentation could involve the skin, joints, lung, heart, CNS, kidneys, blood vessels, or a combination of any of these. We see neuropsychiatric lupus could be lupus can present with any specialty. Takayas arthritis, vasculitis, they can present with ophthalmologists, neurologists, or anybody. Likewise, the lupus can also present to any specialist. It can present with the ophthalmologist with the retinal vasculitis. It can present with the pulmonologist with acute diffuse alveolar hemorrhage. So it can present with any specialist. But the question is, the moot point is, you have to find out whether the patient has clinical features of lupus, constellation of the syndrome. Threshold to suspect SLE should be low given the protean features. Diagnosis depends and demands astute clinical examination and evaluation of multi-system involvement. This is very, very important. Dr. Subramani said about the enthesis, the bursitis and all that. In lupus, to evaluate, you have to examine the skin to foot, every organ. Bursae, enthesis. Enthesis is the point of attachment of a tendon, ligament, capsule or fascia into the joint. Enthesitis, trochanteric bursitis is not the enthesitis. Enthesitis can be medial epicondyl, lateral epicondyl, what you call as medial epicondylitis, lateral epicondyl can be same. When the enthesial organ is complex is involved, it is enthesitis. If it is a tennis spiroitis, medial lateral epicondylitis, it can be a Achilles tendinitis. Apart from that, patellar tendinitis. It can be in several, there are more than 20-30 enthesial spawn. SLE can involve, first presentation of SLE could be enthesitis. That's why I emphasize this. Since the clinical features, antibody testing may not lead to diagnosis, patients with SLE escape detection at the early stages. Pathophysiology, SLE is characterized by remitting and relapsing courses. It goes for remission spontaneously or with the induced drugs, and it remits, relapses suddenly 1 or 2 months. The patient says, Doctor, sir, nalla irukku, 2 months nalla irukken. சொல்லிட்டு போயிட்டு 1 week she comes, there is an emotional trauma induced by, commonly emotional trauma is induced by spouses. The spouses, they induce the trauma. With the trauma, next month, they will come, the lupus is aggravated. Sir, I'm getting joint pains again, and I have got a rash, and I have got the urine albumin is 2+, which was earlier trace, has become 2+. So we have to worried about the remissions and relapses. Susceptibility depends on genetic makeup, increased or impaired clearance of nucleic acids. Type 1 interferon through innate immune system. Since there is lack of time, I would like to say immune system is very important. You remember that there are more than 100 autoantibodies in lupus. Not all are pathogenic. Pathogenic autoantibodies, among the pathogenic autoantibodies, immune complexes, circulating immune complexes, and innate immune system, T cell activation. Subsequent, now the vasculature of all the end organs is being implicated in the SLE pathogens, like in diabetes. The vasculature of the eye, the vasculature of the kidneys, the vasculature of the lungs, vasculature of the entire organs is being implicated in the pathogens of SLE. The activation of cells by intracellular nucleic acids or viruses are products of apoptosis that mimic viral protein. There is molecular mimicry could be one of the reasons. Again, the major histopathogenic antigens are HLA, DR, the complement deficiency is predisposed to SLE. HLA DR2 increases the risk to 2 to 3-fold. HLR-D3 2 to 3-fold. DR2 and DRX associated with the anti-SM antibodies, which is present only in 20% of the lupus patients, but highly specific. Very anti-Smith antibody is highly specific for lupus. DR3 and DRX, anti-Rho and antibodies. About this is, at this point, I would like to I would like to emphasize, reiterate that after the advent of the SARS-CoV-2, COVID-19, the autoimmune diseases have on the increase. In one large study, there are 99 cases have been reported. Of the 99 cases, after COVID, due to the viral molecular mimicry, 12 cases of arthritis, 11 cases of vasculitis, 6 cases of sarcoidosis, and several other diseases, autoimmune diseases, 6 cases of SLE, 4 cases of Sjogren syndrome. So, after the onset of the COVID, all the physician has to be aware that the COVID-induced autoimmunity can induce one of the defined rheumatological diseases. It can be anything from reactive arthritis, cutaneous vasculitis, internal vasculitis, small vessel vasculitis like polyarteritis nodosa, or it could be anything. It can be adult onset Still's disease, something like that. Epidemiology, female preponderance, female to male ratio is 90:1. Sex skewing least understood. Estrogen appears and all these points are DNA methylation and remethylations are defective. Potential changes in the ovary or testis. Now they say that ovary or testis might carry the antigenic potential, and the actual real pathology may lie in the testis or ovary. The ovulation is defective. The spermatogenesis is defective. This is the latest emerging factor. Environmental triggers, poor socioeconomic classes. The SLE typically affects the poor people. Rich people are spared. We don't know why. It is more worse in African Americans, Asians, Caucasians, and Filipinos, and it is bit less common in the white people. Yes, Dr. Subramanian said gut microbiota plays a major role. Translocation of the gut microbiota into the liver is in susceptible mice associated with interferon signature and increased lupus risk. Escherichia gallinarum, a gut microbiome, is often implicated. Criteria, again, I don't want to bore you. ACR criteria, Euler criteria, ACR Euler criteria, SLIC criteria. The criteria should not be applied for the diagnosis of individual cases. Please kindly remind, don't apply criteria. Criteria should be applied for diagnosis of a group of patients in a particular cohort. For individual diagnosis, it is a clinical feature plus a immunological feature. Enough. Don't apply 4 out of 7, 4 out of 11, 3 clinical, 3 immunological. Don't worry about all this. These 11 criteria: molar rash, discoid rash, photosensitivity, oral ulcers, arthritis, neurologic, renal, hematologic, immunologic, antinuclear antibody. So there are 11 about which you should know at least a few factors. Smaller rash. Somebody has smaller rash. It's a hidden epidemic only. Malar rash in Indian races in dark complexion, very difficult to appreciate. Still, most of our people has only photosensitivity. The malar rash is not SLE rash. You have to see whether the nasolabial fold is involved or not. If the nasolabial fold is involved, then it could be one of the diseases that a popular actress is suffering from, dermatomyositis or a inflammatory polymyositis with or without skin involvement, myositis. Whereas if there is lacking of the involvement of this area, it could be seborrheic dermatitis, it could be SLE, polymorphous light eruption, or tinea albae like fungal infections. And if the nasolabial fold is affected, it could be polymyositis, dermatomyositis, or some other features. A patient is diagnosed to have SLE if biopsy-proven lupus arthritis and a positive ANA or anti-dsDNA to fulfill 4 of the out of the 11 criteria, including 1 clinical and 1 immunological criteria. SLIC criteria more sensitive, 97% versus 83% of the ACR criteria, and less specific. SLIC criteria is more sensitive but less specific. SLIC criteria is used in clinical trials. Both ACR and SLIC are useful and approved by FDA and European Medicine Agency. A working group of ACR and Euler devised a set of criteria with the purpose to improve sensitivity and specificity. 7 clinical domains and 3 immunological domains with the ANA titer of at least 1 in 80 is mandatory. In most of the laboratories, don't get confused. They will give 1 in 40 dilution, ANA, speckled positive. Don't worry about the diagnosis. The pattern and the severity. I mean the titer strength. The titer strength should be more than 1 in 320 normally. But in most of our laboratories, 1 in 80 is enough. Suppose if it is 1 in 40, then you have to go for a ELISA test. Commonly, we do a indirect immunofluorescence test. This already I have told. The constitutional features could be 90 to 90%. What are the constitutional features? Fever, weight loss, malaise, fatigability, loss of appetite, loss of weight. Mucocutaneous involvement, 80 to 90%. Again, it can be oral ulcers, usually painless oral ulcers in the soft palate. Musculoskeletal involvement, very, very important, because in arthritis of SLE produces severe arthralgia, because the arthralgia of SLE is very severe. But if you touch the fields, the finger or fingertips or PAP, MCP or DAP feels cold. Cold fingers with severe arthralgia is arthralgia, so typical of SLE. The pain is out of proportion to the synovial inflammation. And Dr. Subramanian was telling DAP is not involved. Why DAP is not involved in RA? Because RA, as the fingers taper, the synovium is lacking in the DAP. That is why in rheumatoid arthritis, there is no DAP involvement. DAP involved is only in 4 conditions. One is osteoarthritis, bone is directly involved. And there is psoriatic arthritis, second thing. Third thing is multicentric reticulohistiocytosis, and fourth is sarcoidosis. These 4 diseases only, and occasionally brucellosis, can affect the DAP. Okay. Glomerulonephritis in 40 to 60%, neuropsychiatric SLE in 40 to 60%, and the commonest NPSLE is cognitive dysfunction, and the criteria says it's psychosis, seizures. This is not common. The common cognitive dysfunction, more than 95% patient will have cognitive dysfunction. மறந்து வச்சிட்டேன், எனக்கு சாவி எங்கே வச்சுன்னு தெரில. They will light the gas. I have seen a lot of patients. அடுப்பு பாத்திரத்தை வச்சுட்டு வந்துடுவாங்க, மறந்துடுவாங்க, அதை தீ பிடிச்சி எரிஞ்சிட்டு இருக்கும். Not only one occasion, several occasions. So forgetfulness, these are the common neuropsychiatric manifestation. And reversal of the sleep pattern. நைட் தூக்கவே மாட்டாங்க, மார்னிங் 7 தூங்க ஆரம்பிச்சாங்கன்னா 12 வரைக்கும் எழுப்ப முடியாது. ரிவர்சல் ஆஃப் ஸ்லீப் பேட்டர்ன். These are all the very common neuropsychiatric features of SLE. Autoimmune cytopenia, very common. Autoimmune hemolytic anemia. A male presenting with a hemoglobin of 9 always suspect lupus. A man, unless having constipated or having hematuria or the chronic hemorrhoids like features, you have to rule out a lupus. This is a typical molar rash sparing the nasolabial fold. This and the bottom right is the discoid lupus. Discoid lupus, if you do a biopsy and you will see paste features for follicular plugging, atrophy, seborrhea, telangiectasis, and erythema. These are all the paste features of the discoid lupus erythematosus. And this is a Jacquard's arthropathy. This Jacquard's arthropathy is very important because this is produced in rheumatology only with 2 conditions. One is SLE, 2 is psoriatic arthritis. The patient will have deformity like that. If you place the fingers over the X-ray plate, the deformity will be reversible, correctable deformities, Jacquard's arthropathy. It is due to inflammation and fibrosis of the periarticular structures. It is not a destructive arthropathy. The interarticular surface is never involved. The articular surface is never involved. It is to the laxity of the surrounding structures. These Jacquard's are like arthropathy, where the person have a Jacquard's arthropathy, Buttonnier deformity, what other deformity, stand-like deformity, Buttonnier deformity, any other deformities, that all are reversible. Renal involvement is very important. Present as microscopic hematuria, but to a lack of time, I am rushing through. It can present with plus always qualitatively and quantitatively analyze the evaluation of the protein excretion, because the renal involvement is main cause for the endothelial dysfunction. Renal, likewise, after 10 years, rheumatoid arthritis will not be called as rheumatoid arthritis. It will be called rheumatoid disease, because it is not only arthritis, is only arthritis. What is fever for general medicine is arthritis for rheumatology. Rheumatology is arthritis is one of the other picture of some other internal problem. So we have to find out what is the internal problem. So probably nephritis, you have to be very careful because it causes morbidity in the cerebrovascular system, cardiac system. Sorry, I will complete, sir. Laboratory evaluation, urinal assessment, renal function, renal biopsy. Renal biopsy again controversial. Some are implicated. I don't advocate renal biopsy. I have not managed a case with the renal biopsy. And during the discussion, I am willing to answer for that. Maintenance of renal function with dialysis, renal replacement therapy. This is membranous lupus nephritis, mesangial proliferative lupus, reversible. IgG deposits, neuropsychiatric, gastrointestinal, ocular involvement, very common. Retinal vasculitis, you cannot miss us. AIRVU, acute retinal vein obstruction, acute retinal artery obstruction. If it occurs, you have to suspect a associated antiphospholipid antibody syndrome, which I forgot to mention. Diagnosis of lupus. Different management, aim of therapy, remission, drug toxicity should be minimized. 3 seconds, sir. Hydroxychloroquine, it's a wonderful drug. Trump should be appreciated for his overwhelming response for hydroxychloroquine for subsequent was snubbed. Poor Anthony Fauci could not defend Trump for known reason, obvious reasons. It has got a wonderful molecule, pleiotropic actions, anti-atherosclerotic, anti-platelet activity, anti-ischemic activity, antioxidant so many actions. So all the presentation of lupus should be treated with hydroxychloroquine. Visual toxicity is very, very, very rare. Once in a year screening is enough. Retinal toxicity almost nil. If you screen at the initiation and after 1 year or 2 years, you can again screen. With the chloroquine, you have to screen for every year. And most of the SLE disease flare should be treated with the IV methylprednisolone 1 gram for 3 days, followed by 1 to 2 milligrams, subject to maximum 60 milligram per day in single dose. Please remember, steroid should never be given in lupus patients in divided doses. The only indication for division of 2 or 3 doses is myositis, severe myositis. That is the only indication. Otherwise, you have to give a single dose. Always supplement with the calcium and maintenance therapy with either azathioprine, 25, to start with, you have to administer an enzyme. And if you lack the enzyme sensitivity, then you have to start with offer 25 milligram per day, 50 milligram, then escalate after 1 week. If there is no neutropenia, granulocytosis or sore throat, then you have to go to up to 100 to 150 milligram, 3 tablets at a single dose. Or if the patient is rich enough, you put the patient on MMF, half tablet to be start with, and you can go to up to 3 gram. Only complication of azathioprine is pancreatitis, and of the MF one is gastric intolerance, gastric upset, diarrhea, and no other side effect. So you can treat the lupus patients on your own. Start with hydroxychloroquine, low dose steroids, start steroids at a higher dose. High dose of steroids for even 20 days, abrupt stop, no HPA suppression, no side effects. So you have to start with high dose, rapidly taper, then maintain with 7.5 milligram per day, then use steroid sparing agents, use azathioprine, MMF, cyclosporine, tacrolimus, sirolimus, so many wonderful drugs are available. So lupus is treatable, preventable, hidden. With after COVID epidemic, be aware that anybody having a prolonged pyrexia, lot of abdomens are open. Abdomen is normal, they closed. The patient is happy, doctor is happy. It is actually it is mesenteric ischemia. There are a lot of points I couldn't speak within 20 minutes. With this, I think the hidden epidemic of SLE will manifest in some way, and the shrewd and astute clinician can always look for it, anticipate it, catch it, treat it, hit it aggressively, and save the patients. Thank you.
Thank you, sir.
Any questions from the floor? Any questions? This topic is a very, very common topic.
Sir,
We expect both. Yes.
It's a wonderful point that the distal interference joint is not affected in rheumatoid arthritis because it involves a synovium. That's a wonderful point. Sir, one point I think is any arthritis, the concentration of the steroid in the cartilage is high. So as low as 10 milligram of prednisolone is sufficient for a management of arthritic problem. If that is the case, why should you want to go high dose? And if it is that what is the need for that?
Arthritis, you are not supposed to use steroids. Arthritis should be managed with NSAIDs and intra-articular steroids. There is one concept known as intra-articular steroids. Systemic steroids is indicated only in RA in few situations. One is RA with severe vasculitis, RA with life or organ-threatening complications of the rheumatic presentation. That is only 2 indications where you use. There is a COBRA trial where they used 60 milligram of prednisolone in the initial period with the combination immunotherapy, and then subsequently they say no side effect. But Steroids, now there are safer steroids are available. Deflazacort, so many things are available which are not adaptogenic. So steroids are not indicated. Go and inject intraarticular. A joint can be injected 3 times a year. You can inject the same PIP or MCP, second MCP, third MCP, 3 times a year. 1 year you can inject 3 times. Again, next year you can inject 3 times. So I don't think in normal arthritis, steroids, if at all you can use 0.5 milligram per kg per body weight, 20-25 milligram, taper it over 1 week, 2 weeks, then you maintain for 5 milligram, 2.5 alternate days, then stop. No need for higher dose of steroids. Higher dose of steroids are indicated only in very complicated stages where you have life-threatening or organ-threatening complication in SLA or some other thing. Rheumatoid arthritis, there is very few indications only.
Thank you, sir. Thank you, sir. Yes, if it is oligoarthritis, you just follow the intra-articular pathway. If it is multi or polyarthritis, the DMARDs normally take 4 to 6 weeks to work. So we need to bridge what we're going to do. So anti-inflammatories, normally NSAIDs can be used, but for the patient's benefit, symptom benefit, you are going to give a small dose of oral steroids, maybe for 2 weeks, until the bridge therapy, until the DMARDs come into effect. So in that case, the newer biologics have quicker onset of action. So they do act within 4 or 5 days. That can also be considered. Sometimes if they are expecting pregnancy and all those things, we don't give DMARDs because all of them have longer onset of action, but then they are there in the system for many months. In fact, leflunomide stays for years together, 2 years. So we do not give leflunomide for any expecting baby or pregnant mothers or young adults, young women. So we don't give that, and it also can cause hypertension. So we normally monitor that. So that is for arthritis for rheumatoid group. I think for lupus, yes, we do have high dose of steroids, and as sir was saying, in a extra neural or renal or pulmonary involvement, we do consider high dose of steroids. Thank you, sir.
Dr. Subramaniam. One minute, sir. You always remember the window of opportunity. You should never miss the window of opportunity. What is the window of opportunity? Window of opportunity is the onset of the first symptom. The joint pain ஆகுது அப்படின்னு சொல்றதுல இருந்து the first radiological manifestation, it can be a juxtaarticular osteopenia, it can be a erosion, it can be anything, articular space. This is the window of opportunity. If you hit the disease in the window of opportunity, then the outcome will be very good. There will not be a damage to the joint. Number 2, these low-dose corticosteroids are very harmless, unless, contrary to the Vandana patient, Subramani sir சொன்ன மாதிரி எவ்வளோ நாளைக்கு சாப்பிடணும், ஸ்டீராய்டா வேண்டாம், NSAIDா வேண்டாம், என்ன பெயின் கில்லரா வேண்டாம், ஸ்டீராய்டு வேண்டாம், டக்குன்னு பேனா போட்டு மூடிட்டு உட்காந்துடுறேன். சரி ஜபம் சொல்லலாம், வாங்க மந்திரம் சொல்லலாம். ஐ க்ளோஸ் த பென் அண்ட் புட் த பென். சார் ஓகே, என்ன உங்களுக்கு எந்த மந்திரம் சொல்லலாம். This is what the public attitude, even doctors' attitude. The medical store people will, the great spoiler of your practice. என்ன பெயின் கில்லர் எழுதியிருக்காரு, ட்ரமடால் எழுதியிருக்காரு, ஸ்டீராய்டு எழுதியிருக்காரு. No. The medical profession is in huge distress, and we have to save that because by public education. Thank you. Any more questions?
Dr. Subramaniam. Sir, is there any prognostic value for a very high ESR, very strong CRP? We can prognosticate that a particular person is going to develop a very tough arthritis or joint displacements or something like that. Can we prognosticate?
Definitely, sir. So high CRP is a high inflammatory marker. So that is harbinger of long-standing disease or aggressive disease. And because we do have a DAS28 score, DAS28 CRP is the disease assessment score for patients with rheumatoid arthritis. And if it is more than 3, then it is going to be high disease activity, and more than 5 is hyper high disease activity. So they can get extra articular complications. Definitely CRP is a marker, sir. So if they have normal CRP at the diagnosis, they are the good patients.
Sir, one point I told, the disease is characterized by remission and relapses, remission and flares. Every time the patient has a flare, the CRP will be high. The ESR will be very, very high. CRP normally high. At the any stage, CRP and ESR does not have a prognostication value because they are totally non-specific. We are got other positive acute phase reactants, negative hepcidin C,
and serum albumin is even more accurate. Serum albumin will let you know what is the level of disease activity in the particular patient. That is a prognostic factor. So ESR CRP is still, Dr. Subramani, I agree with Dr. Subramani, but still with every flare up, it will vary and you can't decide. You can say with definitely that that particular attack is under remission now with the ESR CRP. That's all. Thank you, sir.
Thank you, both the speakers. Though the topics were very elaborate and the clinical pathway for the arthritis is very long, and doctor has taken very good guidance showing all the arthritis. And one simple question, sir, Dr. Subramaniam, sir. The present scenario of rheumatic fever, arthritis, and the prophylaxis, and with this will close.
Yes, sir. It's a different view. The cardiologist would like to treat rheumatic fever or any painful joint with the raised ASO for 20 years, 35 years. It goes on. So from a rheumatologist point of view, unless we have a strong evidence, because you don't get rheumatic fever in 30s, 40s, 50s. Some occasions you do get, but this is infection causing reaction picture, and then it's a long-standing rheumatic fever. So I haven't seen acute rheumatic fever for ages now. Yes, now and again we do see in children. Pediatrics manage it and get to the cardiologist and they look after. So we don't get involved very much. And if they have a sometimes we do see patients like 3-4 months, they're treated as rheumatic but not settling down. Then they refer as JIA. So it's more JIA, but the chance finding of positive ASO. So it's not a classical history, but ASO, I think, you can get for every skin infection, any infection, you can get a positive ASO. So it's not typical rheumatic fever, and you don't get that typical history when we were studying. Thank you.
If someone has to take a long-term steroid, which molecule would you prefer?
I do not prefer, sir, because I've seen many people have osteoporosis, diabetes. Now we're talking about cardiovascular disease the whole day. So I generally not to, and if it's affordability issue, sometimes patients do themselves stop everything, just take one steroid and be happy, and don't come for follow-up for a year. Once when they get the diagnosis of diabetes, then they try to come to us, because that doctor says this is the drug you have been taking for many years, that's why you got the diabetes. Then they refer back to us. But otherwise, I do not intend to give steroids. And in fact, my practice is normally one intramuscular injection of methylpred. That's it at the onset. I don't give beyond that. 80 milligrams.
Sir, one point. You asked about steroids. What steroid you will prefer? Albeit it's prednisolone. In India, we give it as prednisolone. In US, they give it as prednisone. Prednisone is a pro-drug and prednisolone is an active drug. So prednisolone is 7.5 milligram is the supraphysiological dose. So anything, the patient you can modulate and bring it to 2.5 milligram per day and maintain for life with adequate calcium supplementation, anti-osteoporotic medication supplementation. There is no harm. So after all, one thing that will go is cataract, which you can very well remove. And if the patient requires lifelong steroids, you can very well put the patient on steroids. I have got more than 300 patients on lifelong steroids. Nothing happens. No osteoporosis, no avascular necrosis. You have to take adequate physical activity, adequate calcium supplementation, vitamin D supplementation, anti-osteoporotic drugs, zoledronic acid, something like that every year, or oral bisphosphonate every week or once a month. These things you have to institute. In a ward or in your practice, a steroid prescription without calcium is a heinous crime. A steroid dose, even if you give 10 milligram or Dexa 8 milligram, you have to give a calcium carbonate of at least 500 to 1000 milligram per day, because steroids cause wasting of calcium in the urine. It retards the intestinal absorption of the calcium. It causes hypercalciuria. So steroid, wherever used, whatever indication, rheumatological, non-rheumatological, medical, non-medical, surgical, or anything, it has to be prescribed with calcium. Thank you.
Thank you, both the speakers, and a very interesting and discussed session. We thank once again the Tapicon and the organizers for the chance.
Thank you, sir. Now I request Dr. Siva Subramanian, sir, to felicitate Dr. N. Subramaniam, sir. I request you to kindly come onto the stage. Next, I request Dr. K.R. Ramanathan sir to felicitate Professor Dr. T.N. Tamil Selvan sir. I also request Dr. T.N. Tamil Selvan sir to felicitate Dr. Siva Subramaniam sir and Dr. K.R. Ramanathan sir for chairing the session. Thank you, sir.
Audience, kindly note that the next topic, ventilatory management, is shifted to as the last topic. Next we'll move on to the topic of toxicology. So in this session, I just call upon the chairpersons, Dr. N.S. Prasad sir and Dr. K. Satish Kumar sir on the dais. The first topic under this session is paraquat poisoning. I call Dr. Professor P. Parandaman sir to take over the dais.
Good evening, everybody. I first of all thank the organizers for having given me an opportunity to chair the session. Again, we are coming to a very, very interesting topic in toxicology. And that is going to be talked by Dr. Parandaman, who we know is a talented physician award for City Physicians Association. He has conferred FRCP Glasgow in the year 2018. He is the chief editor, Manual of Toxicology and Indian Perspective, and he is currently the professor and HOD of the Department of Medicine, Government Keel Park Medical College, Chennai. I think he'll be talking about the topic of paraquat poisoning. Is it so, sir? Paraquat poisoning you're going to talk, isn't it? Yeah. As you are all aware, now next to organophosphorus poisoning, commonly we are encountering two poisons, that is rat killer poisoning and paraquat poisoning. These are the common poisons which we are seeing in our day-to-day practice, and we need to know everything because at least in organophosphorus poisoning we have got specific drugs for treatment. We have got PTM, we have got atropine and so on and so forth. Whereas these two poisons, be it paraquat poison as well as rat killer poison, are really, really dangerous and are very deceptive also. And what happens is people think that they are all very, very not are innocuous poison, but they land up in various fatal complications involving the various organs for that matter. The GI, GI side effects, the cardiological side effects, the renal side effects, and so the hematological problems. So what to say, they encounter so many complications, and more than 50% of them might land up in some, it could be fatal, or even if they recover, they can have some sequelae. இதை வந்து கலக்கொல்லின்னு சொல்லுவோம். In Tamil we call it as கலக்கொல்லி அப்படி மருந்து அப்படின்னு, that is what we say. To talk more about it, I request Dr. Parandaman sir. Over to you, sir.
Sorry to interrupt, sir. By mistake, our announcer forgot to say about the next chairperson. I request Dr. Saravanan, HOD from PLC, to be the co-chairman. Thank you very much, sir.
Thank you very much, sir, for a kind words. Most respected chairpersons, dignitaries, distinguished members, and dear friends. At the outset, I'd like to thank the organizers having invited to talk on this most prestigious conference, Tapicon 2022. My thanks to them. See, the paraquat poisoning, the paraquat is a weed killer. It's instantly is the second most selling weed killer in the world. It was not so earlier. Now it's become more and more common. It's a bright in color. It's a pungent in odor. It's available as a 20% solution. It has to be used diluted to use as a weed killer for the plants. If you go for the pharmacokinetics, it is primarily absorbed in the gut. The peak concentration 1 to 2 hours. The distribution more in the lungs, even though other organs like kidney, liver, and muscles are being also getting absorbed. The concentration in the liver is 6 to 10 times more than the serum concentration. The elimination prime 90% by the kidney, and this particular specialty is very, this character is very important. The higher the concentration of the poison, higher the concentration of the lung concentration. So we have the rule of 20. What is rule of 20? Anything taken more than 20 ml is poisonous. Anything 20% is poisonous. It is anything more than 20% stays in the stomach of more than 20 ml is dangerous. So, but more importantly, when it's mixed with the soil or the food particle, it becomes inactivated. If this burned, the paraquat is burned, it becomes inactive. How does it cause the injury? The primarily targets the mitochondria of the cell, which is a powerhouse of the cell, and releases more of reactive oxygen species, especially the oxygen free radical hydroxyl and hydrogen peroxide, that injures the alveolar epithelial cells and pneumocytes. This is almost akin to the COVID. How it is akin to COVID? See, within 48, that is 72 hours of 92 hours, the pulmonary alveolar concentration is higher and decreases surfactant, thereby the transudation of fluid into the alveoli causing pneumonia. And also it is causing the endothelial damage, which occurs maximum at the 72 hours, is causing the activation of the cascade pathway, the coagulation abnormality. There is alveolar epithelial abnormality causing pneumonia. There is endothelial dysfunction causing coagulation abnormality. This almost mimic like a COVID. It's always called chemical COVID. If you see the pathology, there are two phases, exudative phase and proliferative phase. When the exudative phase, alveolar capillary barriers are broken and every cells into the alveoli, whereas in the proliferative phase, the fibroblast proliferates and causes fibroblasts and hyaline formation, that are hyaline membrane disease, ARDS. If you see the radios, that is the electron microscope picture, it shows there is initially there will be alveolar hemorrhage, followed by the neutrophil infiltration, the picture B, and hemocyte formation, the hyaline membranes around the alveolar walls. That's another common problem. If it severe poisoning, the hyaline membrane becomes alveolar. Everywhere the deposition occurs, the fibrosis sets in, hyaline membrane sets in. There is no space for the ventilation to ventilate the capillary or the hemoglobin. Clinical presentation, it may be GI, right from the ulcer from the oral mucosa to the GI. It can cause GI symptom. It can cause primarily respiratory symptom, cough, breathlessness, hemoptysis. In genitourinary symptoms, you have necrosis, papillary necrosis, a renal dysfunction, hemopoietic alveolar leukocytosis, anemia, CNS manifestations can cause coma, seizures, including the endothelial abnormalities, which cause adrenal crisis and adrenal cortical necrosis. If you take a CT scan, they've studied out of 39 patients, 26 patients, there's a diffuse consolidation, which occurs like almost like a COVID. And also, with the parenchymal infiltration, there is a fibrosis. If you take a CT scan after 9 months of the small dose of COVID, the paraquat, it causes a fibrosis, as you similarly look into the COVID picture. So this is a picture of a person who was admitted with the paraquat, and see subsequently there is a fibrosis and there is a cicatricial bronchiectasis also be there. So these are complications like pneumothorax also can occur. So the management is you go by this order. So any poison, it has to be removed from the body. If it is contact through skin, wash the skin. If you contact through eyes, wash with the saline and water. If it is taken injection, you give activated charcoal as soon as possible, especially within 1 hour. it immediately goes and binds, inactivates, not only prevents absorption of the poison, it inactivates the poison because the character is that if anything get absorbed, it become inactivated. So very effective is activated charcoal in the early stages, but not in a person who's developing corrosive and hematemesis like acid should not give, but it's a mild to moderate dose as early as possible, given within 20 minutes, so probably you can save the life of the person. And also the most important treatment available is actually hemoperfusion. As early as possible you have to give. So that's what we are going to say, the golden hour. We have got a golden hour everywhere. So now golden hour period for thrombolysis is 4 hours. And for myocardial infarction, 6 hours. Golden hour for the paraquat is 4 hours. So you have to give hemoperfusion within 4 hours. And of course, it is like I say, methylprednisolone, large dose, there is high dose of methylprednisolone, 500 milligram per day. And with cyclophosphamide, what is exactly given in COVID is that's there. And there is you give in low molecular heparin. Low molecular heparin is not only thrombosis, it improves the inflammatory milieu over there. So it is very useful. It's found to be useful. There are several articles are quoting that the mortality is decreased with the low molecular heparin. And also NSSC use it for lung injury. Regarding the oxygen, so this is a one which causes severe hypoxemia because alveoli is damaged, capillary is damaged. That is hypoxemia, severe problem. So in the severe problem, but if you give excess oxygen, it accelerates the lipid peroxidation which is caused by the paraquat. It worsens the damage. So thereby you should not give high dose oxygen. If you don't give oxygen, if hypoxemia, the worsen, then hypoxemic cardiac arrest will occur. So what you do, you look for PaO2, the arterial blood gas. So most of the time, we're not able to take a PaO2. That means you have to take a ABG. So you go with SpO2. If anything is SpO2 less than 90, that is less than 90, SpO2 is equal to 60 millimeter mercury of PaO2. So you give oxygen, use small dose, not the high dose, high flow oxygen. So, and if you want to give ventilator support, the better, I always better go by the Boyle's apparatus with the nitrous oxide. It decreases the conscious level and also improves the lung function. It delivers only a small dose of oxygen, not unlike your high frequency ventilation or the hyposaturation. So, oxygen worsens the paraquat poisoning, paraquat worsens oxygen poisoning. So, now, as of now, what is described in the literature is the only proven treatment is low tidal volume, low pressure ventilation, mechanical ventilation is a proven treatment. So regarding the low molecular heparin, we all know the low molecular heparin can be used for all conditions where the thrombosis is occurring. Apart from antithrombotic, it's specifically localized to the immune muscles. The immune muscles, that's the one causing inflammatory milieu. So it blocks that, and also it decreases the complement cascade pathway, thereby it decreases the coagulation of abnormality. So the mainstay of treatment here is that low molecular heparin. Now they also tried the inhaled heparin, where it specifically reduces the vascular leak in the pulmonary capillary endothelium. So it's been proved beyond doubt, and inhaled antithrombin is also found to be very effective. And of course, regarding the hemoperfusion, it should be given as early as less than 4 hours. And if the dose is taken large quantity, you repeat it every 4 to 6 hours for 48 hours. It improves outcome. You can prevent the death at least. And also, you should be continued for more than 24 hours. So as I already alluded to, the initial 4 hours is a golden hour for paraquat poisoning, like thrombolysis in CVA or acute CVA. And it is associated with 62% reduction in mortality if you give thrombolysis. And in addition, if you add, after the thrombolysis, paraquat, there is a hemoperfusion, if you add methylprednisolone, cyclophosphamide, and improves the outcome, and it prevents mortality by more than 70 to 80%. So that's been proved beyond by doubt. And of course, we can use some fibrotic, antifibrotic drugs, like corticosteroid, immunosuppressant, antifibrotic. Apart from that, you can use pirfenidone. Again, pirfenidone is used for COVID, so that can be used. And this radioactive inhalation, nitric oxide can be used. And of course, low flow oxygen also found to be used. And antioxidants like vitamin E, vitamin C, vitamin A, and selenium all also be found to be useful for paraquat poisoning. So these are the mortality reduction treatment available for paraquat poisoning. It's early there is hemoperfusion and pulse methylprednisolone with cyclophosphamide, followed by the oral drug and low tidal volume protective ventilation. And of course, you can use the low molecular heparin. So these are the portions available to decrease the mortality in a COVID, that is in a paraquat poison. And there are some experimental. It is experiment always start with the experiment to the animal, then it is again applied to the human. So what is found is so metformin 35 milligram per kg intraperitoneally decreases acute lung injury. So wonderful, because by modulating the alveolar macrophages in the lung, it improves the mortality. And oxalo is the one which eliminates the nitric, that is oxygen free radicals from the intracellular epithelium. So whatever the oxygen free radical which is produced inside the cell, it's been eliminated by oxaloacetate. So wonderful. And doxycycline, it's supposed to decrease the matrix bacteriopoiesis, which is released by the macrophage and produce acute lung injury. That is very helpful. It's a commonly available drug. And of course, we have this the monoclonal antibody, which is against a single chain antibody. And most importantly, propranolol. Propranolol is the one which eliminates the accumulation, prevents accumulation of paraquat inside the cell. So it's available freely. And of course, cyclophosphamide and propranolol, it effluxes the paraquat from the cell. So these are the drugs which is an experimental in animal. So it's found to be useful. Of course, length transplantation is the last measures. It might not be that useful if unless taken this thing. So if you are come with the poison, the paraquat poisoning, if your dosage you are confirmed, you don't need for any of this law. You can treat as previously mentioned. If you do not know the poison, what he has taken is a paraquat. So you go by urinary diphenylate. So that is diphenylate. That's the one which is exists in the urine. So that is the indication, or that is, you can confirm the paraquat poisoning by urinary test, dimethylate, which is increased. So if that is there, you go by or repeat after 6 hours. If it is negative, then if it is positive, you treat as a paraquat poisoning. All the drugs like glucosteroid and ventilation, the hemoperfusion, anti-inflammatory, everything can be used as a treatment methods. So prognosis depends on the dose. The survival depends on the dose he has taken. Higher the dose, higher the concentration level. Lesser the dose, lesser the concentration. The mortality is high with the higher the dose. So the patient should ingest. Of course, they found that the patient was taken intentionally, taken a large amount, so mortality is high. The patient is taken incidentally, it is less quantity, so less mortality. This is also found beyond doubt. So now, as I already mentioned, there is a similarity between paraquat and COVID. Pulmonary epithelium is affected. There is also pulmonary capillary epithelium endothelium affected. Pulmonary concentration 6 to 7 times more. The pulmonary concentration 70 times in the COVID-19. There is hypoxia in COVID. That is a change of thing. And severe poison, the hypoxia in COVID. And this is an acute severe hypoxemia in paraquat. Sorry for the typing mistake, the last minute slide. So, and hemoperfusion, steroids, immunosuppression, all these are given. Similarly, steroids, immunosuppression given in steroid. And mortality is 70% there, mortality is 2%. But the paraquat poisoning is a severe COVID, it's not an ordinary COVID. So it's equal to severe COVID. So the COVID paraquats are similar. What you give for COVID, you can give for paraquat except remdesivir. So that's the takeaway. These are the studies we have done. And of course, the rat animal models, the concentration of the blood and urine, kidney, paraquat is very high. It's been proved. And now the inhibitory effect of the pirfenidone in pulmonary fibrosis is studied, is found to be effective. It prevents the fibrosis, thereby improves the outcome. This is yet another study studying that the heparin and glucocorticosteroids are with cyclophosphamide decrease the mortality. And the metformin regularly alveolar macrophage polarized. This is a study, it's done, it's a paper published by Frontier that against the acute lung injury, it improves the paraquat poisoning. This is a successful treatment with the paraquat toxin intoxication with the low dose pulmonary ventilation. The oxaloacetic acid ameliorates the lung injury by alleviating the oxidative stress in the mitochondria. So, and these are the references for this. Thank you very much. I heartfully welcome you all for this API conference going to be occurred in the 2nd to 4th of this next month. I welcome you all for this API annual meet and postgraduate teaching institute program. Thank you very much.
Thank you, sir. As usual, the nice description, your way of presentation to the audience regarding the paraquat poisoning. And can we have the question session now? Can we have it now? So the topic is open for floor for question and answer session. Any questions?
Yes.
From this poisoning.
Yes, sir.
Do you have any global data on this issue?
Actually, sir, when there is a moderate poisoning with one lung involvement, so that lung alone can be removed. That now native lung, other lung will be there. They found that in due course, that lung also get involved and fibrous. So they found that lung transplant is not that very effective, especially in paraquat poisoning. We had tried that. It's not found to be effective. But other modalities are very useful.
Sir, very wonderful presentation.
Yes, yes.
Very nice, sir.
Thank you.
Actually, what happened to these recovered patients? Is they are suffering from this fibrosis is an ongoing process, or is it stopped?
Which one, sir?
The fibrosis of lung.
The COVID or
See, recovered patients, paraquat.
Yes. Recovered patient is if they are taken small quantity, less than 10 ml, they only with all the measures you can prevent the death. If anything in large quantity, very difficult. In those individuals, they said, as per literature, they said it completely improves over 9 months of time. So up to 9 months, they'll be having some sort of fibrous changes and its effects. And after 9 months, they found gradually the fibrous comes down and become normal after 9 months. If it is taken in smaller quantity.
Thank you, sir.
Yes.
Your comment on pirfenidone for antifibrotic.
Yes, yes, sir. The preferred is antifibrotic. It is the only drug for now available to use as it is a modulator, again modulator. It prevents the fibroblast activation over there. So it is useful. It's if we found in COVID, sir, not in paraquat. Because paraquat mortality is almost in our setup, it's almost 90 to 100%. So only few patients, maybe 1 or 2 patients improve. So for them, you cannot give you not apply that.
Sir, in periphery areas, we are planning to refer the patient always in the paraquat poisoning. Before referring, can we start steroids and low molecular
No,
heparin, sir?
actually, what you do is that if the recommendation is low volume the perfusion ventilation, if possible. You give boiled separatus, give oxygen, smaller dose, and if it's a saturation is less than 90%. Otherwise, no. Probably the heparin will be useful because that's the one's going to occur in 48 hours. So heparin one is going to cause a worsening of the damage. That can do. And you can do that activated charcoal stomach wash. So as early as possible, you activated charcoal. You multi-dose activated charcoal can be given in the periphery setup. At least if not the heparin, because that we give tertiary care, you do measure the APTT and all these things. So this you do better. You give activated charcoal as early as possible. Try to wash.
Thank you.
It's ideal to go for charcoal. Charcoal treatment is ideal one, sir.
Yes,
Peripheral setup.
charcoal treatment is ideal. The madam wants to ask.
Sir, are there any studies about monoclonal usage?
No, they are in the rat model. They found it to be effective. Mostly it may be effective because unless you study, you have to see the outcome. They are finalizing the FA fragment of the molecule, then trying it. It is only in an animal model.
Excuse me, sir. You had recommended a hemoperfusion, sir. Is it done irrespective of RFT values, or we have to do it immediately, sir?
Actually, the hemoperfusion is different. Hemodialysis is different. Hemodialysis only for those who develop AKI, acute kidney injury. Only for them hemodialysis. Hemoperfusion for those who, because it filters the poison. It filters the poison. This is filterable poison. So hemoperfusion can be done even without renal involvement, if it quantity is significant. And because you know that the literature says the concentration is maximum at the 72 hours to 90 hours. So definitely that will be you're going to develop problem if it's alive in 2-3 days. 4th day is going to problem. So that's it.
There's no further questions. Thank you, sir, for the lucid presentation.
Thank you.
We'll move on to the next presentation.
Thank you, sir. So we'll move on to the next person. We invite Dr. G. Ratnakumar, sir, from Tirunelveli on the topic rat killer paste.
It's my pleasure to introduce Dr. Ratnakumar. He's a professor of TVMCH, Nodal Officer of Curriculum-Based Medical Education Curriculum, and is been awarded the Best Doctor Award from District Collector and Best Doctor Award from Rotary Club and Doctor Award from Vasigi Tamil Mandram and he has got to his credit lot of books and articles. I request Dr. Ratna Kumar to take over the further proceedings of the session.
Very good afternoon to all. My sincere thanks to the organizers and my wishes to my professors, teachers, and colleagues, and also my students. So, my topic is rat killer poisoning. Poisoning, as you know, is a major health problem next to communicable and non communicable disease in India. That too, as Sir correctly pointed out, next to OPC, nowadays the two top leading poisons are paraquat poisoning and rat killer poisoning in our intensive care unit. Rat killer poisoning, why common? Because it is easily available, accessible, and very cheaper. So, we must do early symptomatic treatment to decrease the mortality. What are the types? It may be suicidal usually. It could be also accidental and could be also sometimes homicidal. If you take mode of poisoning, usually ingestion, rarely inhalation and dermal route. It was once upon a time available as powder, pellet, then biscuits. Now, more life-threatening form is rat killer paste. Classification. Inorganic compounds like barium carbonate, phosphorus, zinc phosphide, aluminum phosphide, and thallium. Inorganic compounds, fluoroacetic compounds. Then calcifying agents, cholecalciferol. Seizurogenic agents, strychnine. And more lethal compound is anticoagulant. If you take anticoagulant, the first generation warfarin and second generation bradifacum and difenacum. The second generation bradifacum is 100 to 150 times more toxic than warfarin. What is the basic mechanism of rat killer poisoning? Zinc phosphide. The phosphide combines with hydrochloric acid in the stomach and releases phosphine gas. This phosphine gas is toxic to mitochondrial cytochrome oxidase that ultimately cause pulmonary toxicity. Then what is the mechanism of next compound, cholecalciferol? It usually raises the vitamin D3 level and cause hypercalcemia and ultimately calcification along the blood vessels and also in the brain, also in the heart and lung. The calcification may lead on either to tubular necrosis or conduction block. The life-threatening compound of rat killer poisoning is an anticoagulant. How it acts is it inhibits vitamin K dependent factors, factor 2, 7, 9 and 10, and ultimately block the coagulation pathway and cause bleeding. It can also increase the capillary permeability and can produce tissue hypoxia. And deoxycoumarin actually directly act on the blood vessels, small blood vessels, and it is the culprit for internal bleeding. Yellow phosphorus in the paste, especially in the southern districts, it is the culprit. It also releases phosphine gas and it is also garlic in odor. The phosphate level in the serum increases that ultimately leading on to fatty degeneration of mainly liver, then kidney and brain. If you take clinical features, the clinical features are usually vague. Zinc phosphate produces nausea, vomiting, abdominal pain, diarrhea, cough, dyspnea, and confusion. The next important compound, cholecalciferol, usually produces nausea, vomiting, fatigue, weakness, and polyneuropathy. Yellow phosphorus. First 24 hours, it usually produces nausea and vomiting. 24 to 72 hours, asymptomatic period, during which we should be very keen. During which period we usually miss the case. After 72 hours, it produces fulminant hepatic failure, acute renal failure, coagulopathy, shock, and coma. The anticoagulants, as you all know, it usually produces bleeding manifestations. Bloody diarrhea may be the first symptom, epistaxis, hematemesis, shock, and confusion. The other compounds, barium, thallium, strychnine. Barium usually produces nausea, abdominal pain, and weakness, but strychnine usually produces generalized tonic-clonic seizure. Arsenic, which is not a usual compound, sometimes could have been added, which produces typically nausea, vomiting, peripheral vascular disease, cardiac arrhythmias, QT prolongation, tardive dyskinesia, pancytopenia, ARDS, and hepatorenal syndrome. How to diagnose? As with other poisoning, it is mainly by circumstantial evidence, then by container identification, then by patient history, then by history from the attenders. Phosphide can be diagnosed easily by its garlic odor, and urine you can demonstrate the reducing substance, and well sophisticated laboratories may demonstrate the phosphine gas by gas chromatography. You can also do assay of thallium, barium, arsenic, and phosphide in specific laboratories. What investigation is mandatory? Complete blood count, renal function test, liver function test, coagulation profile, electrolytes, ABG, ECG, X-ray chest, plain X-ray erect abdomen, and you can do assay of factor 2, 7, 9, and 10. And 4-hydroxycoumarin levels can be measured by liquid chromatography. What is the management? The guidelines are now given by Government of Tamil Nadu, and it is practiced in all the medical college hospital, government medical college hospitals. What is the protocol? First one is ABCD, airway, breathing, circulation maintenance, and decontamination. Should you do gastric lavage? Yes. It should be done with Ryle's tube or orogastric tube. Within how many hours? Within first 1 hour is better, or up to 4 hours ideal. It's not at all useful after 6 hours. It can be done in 1:1000 potassium permanganate. Some textbook they insist, because it converts phosphide into less toxic phosphoric compounds, which can be eliminated. Role of activated charcoal, which is an universal antidote, which can absorb toxic substance because it is a negatively charged material which can absorb all the positive charged toxins. It should be done within 4 hours. The dose is 1 gram per kg. 1 gram per kg within 1 hour. 25 to 100 grams to be dissolved in 200 ml of water and given oral. And remember always that in rat killer poisoning, avoid sedatives. High carb, high protein and no fatty diet because fat increases the absorption of phosphate. So avoid fatty diet. Daily in the bedside, in intensive care unit, what you have to monitor is any alteration in the sensorium, any deepening of jaundice, any bleeding manifestations, any hemodynamic instability, any volume overload. Apart from that, you must do daily CBC, liver function test, renal function test, electrolytes, ABG and coagulation profile. This drug is an emerging drug, has got many clinical indications in general medicine and intensive care unit. N-acetylcysteine. The N-acetylcysteine increases the level of glutathione in the liver. It's not only an antioxidant, but also conjugate the toxic metabolites. But it should be given during the initial period in correct dose. Within the first hour, 150 milligram per kg in 250 ml of 5% dextrose. In the next 4 hours, you should give 50 milligram per kg in 500 ml of 5% dextrose. In next 16 hours, 100 milligram per kg in 1000 ml of 5% dextrose. So it should be continued for 16 hours to have a sustained effect. Then as all the poison does a gastric inflammation, you have to do IV pantoprazole. Sometimes cerebral edema may be a problem. You have to tackle with IV mannitol 1 gram per kg as a bolus dose, provided having a keen eye over the renal function and cardiac function. In aluminum and zinc phosphate, which are commonly found in powder, so you give IV fluids, correct the dyselectrolemia, mechanical ventilation if at all needed, then vasoactive substance. Coming to the management of a major ingredient of rat killer poisoning, vitamin K. If it is a first generation anticoagulant, 10 milligram vitamin K subcutaneous for 2 weeks. If it is a second generation difenacum or bradifacum, 10 milligram subcutaneous should be continued for 4 weeks. If not controlled, you can try FFP. If not so, PCC, prothrombin complex concentrate, otherwise called as factor 9 complex concentrate, which contain factor 2, 9 and 10, sometimes 7 also. If at all you need a sedative, choose midazolam 1/4 of original dose, and ultimately plex therapy, anticoagulant especially bradifacum, which is 100 times more toxic than warfarin, that is very well tackled by plex therapy, which is a novel therapy nowadays adapted in all government medical college by government of Tamil Nadu. Plex therapy, what is the indication? INR, more than 4. Then worsening of INR, deterioration in the level of INR, and worsening of sensorium. The two main contraindications are hemodynamic instability, where you cannot even think about flux therapy, and also active sepsis. So you have to put a central line. Femoral vein is better. Before starting the procedure, prophylactic antibiotic. If needed, you can take a swab for culture. Tablet prednisolone, 10 milligram is given from the day of flux therapy, continued for 4 weeks to prevent cytokine storm. To prevent cytokine storm. Low volume plasma exchange is preferable, 50%. What fluid is exchanged for plasma? FFP. Now flux therapy, plasma exchange therapy is the leading therapy in many diseases. For example, in AIDP, sometimes CIDP, myasthenia gravis, and also thrombotic thrombocytopenic purpura, hyperviscosity syndrome. So many conditions, it play a major role because it removes toxins, abnormal proteins. So here in rodenticide poisoning also it is tried and is having a good result. How many cycles you can do is 3 cycles, maximum 5 cycles. During the first cycle, 65% of the toxic metabolites are removed. In second cycle, about 85% of the toxic metabolites are removed. Provided the flux therapy is started immediately. Though the criteria is given as INR more than 4, worsening of INR, altered sensorium. According to the chief IMCU, who is sitting here, and assistants, their version is they should be started as early as possible with the first report of liver function test. You should not wait till the INR is going for 4. When you have the clinical suspicion, when you are very sure that the patient has consumed the paste, when you are particular that the consumption is high, then you can start the flux therapy. Calcium supplementation is needed to prevent citrate toxicity, and you have to take culture every day. What are the complications of rat killer poisoning? I still remember my PG days when Dr. Vairamuthuraja sir was the DAP. One girl, on the day of discharge, on the 7th or 8th day, she was eating, then suddenly collapsed. Sir said it is due to peripheral vascular collapse, peripheral circulatory collapse, and nothing could have been done at that time. But now the scenario has improved. We have got a very strong protocol by the government of Tamil Nadu for rodenticide poisoning to prevent this complication. Fulminant hepatic failure, acute renal failure, acute lung injury, coagulopathy, shock, hepatorenal syndrome, ARDS, even coma. What is the discharge criteria? It can be discharged on the 7th day, provided clinically stable, provided laboratory parameters are very stable, and you can review the patient after a week. Death in rat killer poisoning is usually due to fulminant hepatic failure and cardiac arrest. This is the cycle. N-acetylcysteine, then flux therapy. The patient is still worsening. Plan for liver transplantation. I just want to put some statistics in Tirunelveli Medical College Hospital. From June 2022, where the government has insisted us to follow the guidelines up to November 2022, total number of Retol powder is 48%, 48 cases. Why Retol, we asked. Our assistant asked several patients, why you are using Retol? They said, the rat eat that powder and went out of the home and it dies. It doesn't die for a known or unknown reason inside the house. That is why most of them prefer. They said rat killer paste 21 cases, rat killer cake 8 cases, rat killer biscuit 1 and pellet 1, total 79. Among 79 rodenticide poisoning patients, 32 were discharged, 36 absconded. Never ask. AMA 1 and death 7. Transfer out to psychiatry 3. That can be also taken into account. 32 plus 3, 35. Among 7 deaths, rat killer paste predominate, 5 cases. Out of 21 rat killer paste poisoning, 8 were discharged, 6 absconded, death 7. Abscond we cannot prevent in government hospital because it's a patient right. And plex therapy is not, I think, practiced in private hospitals of Tirunelveli. Of 8 discharges, 1 by never ingested. Sir talked about paraquat poisoning and we got so many information. And he's pioneer in the field of toxicology, but what we used to tell is when a paraquat survives, that he has not consumed paraquat. So one fellow was discharged and on 41st day, he died at home. So 4 patients had taken Retol paste of less than 5 grams. These patients continued to be clinically stable with the normal parameter. 3 patients have elevated liver enzymes and consistent dearrangement in PT-INR. After successful plex cycles, they have been recovered. And efforts are being made to follow up with the 6 absconded patients. And 7 patients who died had an injection dose of more than 10 grams and they presented very late. So early presentation and early institution of protocol-based treatment could have saved. Plasma exchange is a novel therapy in the rat killer poisoning. Right, with this I conclude my speech. Thank you, sir.
Thank you very much for your very lucid and excellent lecture on rat killer poisoning. I think most of you would be very much interested to ask your doubts. The forum is now open for discussion.
Sir, regarding the investigations, as per the protocol, what is the advice for frequency of monitoring of LFT and PTINR during the in-hospital stay?
So, PT-INR should be repeated in the 12th hourly, sir. And the CBC also 12th hourly. Liver function test according to the clinical parameters. Daily how to do, and you can repeat according to the patient conditions and criticalness.
This can produce manifestation in 2 to 3 days also. So should we do on a daily basis from the beginning?
Yes, sir. From the beginning we have to. So now we focus mainly on rat killer poisoning and the paraquat poisoning. Rat killer poisoning we do daily all these parameters and can be repeated 8th hourly or 12th hourly according to the patient condition, seriousness, and when the INR is rising rapidly or the patient conscious level deteriorates, we do often.
Just add one more point regarding the plasma exchange. It has been the routine protocol for any patients coming across with acute liver injury, not necessarily the poisoning. Planning for liver transplantation, it is one of the mainstay of therapy for the patients waiting for liver transplantation.
So this is a topic of discussion now because the plasma exchange therapy was initially first introduced in 1952 for hyperviscosity syndrome in a case of multiple myeloma. Then now it is mostly useful in AIDP. It gives excellent result when compared to CIDP. And myasthenia gravis also. Then TTP, thrombotic thrombocytopenic purpura and all. But the patients with other liver cell failure prior to liver transplantation, whether the flux therapy, plasma exchange therapy is useful is a debate now, because it only removes the abnormal proteins and also toxins.
Sir, it's again wonderful presentation. Really, for the lucid presentation, you very clearly mentioned about the studies and what was the outcome and all. So as far as the red color poison is concerned, there will be a lot of powders coming. The powder is it a phosphorus or the zinc phosphide? So the powders mostly what we come across in Chennai is only the zinc phosphide. And previously even 5 packets of powder, no, we don't consider them as a poisoning at all, because just for simply taking like that, malingering. But now we found even the packets are the poisonous. So causing, creating hypotension and death also occurring. Mostly SVT is coming with that. So now what actually in the toxicological analysis, we found that there is something is added to that.
Yes,
Previously there was only zinc phosphide. Now something is added. The local preparation is for that. That's the reason why this even 1 or 2 packets of the red color powder is poisonous. So as far as the retol is concerned, it's a phosphorus. The 70% of the poison is constant in the hepatocytes. The rest of the 30% only goes elsewhere. So, and moreover, this causes injury like a thermal reaction. So all the cells absorbs this poison and cause a heat energy and death occurs. That's the reason why there's a liver transplant comes to the role. But generally for liver failure, generally we don't go immediately liver transplant. For here we go because almost all the cells get damaged and thermal reaction, necrosis occurs. That's why 3 types of liver necrosis occur, 3 types of liver damage occur. 1 hepatitis, 1 hepatic injury, and 3 the hepatic encephalopathy like severe necrosis. So in that is the case, if the PTNR is more than 4, probably we go. And if it is a severe ingestion, large quantity, we will go for as early as possible, we go for Plux rather than waiting for the complete picture. So wonderful presentation again, sir. Thank you very much.
Thank you, sir.
Any aluminum preparations are also in there?
Yes, sir. Yes, aluminum phosphate is a cake, like, not the cake, the pellet one. It is a rounded tablet-like thing, which is a yellow color, and sometimes white color also comes. Very big, like a 5 rupee coin size. So that's aluminum phosphide. That's more dangerous than the zinc phosphide. So it causes severe hypotension and cardiac arrest, and very lethal. Very lethality is very high. But unlike this one, it's caused only third day, fourth day, whereas that one caused in the day 1. So if it consumed in large quantity. And cake is there, that is only dichloride derivative. So that is the usual poison what generally we get, but not much of bleeding occurs. If we give vitamin K and supporting measures, probably that settles by itself.
Thank you, sir. As sir told, there is no licensed production of rat killer powder. Everything is being added. So zinc phosphate, aluminum phosphate, and anticoagulants, yellow phosphorus, etc. So that is why we get nowadays more death. Thank you, sir.
Thank you, sir.
I think if there are no more questions, we end this session. It was really a wonderful session.
So next we invite our next person, Dr. J. Sangumani sir from Madurai, on the topic toxicology, Indian scenarios, do's and don'ts.
I have great pleasure in introducing Dr. Sangumani sir. He is the Dean, Madurai Medical College.
Virudhunagar, sir. Virudhunagar. Previously, Madurai.
Madurai Medical College, Virudhunagar Medical College.
Yes, sir.
At present, Virudhunagar Medical College. Over to you, sir.
Sir, I am the last speaker of the day, but not the least speaker of the day. I am second last. So this topic I took because of the experience as assistant professor, as associate professor, and professor of the medicine in Madurai Medical College for almost 25 or 28 years. So the topic is not going to discuss about the theoretical aspect, especially theoretical aspect of the. It is only practical aspect. That is only I have named it do's and don'ts. Next. So who is toxin, who is antitoxin. So life is full of toxin and antitoxin. You should know what to do, what not to do in the life, otherwise it will be in the trouble. Ultimately, antitoxin only wins in the Punniyin Selvan. So, what to expect? Especially, Parandaman is covered and one of the professors is covered. But my consensus is the what to do and what to do. Most common poison is the OP compound. And then rodenticides already discussed. And then aluminum phosphate also discussed. Paraquat discussed. And a common plant poison and snake bait. Next. So this slide tells that most of the admission now, if you take alcohol intoxication is the commonest poison in the government setup, even in private setup. And then only OPC poisoning. And then only drug overdose. And then phenyl poisoning, zinc phosphate, and then miscellaneous. If you concentrate on alcohol intoxication, even in private setup and government setup, any alcohol intoxication, you should suspect methyl alcohol contamination. That should be your thinking. Or how to differentiate methyl alcohol intoxication and alcohol intoxication is the, you have to calculate the anion gap. Anion gap is the high in the methyl alcohol. Anion gap is the less in the alcohol intoxication. If you take in COVID season, we got so-called rub alcohol. Isopropyl alcohol we used. Isopropyl alcohol is the 70% alcohol only, but it has no side effects. Isopropyl alcohol poisoning also we have encountered in the COVID season. So the first thing is the alcohol. See, in kids, this is the age of clinical medicine. So you have to ask the history. Duration of the exposure, you have to get the history from the patient attender or if the patient is comatose or patient. That is very, very difficult. That is very, very difficult, but that is very, very important. Whether it is an acute exposure or subacute exposure or subchronic or chronic exposure. Because the time lag, like we are telling about thrombolysis, we are starting with thrombolysis in the stroke also. The time duration is very, very important. And the route of exposure is also important. Overall route. What is the main advice is the, you have to ask the clear cut and correct and accurate history from a attender. That is very, very important. So decontamination procedure. So gastric lavage almost we are using for the years together, but definitely it is very useful. And activated charcoal. Activated charcoal is the universal antidote. Even I can tell you, it is a wonderful drug. It is a wonderful antidote of the any, but it is underused. It is a wonderful antidote, but it is underused if you take private setup or government setup. Activated charcoal can detoxify any toxin. And then whole bowel irrigation also. And how to dilute the toxin and the endoscopic removal of the toxin also very, very important. But the gastric lavage to be considered poisoning that cannot be treated effectively with other decontamination, elimination and antidotal therapy. So gastric lavage and activated charcoal is a very, very useful when you know the time duration of the taking poison. It should not be missed. So I want to tell something about activated charcoal. Activated charcoal can be any toxicity. Anticipated, if you don't know, most of the PGs or houses and they are writing unknown poison, unknown poison. That is the common diagnosis in the case sheet because it is very difficult to identify the toxin. So there is no poison called unknown poison. But you have to identify what is the probable poison by the clinical methods also. So when the toxin ingestion occurs within 1 hour of the administration, and activated charcoal administration may be beneficial and administered up to 4 hours after large ingestion of the delayed release drug. So it is a wonderful antidote for most of the toxin. If alert patient, not comatose patient, it is very useful. Ingestion of the toxin without specific antidotes. So this is get dialysis. Whenever any toxin, almost when you are putting the valve in the gastroduodenal junction, it anatomical wall. Activated charcoal deactivate any toxin. So it is a wonderful drug. So you can drink in the single dose therapy and you can drink in the multi-dose therapy. Used in the life-threatening injection of the carbamazepine, dapsone and phenobarbital, quinine and theophylline, it does wonders. So gastric lavage, again we know, it is a very useful method for decontaminating the toxin. So, but during gastric lavage, aspiration should be prevented. Activated charcoal contraindication is the cyanide poisoning, hydrocarbon poisoning, and ethanol poisoning, and metal poisoning, iron, caustic, and unprotected airway, lithium, and camphor and potassium. These are all the poison. You should not use activated charcoal. In alcohol poison, why they are not giving the activated charcoal? Alcohol is very rapidly absorbed in the stomach. So when you give activated charcoal, it is not going to be useful. So another thing, we lack the skin decontamination, especially in OP poisoning. So triple wash with soap and water is always very important. Whatever the type of poison he took in the oral route and thing, the skin decontamination is necessary. We forget to eat always in the ward. If you take a skin also, the areas where the absorption of the toxin mostly occurs the face, scalp and neck and dorsum of the hand. These are all the areas where absorption of the toxin occurs mostly. But normally we wash the face and everything, but we forget about the scalp. But even though it is a very simple thing, it is the major thing for to reduce absorption. And then gastric lavage, and then atropine needs to be started and titrated, especially OPC. This is the mechanism, theoretical. So, number one, skin decontamination, gut decontamination, and oxygen therapy. Early oxygen therapy is definitely going to help everything you will be knowing. But when you are putting the oxygen, you should be cautious. Hypotension can occur with oxygen therapy, so you should be cautious and you should monitor. ஸோ எம்ஜிஆர் ஒரு பாட்டு பாடுவார், கண்ணை நம்பாதே உன்னை ஏமாற்றும் சொல்லி. எப்பயுமே ஆர்கனோபாத் பார்த்தீங்கன்னா நம்ம பீப்புள் டார்ச் அங்கப்பா பீப்புளை பார்த்து பழகிட்டோம். ஸோ மிட்ரியாசிஸ் இஸ் நாட் டெஃபினிட் சைன் ஆஃப் தி அட்ரமினைசேஷன். அதை நம்ம ரொட்டீனாக டார்ச் எடுப்பா, ரவுண்ட்ஸ் போகிறப்பையோ டார்ச் எடுப்பா, பார்க்கணும். ஸோ கண்ணை நம்பாதே அறிவை நீ நம்பு, அதுதான் மிட்ரியாசிஸ். ஆல்வேஸ் நீங்கள் பார்க்கக்கூடாது. வேணா ஏர்லி ரெகக்னிஷன் ஆஃப் தி ரெஸ்பிரேட்டரி லங் சைன்ஸ் மட்டும் பார்க்கணும். Look for twitch and arrhythmia, both indicate severe poisoning. And always in OPC poisoning, you look for VPC and ECG. It denotes the severity also. Seizure also denotes severity of the OPC poisoning. So one important thing about seizure in OPC poisoning is this seizure will not be controlled by the phenytoin. You have to use a diazepam or midazolam or anything. Phenytoin is not going to be useful in the seizure induced by the OPC poisoning. Organopostal poisoning do's attenuation, you have to do drying of the tracheobronchial secretion, and this is very essential to prevent intermediate syndrome. And you have to identify the person. If the patient is having obese person have fat storage, more fat storage. So you know the lipophilic organophosphorus is stays in the store, so they are more prone to intermediate syndrome. So when obese person is coming to you, they are more prone for intermediate syndrome and infusion in the first hour. So aging reaction, you will be knowing what is the aging reaction. So always don't be in atropine earlier. Atropine is not going to kill the patient. So no action for carbamate, that we know. And wait and watch lipophilic obesis. Pentheon or first identify whether it's lipophilic or hydrophilic. And then you have to wait. So newer advances in the OPC poisoning, we are not using hemodialysis, hemoperfusion and hemofiltration and bioscavengers and then brain cell therapy and neuronal regeneration which will act. And some of the mitochondrial drugs also has been tried in the OPC poisoning. So in yellow possible poisoning, the only thing is the lavage and early acetylcysteine. And the only thing I can tell is avoid milk and fatty food. They will increase the absorption of the rodenticide. Aluminum phosphate poisoning. Aluminum phosphate poisoning, as the previously speaker told, it releases phosgene gas. Phosgene gas is a cytotoxic. So release of the phosgene gas will be prevented. So early inotrope support and sodium bicarbonate inhibition and magnesium sulfate therapy. So when it is released, one of the experience I have got is the one lover, both the lover and both male and female admitted in our ward, male side and female. Usually post-admission day we will take runs. In male side, after the aluminum phosphate poisoning, that male survived that female death. The same amount of toxin, they have taken aluminum phosphate tablet. The reason is he is alcoholic. He has put the aluminum pellet, that aluminum pellet in the alcohol, and he waited for half an hour. You know, anybody is taking alcohol, they will wait for alcohol. They will wait for some time. And then 10 minutes, the phosgene gas released. So he survived. Outside. And he survived. But unfortunately, her lover, female side, the death. Next morning, the death occurred. So phosgene gas is very, very important. So you should not give the water and the stomach wash for aluminum phosphate, because again it will release the phosgene gas. Release of the phosphine and increase the toxicity will there inside the stomach. So paraquat poisoning, he has told, Parandaman has told very good instruction for us. And it is the poison which will affect each and every cell of the body because of the red dot system. So each and every cell of the body it is affected. That you should know. And avoid excessive oxygen administration always. But it is contrary to the COVID. He has told COVID and it is a COVID pneumonia like chemical COVID. But excessive oxygen is almost helpful in the COVID. We know we got more experience. And severe myopathy. So it is a cytotoxic toxin. So experimental therapy is the prevent accumulation of the paraquat. He has told cyclopropanol and everything. But corticosteroid is not having very much value. But whatever we don't know, if we don't know. So for example, even in the aluminum phosphate poisoning, in our days, large dose of corticosteroid they have started. Large dose of, for example, hydrocortisone 500 milligram, when you start, it will prevent myocardial toxicity. There was one school of that, but it is not so. So whatever we don't know, we start the steroid, but it is not good. But it is not warranted. And oleander poisoning, so you know the routine, what to do. Electrolyte monitoring is very, very important, and hydration. Any oleander poisoning coming with the hypotension is always bad prognosis. That is very, very important. You should tell your house surgeon or PG to take care of that case. And then digoxin antibody, now it is available, and potassium. When it is hyperkalemia is very common, you have to treat the hyperkalemia also. But digoxin specific antibody is doing wonders in the oleander poisoning. That is also we are not using. And then low dose atropine. What the don'ts in the oleander poisoning? Low dose atropine can paradoxically cause bradycardia by slowing the STA node via the central vagus action. This point everybody will be knowing. Ranitidine should be avoided in the case of oleander seed poisoning because it can result in bradycardia. PPAs are preferred. And snake bite. So snake bite again, it is a problem. You should identify the snake, whether it is a common cobra, which is neurotoxic. Cobra is a post-synaptic and a toxin of the common crate is the pre-synaptic. Russell viper is the worst. It is a chemotoxic, vasculotoxic, nephrotoxic. When I am telling vasculotoxic, it is going to affect the capillaries. You should mind that it is going to affect the capillaries and a sauce-scaled viper. So what are the don'ts and don'ts? So when to release the tourniquet? If already tourniquet should not be put, already put, preferably after ASV infusion. Release while keeping the limb on the level of the body. That is very important. So even though it is a very simple point, it is also plays role in reducing the toxicity. So in AHV can be given in pregnancy. That is very, very important. Another important thing I want to tell is the AHV indication. Antibiotics is not going to useful. Cellulitis is going to, and then bleeding manifestation, neurotoxic signs, shock. You have to monitor. You have to monitor. So administration of the AHV, normally what we are doing is the amount of toxin. Usually I will tell in my rounds, the amount of venom injected in the person, only snake only knowing. We are not knowing that what type of force, what amount of venom. So better over treat than the under treat the patient if you want to really save the patient. So again, lifting the limb and lowering limb, they both should not be done. So tourniquet should not be there and the limb elevation done by AS administration. So this incision section, ice pack, drill per wall, staying awake overnight, these are the myths in toxicology that we should not do it. And there is no AAC should not be given locally. That is very, very important. And then AM, like we are normally we give Rabipur locally, but you should not give IM or SC injection locally in the injection site. So how to approach the snake bed? This is the protocol. How to approach the snake bed? You should identify the snake and you should identify what is available. What is, whether it is a neurotoxic, whether it is a combined toxic, whether it is a non-toxic. That is also very, very important. Somebody will, even non-toxic snake bite, with fear they will going for the cardiac arrest. So clotting time is the very good, very simple bedside test. But what is very important is it remains negative in patients with evolving venom-induced DAC. So whether it is a directly venom-induced problem or DAC problem, you should identify. Patient is retested every hour for the first 3 hours and then 6 hourly for 24 hours until either test result is not clotted. Clinical evidence of the examination to ascertain if dose of AAC is indicated. That differentiate in bedside you should know. So, this is a very simple test. There is a grading of the clot is also there. So, when there is a big problem, stop AHO temporarily, oxygen, and you can give adrenaline also. Some of the centers, they are using adrenaline drip also. So, this is a corrosive poisoning. What to do, what not to do. What not to do is the gastric lavage, emesis, neutralization, activated charcoal, carbonated drinks. So, approach to unknown poisoning is a very good, you can go inside tachycardia, bradycardia, and hypothermia, hyperthermia, hypotension. By that, you can handle which toxin. A big list is there. With the clinical signs, always clinical sign is like a good friend. Clinical medicine is always very important. So, looking for clinical signs will win you, but mind it, even though it is a close friend, it can cheat you. So, this is a list. So, this is a common toxic rooms available. So, the established toxicology unit involving all the specialties, definitely when it is there, definitely it is going to helpful to you. So, prevention, evolution, treatment, and monitoring of the injury illness from exposure to drugs and chemicals is very important. This is the component of the resistant disease. What is the take-home message? As I told you, over treatment always better than under treatment. This is my experience. So yes, we even I can tell as an assistant professor when I was working with my chief, even I can give giving even 80 vials of ASV we have given. Whether it is, and then audit also came, everything came. But we have patient surveyed. Patient surveyed. That I can tell. Always look for delayed symptom in every poisoning. So now you have to like hair dye poisoning, paraffin diamine, like yellow phosphorus poisoning, red color paste. Always look for discharge அவசரப்படவே கூடாது. For 6 days, 7 days, you look for the conjunctiva, whether it is having jaundice or whether it's high colored urine or not. So then beware of comorbidities. That is the thing again lacking. Admitted patient nowadays, diabetes is very common in young age group. Even CAD is young age group. The patient will not die out of the CAD. The patient will not die of toxin, but he will die of the CAD or anything. So beware of the comorbidities. That is very, very important thing. And then activated charcoal use should be enhanced. Always, this is intensive monitoring never means intensive medicine. It is a intensive monitoring is the best antidote you can do in the toxicology unit. More than medicine, intensive monitoring is going to help. When you give atropine, even when you give PTM, intensive monitoring is very, very important. When you are not monitored, you are the loser. Thank you.
Thank you, sir. The topic is open for discussion.
It's a wonderful presentation, sir. It's a great presentation. We have learned a lot from this presentation. One point what I learned is that whenever you take an alcohol, you dilute and take. The reason I thought the concentrate they cannot swallow, it might burn. That is not the reason. Alcohol in 20% is better absorbed than the higher concentration. That was I learned from the literature. Now, if you take any person who take poison with alcohol, the more toxic absorption is increased by alcohol. Whereas in contrary, that is this aluminum phosphate poisoning, where because anything water it comes to, it releases a phosphine. If you wait for some time, the phosphine goes up, he escaped. So it's a wonderful take-home message for me, sir. Thank you very much. And a lot of other lot of other points to learn. So it's really a great presentation. Thank you.
So all PGs are here. You can refer Dr. Parandaman's book. He has written a wonderful book in toxicology. You can refer the very good work he has done. I have to compliment Dr. Parandaman also for the book. Sir, you can suggest the government for banning this red killer. When we are talking about red killer paste, banning the red killer paste, it's a simple solution you can do. Thank you, sir.
Really, thank you, sir, for making us to recognize Aishwarya Rai or Trisha is the heroine or anti-heroine. Thank you, sir.
Thank you,
Go to the
sir.
next presentation.
Thank you, sir. Now it's time for the felicitation. I now request Dr. N.S. Prasad, sir, to felicitate Dr. G. Ratnakumar, sir. I request Dr. Saravanan, sir, to felicitate Professor P. Parandaman, sir. I request you to kindly come on to the stage. I request Dr. N.S. Prasad, sir, and Dr. Saravanan, sir, to felicitate Dr. J. Sangamani, sir. I request Dr. Sangamani, sir, to felicitate Dr. N.S. Prasad, sir, and Dr. Saravanan, sir, for chairing the session.
I request the chairpersons to stay on the dais. I request the chairpersons to stay on the dais for the final session. The final topic of the day is ventilatory management in respiratory failure, what a physician needs to know, by Dr. Sriram Ganesh from Tanjavur.
It's my pleasure to introduce Dr. Sriram Ganesh. He's a critical care physician and diabetologist and working as assistant professor internal medicine, Tanjavur Medical College, and is presented various papers in national index journals as research scholar in UG and PG curriculum. Aspiring UG PG teacher over 10 years. Over to you, Dr. Sriram Ganesh. Please take over the session.
Yeah, thanks a lot for the nice introduction, sir. Actually, my previous speaker, Professor Sangamani sir, spoke like it was the last topic, but it wasn't. My topic was placed in the previous position. So I thought I'll speak at the last because you know why? So everyone spoke nicely. Professor Parandaman sir, Professor Ratnakumar sir, Professor Sangamani sir. So I'm really privileged because I'm from Tanjavur Medical College and the Dean of Tanjavur Medical College is a physician. My teachers, I'm very proud to, speak before my teachers, Dr. Ratnakumar sir, Dr. Paul Raj sir. So I'm extremely thankful to the organizing committee at this juncture for giving me this opportunity. You know why I'm speaking as a last? Because most of the poisons, it might be a OPC or paraquat, people are speaking everything. So they land up in multi-organ dysfunction, ARDS lung, and ultimately your respiratory failure or your cardiac arrest. So I thought I'll speak as the last one. Yes, so today I'm going to speak what a physician need to know as mechanical ventilation. Yes, thank you for introduction, Saranan sir. So your best teacher is your last mistake. It's not good morning, of course, it's good evening. So that doesn't mean that you should not become a good teacher by doing many mistakes. Of course, you should learn by mistakes. Yeah, your life is not measured by the number of breaths we take, by the moments that take our breath away. So every breath is important, isn't it? So you have to give utmost importance to every single breath of the patient. You have to address all those issues. So this is the scenario. Most of the times we are meeting all the poison. The professors have spoken about the poisoning. So we are meeting in the situation, trying to intubate, succeeding if not. And then finally you are managing with amber bag ventilation. So the final step would be, this is the thing. So either you are connecting to the ventilator as non-invasive ventilator with a mask on the face or as invasive ventilation. So this is what we are going to see today. Yes, the lungs, the management, the graphics in a simpler form. That's the gist of my talk. I don't want to waste my So the indications, as you all know, specifically, it is acute respiratory failure. For that purpose, we are giving mechanical ventilation, and the causes being on the top is your ARDS lung. Because all the poisonings, paraquat or OPC, this COVID pneumonia, so everything is landing up in ARDS lung. So you have to address that ARDS lung meticulously. And the next comes in your ICU indication for acute respiratory failure is your cardiac failure, congestive cardiac failure. In ARDS, most of the times they need invasive ventilation. Whereas in heart failure, you can manage with NIV, that is your CPAP or BiPAP. So the indication specifically speaking, if the PaO2 is less than 55 or if the PaCO2 is more than 60, despite your 100% hyperbaric oxygen therapy, obviously you're going to manage mechanically ventilation. And then deteriorating respiratory status in spite of your treatments, patient is anxious, sweaty, lethargic, deteriorating mental conditions. In that situation, you warrant invasive ventilation, and again respiratory fatigability. So all these are specific indications. So what is exactly a mechanical ventilation? It's nothing but assisting a method to mechanically assist or replace a spontaneous breathing. In those days, to start with, they started with negative pressure ventilation. It's like sucking of air into the lungs. And then nowadays it has been transformed into positive pressure ventilation, which is we are going to see in the subsequent minutes of my talk. This is basically the difference between your negative pressure ventilation and your positive pressure ventilation. Your negative pressure ventilation is your spontaneous breathing, right? So it's a normal respiratory cycle of a spontaneous breath. It's the intrapleural pressure is becoming more and more negative once you suck in the air. So during inspiration, it is forced by the inspiratory muscles due to the increased intrapleural pressure. Thereby, the air is sucked into the lungs. So this is the normal spontaneous breathing, which is called negative pressure ventilation, which is the first one to start. In big iron carousels, they'll keep, that's the first mode of ventilation they started. And now it is becoming into positive pressure ventilation. It is nothing but opposite, exactly opposite to that of your spontaneous breathing. So the ventilator generates a positive pressure in airways to drive the air into the lungs. So initially it drives into your, if it is a non-invasive ventilator, it's going to drive into your upper airway, and if it is an invasive ventilation, it's going to drive into your tracheal tree directly. So that is the thing you're going to do. Yes, so either you'll be connecting the patient either as an invasive ventilator or as non-invasive ventilator in terms of positive pressure ventilation. So NIV, when compared to NIV, so NIV, that is non-invasive positive pressure ventilation, most of the times I would say any acute breathlessness, if you see a case in ICU, the first one you have to do is you keep a NIV and connect to the mechanical ventilator, and you observe for if there is any synchrony between the machine and the patient. So always you have to see the synchrony between the machine and the patient. So in acute exacerbations, especially, if you keep NIV, that shows good amount of improvement in ABG. It reduces the in-hospital mortality. So I would advise always keep NIV. Yes, so what happens if you keep NIV initially? Whatever the cause of respiratory failure, before NIV, the alveolus are collapsed. After study, they observed that after NIV, all these alveolar basal segments especially, they've been recruited. So that is the main advantage of keeping NIV. You can assess in a matter of 20 to 30 minutes if the patient is tolerating the NIV, if the oxygen status is improved. If not, you have to proceed to the invasive ventilation. Yeah, what is our purpose? Yeah, to maintain or improve the ventilation and again the tissue oxygenation. So ventilatory defects, most of the times they have raised PaCO2, whereas your oxygenation defects, they have decrease in PaO2. So these are the two situations wherein you need to, combat the situations to decrease the work of breathing again and to improve the patient's comfort. This is the criterion. Again, most of the times the patient will be landing up in tachypnea. So more than 35, the respiratory rate, the tidal volume and vital capacity reduced in values of 5 and 15 respectively. And your maximum inspiratory force is again too much reduced. So these are the main pulmonary function studies based on which we are going to connect to the mechanical ventilator. And what does the ABG say? If most of the respiratory failure, they land up in respiratory acidosis. So at that juncture, you have to give, based upon the ABG less than 7.25, and your PaO2, as I said previously, in hypoxic respiratory failure type 1, always the PaO2 is less than 16, and your PaCO2 more than 50 in type 2 hypercarbic respiratory failure. So based on this, criterions, you have to connect to the mechanical ventilation. And again, what are the two types? I don't want to repeat much. Yeah, I would like to speak about this slide because this is taken from Harrison. There are 4 types of respiratory failure. Type 1, as I said, it is hypoxemic respiratory failure, wherein the PaO2 is less than 16, and type 2 hypercapnic respiratory failure in most of the cases of your neuromuscular disorders, in OPC poisoning, in opioid poisoning. So in all these scenarios, you land up in type 2 respiratory failure with hypercarbia. And type 3 is your perioperative respiratory failure. So in this particular scenario, after any upper abdomen surgery, they are going to land up in acute respiratory failure. So if you give, or even if the patient goes up in hypotension, so they'll go for respiratory muscle fatigability. So that forms the type 3 and type 4. In that scenario, simply you keep the NIV for the patient for a couple of days. So that way you can make the patient off from the ventilator as well as from the ICU. The outcome is going to good. Yeah, this is exactly the indications. You need to concentrate on this. It will be looking cumbersome, but I'll tell you what is that. So we are seeing the indications of mechanical ventilation. That's it. So number 1, failure to ventilate in most of the neurological conditions, your respiratory center depression due to opioid poisoning or whatever the indications, and especially in cervical cord injuries, going for quadriplegia, in phrenic nerve palsies, in neuromuscular junction disorders, especially myasthenia, in muscular myopathy, any sort of myopathy, muscular dystrophies. So these things are neurological and myopathy, and failure to maintain the airway. So upper airway obstructions and all your, these are the indications in chest wall, in pleural cavity, massive pneumothorax, massive pleural effusion, in abdominal compression. Imagine you cannot see any respiratory illness, but the patient will be coming with dyspnea. The reason behind is massive ascites. So in that particular scenario also, you have to keep the NIV ventilation. So the main thing is your failure to oxygenation, your diffusion abnormality, your pulmonary embolism. See, you have to calculate the ventilation perfusion ratio. That is V by Q. It's normally equal. That's 1. So if it is more than 1, then you have to deal with the cases of, mostly your pulmonary embolism. So ventilation more than perfusion, obviously the defect in the embolism, and ventilation less than the perfusion, the defect is in the consolidation lung or in pneumonia. So these are things. In the bottom slides, again the repetition, I don't want to repeat, you can sleep. So these are the indications. So how you are going to obtain the respiratory failure? Either you are giving total mechanical ventilator support or you are only partially supporting the patient. Yeah, what is a mechanical ventilator? It's a machine that generates a controlled flow of gas into a patient's airways. So what are the types of ventilators? Your transport, your ICU, neonatal, and your positive pressure ventilators. This is the components. airway, patient's ventilatory circuit, your power source. So ventilatory circuit and the breathing, a breathing system with a single water trap, double water trap. I would like to concentrate on HME filter. This HME filter, you have to change for each and every patient because it is the one thing which prevents what is the most common complication of invasive ventilation? Any postgraduates? Spreading of infection directly into the lungs. Yeah. So most of the times you should not keep invasive ventilator. See to that your oxygenation status is maintained with the NIV. If not, if it is really warranted, and if you need invasive ventilator, always connect to a HME filter. It filters all the microbial organisms. So now comes the main thing. It's very simple. You can easily understand. So this is the respiratory flow. Most of the times the physicians will, skip away from the flow patterns, but I'll make it simplified. So this is the initiation of the breath. So a trigger A at the end of the curve, it's inspiration. From A to C, it is inspiration. Okay. So trigger is what initiates a breath. Either if the patient is breathing, patient is going to trigger. If the patient is not at all breathing, the machine is going to trigger, right? Okay. So A is the trigger and B is what it controls or limits the inspiration. So limitation of the inspiration, it should not prolong, isn't it? Right. Then C is what? End of a breath. It is nothing but your cycling. Cycling is the end of a breath. So this is the inspiration, it's going to happen. This is the flow pattern, whatever ventilator you are going to connect. So A triggering, B limiting the inspiration, and C your cycling of the inspiration. So what is the limit? It should be pressure limited or volume limited. For example, if it is a volume control ventilation, your tidal volume is going to limit the breath. And if the pressure control ventilation you are connecting, your pressure what you have set is going to limit the breath. So this is what basic things. And the next one is how it is going to apply in this graph. See at the bottom line, it is a controlled or mandatory machine triggered and machine cycled. Yeah. So see, the machine is triggering. The patient is not showing any efforts. The machine is triggering and then it is limiting and then it is cycling. Cycling is nothing but end of the breath. So totally machine dependent. That is controlled ventilation. What is assist control ventilation? The patient triggers. See at the bottom line, the patient triggers, but the effort is not adequate, isn't it? So automatically the machine takes over and then it limits and cycles the breath. That is assist control ventilation. And the last one is your spontaneous. Most of the times in acute respiratory failure, the patient is breathing. So there will be tachypnea. So this is the last one you are going to address. You both triggering and cycling by the patient, but see to that you always have to select a pressure control ventilation in that scenarios. That will tell you later. I don't want to repeat all those things. So basically, pressure cycle ventilator, your volume cycle ventilator, and time cycled. So pressure cycled is you are setting a preset pressure, right? It's an inspiratory pressure. And volume cycled is you are setting the tidal volume. And time cycled is up to one particular time you are going to limit the inspiration. What is the normal IE ratio? It is 1:2. So that's what you are going to set. After a period of 3 seconds, each cycle is going to limit. Right? So this time cycle ventilator is most commonly useful in pediatric populations, right? In pressure cycle and volume cycle, we are using in adult communities. Yeah. So volume cycle, as I said, preset tidal volume. The other one is alterable. Pressure cycle, preset inspiratory pressure, airway pressure. For example, we can keep up to 15 centimeters of water. And time cycle is in pediatric usage. So this is what we are going to observe. The mechanical ventilator breaths and pulls up. As I said previously, the ventilator does all the work in controlled breath. And in assisted breath, the ventilator takes over the work. And in supported breath, the ventilator assists us to finish the work, that is pressure support. Remember, pressure support ventilation, that is PSV, that one mode which helps the patient to wean off from the ventilator. So you cannot just like that connect to the ventilator and go away. See to that, you have to select a mode in which the weaning is very easily feasible. These are the basic modes. I don't want to repeat. Yeah, so there is two modes, your open loop method and closed loop method. In open loop method, that I previously said, machine does everything. See, patient has to adapt to the ventilator. There is no connection between the patient and the machine. So always if you connect a ventilator, there should be an interaction between the patient and machine. And you are the anesthetist or the critical care physician or even now a physician, internal medicine specialist or a student, PG student has to read what is the interaction between the machine and the patient, right? So in this particular modes, control mode of ventilation, there is no interaction between the patient and the ventilator. The patient has to adapt to the ventilator, just like that. What happens to the advanced modes like closed loop? There, the ventilator adapts to the patient according to the breaths. Thereby, it delivers the breaths. The modes being your adaptive support ventilation, your proportional assist ventilation according to the patient's ventilation, and NAVA is your neurally assisted according to the diaphragmatic contractions. So you select these modes. ASV, your pressure support ventilation, adaptive support ventilation, proportional assist ventilation. NAVA, it's not available in all the ventilators. Yeah, so what is the advantage of one over the other? Always, as I said, your PSV, the pressure support ventilation patient is very much comfortable. Improved patient ventilator interaction, good amount of interaction, thereby the ventilator reads the patient and delivers accordingly. Right? There is no dysynchrony. There should not be any dysynchrony within a matter of 15 to 20 minutes. So then only you can improve the oxygenation status, isn't it? Yes. So always this volume control, pressure control is not a matter. You see to that, you connect the patient to the pressure support ventilation. This is the ventilator settings. Your respiratory rate, I'm sorry for the slide. Your respiratory rate, your tidal volume, your FiO2, these are the variables you're going to set. And you can choose, as I said, always choose NIV, positive pressure ventilation, pressure versus volume depending upon the condition. Most of the patients will suit pressure support ventilation. So always select pressure support ventilation, even if it's a cardiac failure or a respiratory failure. And you decide whether you're going to give partial or full support. Yes, the number one variable is your tidal volume. So this is very important. So normal tidal volume, remember 10 ml per kg, that is the normal tidal volume. So why we are going to give low tidal volume? The low tidal volume is always in ARDS. You have to give 6 to 8 ml per kg. Whereas in post-operative patients, you need to give higher amount of tidal volume. What about the respiratory rate? The respiratory rate has to be combined with the tidal volume. As you all know, it's the outcome of your minute ventilation. So your respiratory rate is always between 12 to 18. Your higher rates is useful in pediatric communities, okay, and in ARDS. But nowadays, in ARDS protocol, evidence says, as far as UK protocol, they says never exceed respiratory rate more than 30 in ARDS, right? So always keep the respiratory rate less than 30 in your ARDS patients. And FiO2, start with the higher one and down titrates. IE ratio, excuse me. So IU ratio, you have to keep always 1:2. There is no concept of inverse ratio ventilation, no 1:1, always 1:2, right? So in what conditions you can extend the expiratory time? Obviously, in COPD, in any expiratory airway obstruction, you have to keep 1:3 or 1:4 to avoid air trapping, right? Then what is about PEEP? This PEEP is going to be, it acts like a CPAP, it's like a PEEP. At the end of expiration, you're going to recruit or open the alveoli in case of all collapsed alveoli. So higher the PEEP, higher the outcome. So you have to keep at least 50% FiO2 is an oxygen concentration, 50% of oxygen and 8 PEEP to start with, right? The main drawback is the PEEP reduces the venous return as well as the blood pressure. So see to that, you have to be cautious in low BP patients. So this is the PIP, the inspiratory pressure. As I said, you have to keep between 12 to 15. Remember the values, 12 to 15. So higher PEEP obviously required in severe lung disorders. Gas flow, the normal flow is 60 liters per minute. Next. Yeah. So this is the initiation of mechanical ventilation. The flows are set to meet the patient's inspiratory demand. So if the patient warrants, as I tell post-operatively, in post-operative they need high gas flow rate. That is the one indication of high gas flow rate. So this is the initial settings, finally, a full nutshell. So FiO2, start with the higher one and de-escalate. PEEP, as I said, 5 to 7 or 8 even. So tidal volume in COPD and your ARDS, low tidal volume. Otherwise, you can keep 10 ml per kg. Your PAP 15 to 20 centimeters of water. Your respiratory 10 to 15. IE ratio 1:2. So if we keep all these settings, you can avoid the ventilator dysynchrony, right? All these flow patterns. So this is the ultimate indications for your ventilator support. As I said previously, I don't want to repeat. Yeah. Now we are going to see the 2 case scenarios. Only 2 case scenarios I'm going to deal with today. ARDS and COPD. So ARDS is the most common situation. So what we are going to set. So let's see. So it's a definition based on ABG or Berlin's criteria. FiO2 by PaO2 ratio less than 300 is ALI. FiO2 by PaO2 ratio less than 200 is ARDS. And if it is less than 100, severe ARDS, right? Okay. The most common cause, your pneumonia and aspiration lung disorders for ARDS. This is the normal alveoli in the upper part. The black is normal alveoli, and the next one is injured alveoli, ALI, and the last one is damaged alveoli. You are going to rescue the injured alveoli. You know why? Because they potentially participate in gas exchange. So it is susceptible to opening and closing. So you cannot do any benefit to the already damaged alveoli. In ARDS, you are going to improve the injured alveoli. How? As I previously mentioned, low tidal volume, and high FiO2. So this is based upon the guidelines definitions of mild, moderate, severe ARDS. I don't want to deal with this. Yeah, the pathology, what is the pathology? Impaired, see the yellow lines. So, sir, shall I take a couple of minutes, madam? It's a lengthy discussion, right? If you permit, another 2 to 3 minutes. Yes. So the important pathophysiology for ARDS is your impaired gas exchange, ventilator perfusion mismatch. Your hallmark of ARDS is decreased compliance because it is otherly termed as your stiff lung. And the third one is increased pulmonary artery pressure. You're going to address this stiff lung, right? Yeah. So you are going to correct the hypoxemia by keeping high FiO2 and high PEEP, increase work of breathing. You are going to address all these issues, ultimately low tidal volume. So low tidal volume, higher PEEP. That is the two messages, and conservative fluid management in ARDS, right? So this is the evidence. Yeah. So the respiratory rate, again, you can keep according to the minute ventilation and your tidal volume. You can adjust accordingly. PEEP, as I said, you have to keep higher PEEP, 8 to 10. See to that the BP is not falling. Yes, these are all the evidences. Higher PEEP, better clinical outcomes, and JAMA and NEGM evidences. So airway pressure, this is very important. This slide is very important. The plateau pressure, okay. So see to that in all ventilators, you can see a plateau pressure. It shows that 30 centimeters of water. So never exceed 30 centimeters of water of plateau pressure to avoid the barotrauma. Accordingly, you have to set the PIP, that is the peak inspiratory pressure. The only exception is the more than 30 plateau pressure required in conditions of your morbid obesity, pregnancy, ascites, and your obstructive sleep apneas. These are the evidence prone. Again, prone ventilation is going to do real benefit in case of severe ARDS. So they advise early proning and early neuromuscular blockage. Avoid HFOV in ARDS. It's going to be detrimental. So supportive measures, I don't want to discuss much on these. Steroids, never use steroids. If at all you want to use, even at the early stage of ARDS, not at the late stages. And this is the pathology given in Harrison. So fluid, decreased diuresis, you have to give diuresis at the middle or late stage of ARDS. So fluid restriction, conservative fluid management. This is the initial ventilator settings, right? So we are at the end. So normal lungs, 8 ml per kg, respiratory 10 to 12, IA ratio 1:2. Your PEEP 4, FiO2 100% and de-escalate. In asthma and COPD, lower tidal volume and lower respiratory rate. That is very important. Never hyperventilate in asthma or COPD because you're going to land up in air trapping, right? And IA ratio, as I said, you can keep 1:3 or 1:4. You are prolonging the expiration for all the alveolus as to, empty because it lands up in air trapping and barotrauma. In ARDS, as we discussed previously, this is the settings. In hypovolemia, again, lesser PEEP because in fear of your hypotension. So this is the initial alarm backup. And what are the complications of mechanical ventilation? As I said, pneumonia, VAP, and your villi. What is villi? It's a short notes for postgraduates. So ventilator-induced lung injury, your volutrauma, your atelar trauma, that is collapsed alveoli, your biotrauma due to the chemical release of inflammatory mediators, your barotrauma. So today you're going to deal about the barotrauma. See to that you reduce the pressure. Okay, if you keep a high pressure, you're going to produce barotrauma. So reduce the peak inspiratory pressure in pressure support ventilation to reduce the barotrauma. Volutrauma, reduce the tidal volume. These are the two messages you can take away from me. Yeah, the predisposing factors in barotrauma, your ARDS, so never keep high pressures, right? So see to that you are keeping at least maximally 20 centimeters of water. Volutrauma, excessive stretch in the absence of excessive airway pressure. These two things has to be avoided. And this is the thing we are going to keep, that is called lung protective strategy, right? So you have to keep low tidal volume, your plateau pressure is less than 30, your high PEEP. So these three things, if you keep and set in the ventilator, you are going to avoid dysynchrony and any breath stacking. So this is the lung protective strategy. And imagine never thinking of parking in the volutrauma area and airtalated area. So always park your ventilator in the safe window. It is like, your plateau pressure is less than 30, your PEEP is slightly going to be higher and tidal volume is going to be lower. That is a safe parking of your ventilator whenever you see any case of ARDS or acute respiratory failure. These are the futuristic goals. Yeah, ECMO for ARDS, permissive hypercapnia. So I was telling about ASV. This is very important. In modern ventilators, you have got ASV, adaptive support ventilation. It adapts to the patient. It recognizes the patient's real condition, thereby it supports the ventilation. It gives minimal tidal volume and it reduces the respiratory. That is adaptive support ventilation, and it is available in all the Hamilton ventilators. And the next one is neurally adjusted. according to the diaphragmatic contractions, the electrodes are placed in the diaphragm, and according to the contractions, they are going to give the stimulus. Thereby, it is highly sensitive, neurally adjusted ventilatory assistance. Okay, these two are really reading the patients and help in weaning of the patients, right? So finally, in any settings, if the SpO2 is very low, you increase the FiO2, increase the PEEP, and increase the inspiratory time, right? So these are the things to increase the oxygenation. For example, if you are seeing type 2 respiratory failure, that is progressive respiratory acidosis, in that case, you increase the respiratory rate and see to that the tidal volume is maximally up to 10 ml per kg. So these are the main alterations or troubleshooting you are going to do in type 1 and type 2 respiratory failure. Yeah, we are doing in COVID pneumonia, LCATs and HCATs. HCATs is high lung elastance and low compliance in COVID pneumonia, which is like ARDS lung. So COVID pneumonia is HCATs, and you're going to deal like ARDS lung. Yeah, so how you're going to wean, sir? I'll take another 1 minute, sir. I'm going to finish. So how you're going to wean from mechanical ventilation? So you cannot just like connect the ventilator and go away. You have to see how we can wean off from the ventilator. The determinants are of course ABGs. The next one is important is your PaO2 by FiO2 ratio, again a biochemical value, and your minute ventilation less than 10 liters per minute. So all these biochemical parameters have to be considered while weaning off from the ventilator. Before that, yeah. So see to that you are following a clear-cut protocol, and never try weaning at night. Basic tips for weaning: never try weaning at night. If once weaning is failed because the patient will be highly fatigable, sweating and dyspneic, never attempt weaning for another couple of days, right? So you slowly wean off the patient on the ventilator. So these are the basic steps to wean off. You can straight away go into the CPAP or your TPS trial to wean off from the ventilator. So weaning off, if you select a CPAP trial, so set CPAP 5 centimeters of water and 50% of FiO2. Suppose if the patient is ventilating with 5 centimeters of water and less than 50% of FiO2, you can easily wean off the patient, right? So this is your ventilator support is not complete, but for your nursing care. So assess patient first, then the ventilator. Whenever there is alarm is coming, never advise the staff nurse to switch off the alarm, right? You ask the staff nurse to see the patient and then you treat the ventilator. That is the information. Again, hand hygiene, eye and mouth care. A few points about NIV, CPAP and BiPAP. So CPAP and BiPAP, that is CPAP is continuous positive airway pressure and BiPAP is your bi-level. In inspiration, IPAP, inspiratory positive airway pressure, EPAP is expiratory. You're going to keep 10 to 15 centimeters of pressure in IPAP, inspiration. And in expiration, you're going to keep 5 centimeters of pressure. So the difference should be at least 10. So CPAP and BiPAP are indicated in your COPD, your morbid obesity, and your congestive heart failure. So any respiratory failure, as I previously mentioned, you start NIV with this CPAP or BiPAP, whatever modality available in your center. Yeah, so this might be looking cumbersome. I'm not going to deal with it. Yeah, so this is CPAP and IPAP. So what is the basic difference? Constant set pressure during inhalation and pressure is relieved during exhalation. So continuous through both the phases of inspiration and expiration, you're going to give continuous pressure. Whereas in BiPAP, you're going to give a constant inspiratory pressure and you're going to, ultimately what you're going to do, you're going to recruit the alveoli, open up the alveoli and prevent atelectasis and thereby improve the oxygenation of the patient. That's the machines we are giving. Yeah, so the ventilation, COPD and asthma, even though the pathogenesis differ, their management is similar in many aspects. As I said, you keep IPAP, for example, 10 to 15 centimeters of water and EPAP 5 to 8 if you deal a case of COPD or asthma in NIV. If you are giving invasive ventilation, never try invasive ventilation in COPD asthma because you're going to land up in deep troubles, right? So always give NIV in case of COPD or asthma, and your expiratory IE ratio, as I previously mentioned, should be between 1:3 or 1:4 for the escalation of the airway limitation of your obstructions. Yeah, so what is the ventilator strategy in COPD? The primary goal is to increase the PaO2 more than 60, or the SaO2 more than 90%, your tidal volume 8 to 10. This is for invasive ventilation, right? Your minute ventilation 115, long expiratory times. As I said, IE ratio should be 1:3 or 1:4, and lower respiratory rate. Never keep higher respiratory rate in case of airflow limitations, COPD or asthma. And volume control ventilation is more versatile than pressure control. So I would say finally, you can keep pressure control ventilation in ARDS, in congestive heart failure, in other conditions of, your volume overloaded lung. Whereas in COPD and asthma, you can select the volume control ventilation, right? You can limit the volume, you can limit the respiratory rate, you can avoid air trapping. That is the final information from my side. Yeah, ultimately you're going to successfully connect the NIV to the patient. Simply he can read and, connect the mechanical ventilator if there is good amount of interaction between the patient and the ventilator. So what is the selected etiology? This is the last but previous slides. So most of the times we are landing up in respiratory acidosis. So the reasons behind airway obstruction, your upper and lower COPD asthma, your CNS depression, your sleep disordered breathing, your neuromuscular impairment, your ventilator restrictions, your hypercarbic conditions, shivering, rigors, these sort of things has to be addressed. Simply correcting the ABG might not help. So these things have to be addressed before you wean off the patient on the ventilator. So this is what you are going to do. Always create awareness among all the, medical personals. So ultimately with mannequins, so every time you have to read about NIV and invasive ventilation. Finally, we are intubated and rescued the patient. So we have to pray for a healthy lung. So just breathe. You are strong enough to handle your challenges, wise enough to find solution for your problems, whatever it is, and capable enough to do whatever needs to be done. I want to inspire people. I want to inspire people. I want someone to look at me and say, because of you, I don't give up. It be the statement of your patience, right? So life is short, so smile while still you have teeth. Laughing is also good for your respiratory system. There is only one rule for being a good talker: learn to listen. I always love learning to listening to all my professors and senior laurels over here. The good physician treats the disease. The great physician treats the patient who has the disease. So always let's all be a good physician. And thank you for the wonderful opportunity. Thank you for the patient enough. Thank you for the chairperson. Thanks a lot. And this article of mine have been published. I'm sorry. Can you please publish? Yeah. So this article of disease-specific ventilation strategies and evidences have been published in 2021 Medicine Update APA textbook for sort of postgraduates. And thank you for the opportunity. This is what we do in and out. I have rescued a baby of ARDS. Thanks a lot.
Thank you, Dr. Sriram, for an excellent lecture. As suggested in the topic, you have really given the gist of what is required for the physicians in a very, very understandable and palatable way. Now the forum is open for any questions.
I think everyone is deeply comatose.
I think if there are no more questions, we'll just.
Thank you, sir.
Postgraduates, any questions you can ask. I think I have hyper loaded, I think, isn't it, sir? But still, it's very important, sir. All these slides are very important.
Any questions? So thank you so much. Now I request Dr. N.S. Prasad sir and Saravanan sir to felicitate Dr. Sriram Ganesh sir from Tanjavur. Let's give a big round of applause. Thank you, sir. Thank you so much, sir, for chairing the session. That brings us the end of today's scientific session. This will be followed by the inaugural function at Hall A. We invite you all to this function. Thank you. See you all there.